of this wonderful meeting. At the onset, I would like to call on the moderator, Dr. Rajesh Fogla sir, Dr. Beatrice, Dr. Francois, Mark, Dr. Amrita Anjani, and Dr. Samresh Srivastava. This session is going to be about, I think this is one of the most important session. Shiham, if you can put it on the group, that this is a practical session of Deoss, the most practical you have. You're talking about the plugs, you're talking about the concept of customized lubrication. So if you can write there that, this is going to start and we should have enough time for the discussion at the end of the session.
Good morning, everyone. We start with the topic on punctal plugs, why, when, and what to avoid. No financial interest to disclose. In the definition of dry eye, we know it's a multifactorial disease of tears and the ocular surface, resulting in discomfort and visual disturbance. There is associated inflammation of the ocular surface, tear film hyperosmolarity. It's a chronic and progressive disease that continues to worsen over time. In terms of tear film dynamics, it's a balance between aqueous production versus tear drainage. The normal drainage occurs via the upper and lower punctum. And the principle of occlusion aims to preserve the existing tears. So what's the rationale for punctal occlusion? Well, you try to increase the tear retention time, resulting in tear film stability, and has the efficacy of topical therapy and reduce the need for frequent artificial tears. Now, where does it fit in the treatment algorithm? If you look at the Deoss 3 guidelines, we find that it's not in the initial stage of management of dry eye. It's only when you have a failure of using lubricants and the common environmental modification, and you also use it when the surface inflammation is controlled. So even if you look at the start of thinking of punctal occlusion, always when there is some ocular surface abnormality in terms of irregularity, staining, or deficiency of aqueous, that is when you think about moving to punctal occlusion. Ideal candidate, yes, it is beneficial in aqueous deficient dry eye when you have a deficiency of aqueous tears, like in Sjogren's syndrome. We also use it for post-refractive surgery in the early period. And also for contact lens intolerance when there is difficulty in wearing contact lens comfortably, and especially if their eye is associated with neurotrophy, where there's a decrease in the tear production because there's not enough corneal sensation sending signals to the tear gland to produce tears. The contraindications would be if there is active ocular surface inflammation, any infection of the lids and the meibomian glands, or the patient has lacrimal drainage obstruction. So that's, again, one of the principles that you need to look for before you think about doing a punctal occlusion. Types of occlusion, you can do temporary, semi-permanent, and permanent occlusion. And there's a wide variety of plugs available for all these three categories. This is a nice comprehensive review published in 2016 in the Journal of Ophthalmology. The temporary collagen plugs are made of collagen. They dissolve within days to several weeks. It's always useful as a diagnostic trial, and it can also assess the benefit and tolerance to punctal occlusion. In my clinical practice, when I have to use a temporary collagen plug, what I find is using 2-0-chromic catgut suture. You can take this suture, cut it into 2-millimeter bits, and they fit into the punctum very easily. And that's very nice. It stays for about 2 weeks. And it's relatively inexpensive, and you can use them in your clinical practice to do a temporary punctal occlusion. Silicone punctal plugs are commonly used because they provide the punctal occlusion for a longer duration of time. There are two basic designs. One is like a collar stud that fits into the punctum, but there is a flange that remains outside, so you can see the punctum once it's been placed. And the second type are the intracanalicular, where you put the plug but it goes into the canalicular, so you don't see them outside. They come in various sizes and designs. So you need to look at your punctum and decide which size is going to fit. Some of them will be like, they will be small, medium, and large. Some come in well-designed sizes like 0.4, 0.6, 0.8. So you do that. And even before you put in the punctal plug, usually the device that comes preloaded punctal plug, the reverse end is usually a punctum dilator. So you can go and dilate the punctum before you can. And that also allows you, when you're using that punctum dilator, you know what is the diameter. They are commonly made of silicon, hydrophobic acrylic, and the intracanaliculaar plugs, like the Herrick plug or the Smart plug, they are placed inside the canaliculars. They have less chances of extrusion, especially if the patient is rubbing the eye, compared to the other silicone plugs which have a flange. But the problem here is you cannot visualize where the plug is. So you assume that the plug is within the canaliculars. Some of these plugs are radio opaque, so you can do an X-ray and figure out where the plug is. The other problem is, with the repeated blinking mechanism that you have, sometimes the plugs can migrate and you find that the patient comes back and with a recurrence of symptoms, and that tells you that the plug has, it's no longer doing the way. You can do a fluorescent dye clearance sometimes to establish that if the plug is still working. The permanent occlusion you can do with thermal cautery, argon laser, or even surgical occlusion, where you excise the rim of the punctum and then you suture it with vicryl sutures. These are reserved for severe aqueous deficiency, where you know for sure that the aqueous production is not going to improve, and you try to conserve tears. And in these kind of eyes, I find that it definitely gives a long-term success. So this is a patient who had, when she first came to me, she could not even open the eye. She has severe aqueous deficiency, a lot of filaments, and we went ahead, we did a thermal punctal cautery using the heat cautery, and you can see that this is just 1 week after the procedure. You can look at the luster of the surface. It's so smooth, and she was so comfortable. She felt that this was the best treatment that was done for her. So you have to assess the ocular surface, do surface staining. You can do some baseline Schirmer's test to know that, that this is not like, you need to make sure that the reflex tearing is not very active. Otherwise, you may have epiphora. You can look for dye clear, the fluorescent dye clearance. You can do a syringing to figure out whether the punctum is patent or not. Because the punctum is already blocked, then less likely that you will have any improvement. Rule out active inflammation, and if there is any inflammation of the lids and surface, you treat that. To insert, well, it's mostly done on the slit lamp. You can put some topical anesthetic, measure the punctum size, then use the appropriate instrument to hold the plug and insert it. And once it is inserted, just confirm the stability. And for me, I always tell my patient, if I'm putting in a silicone plug, that be careful when you wipe the eye. If you use a tissue paper and wipe, sometimes the tissue paper will catch the plug and your plug will extrude from the eye. And that is also true if you put in a very small plug, which are loose, so they have a more tendency of jumping out of the eye. So the expected benefit, you will expect that the patient's symptoms will improve. The surface staining goes away in the sense that you do a pre-op surface staining, and when you come back and if the tear film volume has improved, stability has got better, you find the surface staining reduces. That results in better visual quality as well. And the patient says that what I used to put every hour now, I don't need to put my drops that frequently. Complications, yes, you may have excessive watering from the eye. That's why if you are doing it, maybe just do the lower punctum first and see if that is sufficient. If not, you can go and do the upper punctum as well. Because if you do both, sometimes they will end up with epiphora, extrusion of the plug, foreign body sensation. The other thing that can happen is canaliculitis and pyogenic granuloma. This is something you need to watch out for. If you manage that, you remove or change. If the size is not correct, you can change that. If there is any infection, you may remove the plug and treat the infection, and then move on to a different category of plugs, which may be intracanalicular, or in case there is severe aqueous deficiency, you can use the cautery. If you look at the evidence-based, in the Deoss management, you see that punctal occlusion is mentioned as an interventional treatment for moderate to severe aqueous deficient dry eye, because it increases the quantity of tears by partially or completely blocking the tear drainage system. Cochrane review of 18 RCTs did not find a significant benefit of using silicone or collagen plugs, but these are category in a normal dry eye patient you may not see. So if you look at a specific subset of patients with aqueous deficiency dry eye, this is where punctal occlusion plays a very vital role. But you need to be aware about the complications, especially infections that can happen, because when you put in a plug, in a surface that's compromised, there is less tears, you can get bacterial colonization, biofilm formation, and they have shown when they removed the plugs and they cultured it, they found a lot of organisms, especially Klebsiella. So the clinical Pearls take-home message is that punctal occlusion is a valuable adjunct in the management of dry eye. Patient selection is critical. It's integrate in a stepwise dry eye management. Never plug in an inflamed eye. Give a trial with temporary plugs first, and the lower punctum in first instance, and then reassess regularly for efficacy and look out for any complications. Thank you for your patient hearing.
Thank you, Rajesh. Can we start with some questions? I was wondering, in your practical practice, when do you decide for going to the superior canicular plug?
Well, it depends on the severity of the condition that you start with. In a referral practice of mine, most of the time when the patients come, they already have significant amount of surface staining and reduced aqueous. So we do both the upper and lower punctum. And we find that, if we are sure that the aqueous production is not likely to get better, then we straight away go for a permanent occlusion. Now, the difference between putting silicone plugs and punctal cautery is that if we know that it's not going to improve, the punctal cautery, you can avoid any of the complications of infections because, unlike plugs, which can have bacterial colonization, when you do a heat cautery to close it, you don't have the risk of having the secondary infection. The only problem that we see when we do heat cautery punctal occlusion is the recanalization. It can be as high as almost up to 20-25%, depending on the type of cautery that you have put. If you can insert your probe well into the canaliculus and you apply the heat and then come out, then the chances of recanalization is low. But if you keep your tip of the cautery just at the punctum and you cauterize it, it will shrink that. But then what happens when the eschar falls off? You find that you again have the punctum opening up.
Any of you have an experience with the new strategy of having this hyaluronic acid, the gel, that you can cross-link and put instead of a plug? You do have an experience in that?
There have been very good data on that, but currently it's not available but once it's available, we would definitely try to use it.
And cheap enough.
Yes.
I've got one question. I totally agree when you say that it should be not used in eyes with a high level of inflammation, but what is your clinical criteria for that?
Yeah, so when we say high level of inflammation means an eye with active discharge, or if you look at the lids, there is active inflammation, where you think that already there is a bacterial overload. So you may first initially treat that, get the eye so you decrease the bacterial load, and then you can go and do that. So when I say high level of inflammation, if the inflammation is induced by the aqueous deficiency, then by plugging, you are going to help that.
Yeah. Okay, thank you.
I had a question in the same lines because you're plugging it, so the inflammatory markers are now pooling up in the lower part of the eye. So is there any specific test you would want to do, or where you would, if there's no active bacterial infection and all, would you put the patient on anti-inflammatories before?
Well, you can always, instead of going and doing a permanent occlusion, you can do a trial of temporary plugs and see. So you will have, so it is temporary. You can even, if you put in a catgut, you can just go and flush it. It will go away. So so basically this judgment, there is no defined guideline where you can see if I do this test, it can tell me that you should plug or you should not plug. But it's a clinical judgment where you look at the eye and the patient's history. If patient has active arthritis and patient has deficiency of tears and your Schirmer's is almost zero, then you try to see whatever you can conserve. Even the drops that you apply to the eye, you're applying preservative-free tears. You want that to reside on the eye for a longer period of time. I think. So
when we do the treatment, we stop steroids post-operatively so that we want scarring to happen. If you give anti-inflammatory agents, sometimes we see that the recanalization happens and you want it to fibrose down. So would you recommend stopping topical steroids and anti-inflammatory agents for a while after the procedure?
We haven't done that, but we usually put them on a steroid antibiotic ointment, which they apply, because we don't want the eschar to be so hard that then the chance of that falling off is even more. But if you put some emollient ointment or something, then it allows that to remain soft, and the chance of the entire eschar falling off and recanalization to happen would be less.
So
Excuse me, you go already for plug in the inferior and the upper punctal, or you begin by just the inferior?
We can, depending on the severity of the disease, if you feel, maybe you would do the inferior first and look at the result, and then come back and do the superior. But if the original disease itself is very severe, then we go and do both at the same time.
I think that Rajesh is full of passion. We need now to move,
Sure.
I think. So the next speaker will be Deepti Mehta, talking about stories from real world practice with a very enigmatic title, which is Beyond the Bottle.
Thank you so much, and a lovely morning. So, beyond the bottle, why I called when Dr. Rohit sir called me asking what I would want to speak on ocular surface. So I thought this is one thing which has been ignored in our regular curriculum, maybe because that's not as vital as the retina or the cornea. And I thought I'll just put in 3 main learnings which I have learned over, probably a decade of cornea and ocular surface practice. So the very first thing is, I think ocular surface is the easiest in the eye to examine. You don't need an IDO or your gonio skill. Everything is in front of you. So I think if you have an open eye, a lot of these missed links can be found out. So examining the ocular surface is time consuming, looking from the bulbar, conjunctiva, palpebral. You have to look at the meibomian gland, the puncti, and new patient, obviously we will have to look at the tarsal, and now we cannot end it without looking at the lacrimal gland. So this is something that can be missed in a busy OPD, and I feel one golden tool which helps not miss anything is certainly the fluorescent stain. So I think I dedicate this entire presentation into this beautiful stain, which is a must for any patient who comes to you for the first time or anyone who has a symptom of ocular surface issues. So there are different staining patterns which this beautiful fluorescent drop can create on your ocular surface. So if you divide it, the first pattern you see is a punctal staining. Now what exactly is a PE or SPK is nothing but desquamatized epithelial cells causing a pooling of your fluorescent dye and staining. So whenever you start looking at a more severe form, you'll have filaments and reduced tear film, and this is when you start looking at a primary or a secondary Sjogren's. So this is just with a cobalt filter, and you see how beautifully everything is highlighted with a Ratten filter. And this is a must in your ocular surface practice. So this is the first case of 42-year-old female who was symptomatic for more than a decade. This is how her fluorescent stain looked with a very low Schirmer's of 2 to 3. And this is when you subject these patients to your collagen workup. And she was referred to a rheumatologist, started on HCQs and our local treatment. And she certainly felt much better. Pilocar does great in such patients. She was happy, but still symptomatically not fully out of it. So this is when we did this treatment, and you can see how pristine the surface look. Yes, again, this was a patient whom we did a punctal cautery, which was just discussed. A beautiful procedure for Sjogren's, where you have a very high aqueous deficiency. So a very elegant technique, just takes a few seconds. And as Dr. Fogla just discussed, you can do both eyes or one eye as per the case be. And she was so happy that we went again and did the other eye, which was less severe, and this is how she looked in 2 months. And trust me, this is a life-changing procedure. So 3 months later, she comes back with a box of sweets, not because of her eye, but because she had conceived. So many a times, arthritis and these systemic diseases are picked first by us, and probably the treatment of RA treated her infertility as well. So this is the next patient who had a similar complaints, but as you see, her Schirmer's was slightly better, 5, 6. So this is where we planned a little customization. We went ahead, cauterized the lower punctum, but I didn't want to do that for the upper, so I just put a catgut temporary occlusion. And day 3, you see how beautiful. She couldn't even open her eye for a photo on the first time, and this is dramatic at day 3. But as you see, in 2 weeks, when the catgut got absorbed, the SPK started recurring, not as severe as first. So this, and there was no epiphora. So this reassured me, and I went back and cauterized the upper punctum, and this she is after 6 weeks. So as discussed, it's a permanent closure, so it's always better to do one by one if you're in doubt, or if you're sure of cauterizing both, you can go ahead as well. So this was another patient who presented with diffuse SPKs. This is how she looked. But the culprit was here somewhere. This was an OSSN masquerading as ocular surface dryness. And here the pathogenesis of the staining is basically metaplastic cells. So all SPKs are not dry eye. And this is how she looked, and it resolved very well with mitomycin C. Again, another differential for diffuse SPK is this gentleman who was 70 years, who underwent a bone marrow transplant. So these are cases of GVHT, which looks very typical to Sjogren's, and they do beautifully well. So this is how he looked after 10 days. So in him, we went ahead with a scleral contact lens. So today, scleral contact lens in India are much more affordable, and a lot of our ocular surface patients can benefit. Again, OCT is a great tool to judge your fitting, may it be the central vaulting or the peripheral haptic junction. So this is again a diffuse SPKs, but as you see, the pattern is very different. These are more coarse and more granular. So this is typically called a starry sky appearance. So these are Tygerson patients seen in men who are middle-aged, and here the pathogenesis of the staining is either a viral or immune reaction, and here you would require a steroid and a long-term tacrolimus or cyclosporin drops. So again, when you have the staining localized to an area, that is the giveaway sign. So these are very typical of these boys who have a nocturnal lag of thalmos, and they get up never with a happy face. They always have this difficulty early in the morning, pricking. Their school timing is affected, so a simple lubricating ointment or a lid taping will help them. So this again a patient with a lower SPK, but here it's not the lid, but basically this missed low-grade meibomian gland inflammation, which was causing these immune reactions and inferior SPK. So again, a systemic antibiotic treated the mild chalazion or hard yellow. So this was an interesting patient, 40-year-old. He had visited at least 2-3 hospitals with a bunch of dry eye assessment chart. Every test in him was normal. But what most of these gadgets do miss is the peripheral cornea. So if you carefully appraise, he had a very thin linear strain of SPKs in both his eyes, which causes typical never comfortable pricking sort of sensation. So just looking at these smaller signs, this was a typical case of inferior lid retraction, where you see the opposition of the cornea and the lower lid is not as normal. And these are patients who, though blink well, they have sort of an incomplete blink, and a simple oculoplasty treatment of fixing this can help them change life. So this case I put just to show the importance of a stain. So this was a very severe limbal VKC with few weeks of steroids, did respond very well. But do you really know how the inflammation control is just by a stain? So if you look at their staining, look at the SPKs in the first, and look at how pristine the ocular surface looks after a week of steroids. So yes, the limbal nodules do take time, but a simple stain can really tell you how the molecular level at the ocular surface is changing. So a stain surely speaks a lot. So always look at your intensity, position, shape, and so many things. Even a single SPK on your surface does show there is something that you'll have to look more than your computer vision syndrome. So the second staining pattern is a pattern staining. These are very, very typical of a tarsal foreign body. So as soon as you see a lenient stain, just make sure you remove that subtarsal foreign body. Again, this was a pattern staining caused because of an exposed concretion. So the third staining pattern is the vortex pattern, which is extremely interesting. So these are patterns created by a moderate or a mid-grade limbal stem cell deficiency, where there is a slow growth of the epithelial from your limbus. So this was a patient with aniridia, and you see how beautifully the strained epithelial cells are trying to cover the central recurrent corneal erosions which can happen. So this was a gentleman who was been using 9 diopter contact lenses for more than 3 decades, and probably that is the reason why his superior limbus is not as healthy, and he kept getting these recurrent erosions and whorl patterns. So in him, we did the autologous serum. He was on lubricatings for years, but something different does make a difference. So this is how he was on presentation, and this is after maybe a month of autologous serum. So my learning too was every case of dry eye is different. You don't have to really look at the flow charts and things. In your clinics, just look at what is causing the dry eye and just create a small custom treatment with so many options we have today. So this you also have to differentiate from something called hurricane keratopathy, which is opposite. This is where your limbus is overactive and it's trying to give more epithelium. This is usually seen after an epithelial injury or typically post-graft. So this is a 1 week post-DALC, and you can see how beautifully in a vortex pattern the epithelium is trying to repopulate, and these smaller whorls at the suture line. So this was an interesting paper by Dua where he shows most of these whorls are clockwise probably be responding to the Earth's electromagnetic field, and he has a beautiful paper on that. This again has to be differentiated from vortex keratopathy, which is typically seen with amiodarone, but here there's no staining issues, but it's basically this. So this was 2 days later, he called me, and 2 days later he comes to the OPD, and this is the staining pattern, and this is called a negative stain. So this is not a true staining, but basically shows epithelial irregularity, and this is very typical of how your recurrent corneal erosion patient comes, because once they come to you, the erosion is already healed. So looks pretty clear, but if you see the negative staining, such a tear breakup time is very low, and this is a patient with basement membrane dystrophy. A simple PTK can help such patients. So this again is an interesting pattern called dimple veiling, usually seen in steep RGP contact lenses. So this is basically pooling of your dye. So I think I'll end it with 1 or 2 cases. So this gentleman, a corporate guy, his only symptom was when I smile a little bit, I have tearing in the left eye. And he was always told this is reflex tearing because of dryness. But just look at the fluorescent stain. This is not the right eye being less, but you'll see the tear meniscus in the left eye being more. He has undergone syringing quite a few times and was always told it's normal. So this was a very simple case of punctal stenosis. For some reason, he would get it back. And a simple in-office punctal dilatation, you see how beautifully the tear meniscus has gone back to normal. So these are subtle things. After this, when he smiles, it doesn't water. Maybe simple for us, but truly life-changing to others. So always when in doubt, if a patient has come to you as a second opinion or comes back to you with the same problem, it's always important to look at smaller missing links, which can be life-changing to the patient. So this again was a patient who was, okay. So again, this was a patient, this is the last case, who had pricking for 2 weeks. This is a very typical pattern staining, and I was pretty sure there'll be a subtarsal foreign body, but the tarsus was looking pristine and nothing seen. But the clinical staining pattern is so obvious that I had to slightly nudge, try to remove the mucus which was there, and then I could see a tiny end of eyelash. So this was a cilia which was embedded in the tarsals, and if not for that strong pattern which was created, this could have been easily missed. So that important would be staining in this patient, and this was the next day morning, he comes very happy with it gone. This was there in his lid for around 2 weeks. So I think the take-home message for ocular surface, it's an extremely unique organ. It receives less importance in our clinical practice for varied reasons, and ocular surface reflects the systemic health in ways more than we actually can imagine. And many a time, simple things in life we complicate. So there are a lot of gadgets, and all of them are fun and super useful, but I think a thorough clinical examination is of utmost importance. Thank you so much.
Thank you. I think that there is another message. How much we can learn from one drop of fluorescein. Any comment? Any comment? That was a beautiful work. I mean, thank you for these great cases. I think that we need, first of all, to thank Rohit and his team for the great table that we just received on the sum up of all the product that we can use nowadays. So thank you for this big work. Thank you.
So next we have Dr. Wasim Altrodi. He'll be talking to about diagnosis and monitoring of dry eye.
Thank you, sir. Good morning, dear colleagues. Allow me first to thank Professor Rohit and his team for the great organization and for the tremendous hospitality. And thank you, Professor Siham, for the opportunity. I'll try today in the next couple of minutes to try help our junior colleagues that they want to start adopting their dry eye to their clinics by identify a 3-level of dry eye practice, adopt a core algorithm for diagnosis, and adopt a minimum set for each level of dry eye practice, standardize the test order, and do a better documentation in order for them to follow up properly. As we spoke today, that dry eye is multifactorial. There is poor correlation between signs and symptoms. There is no gold standard test. That's why there is lots of diagnostic tests keep coming to the market. That will cause lots of inconsistency in the workflow and at the same time, more chair time consumption. So what do we need in real life? We need a minimum metric set for each level of dry eye practice, and we need to standardize the test order. We need to do a proper documentation in order to assist our results of treatment. As a core diagnostic algorithm, you may agree with me that Deoss 3 is the core for the diagnosis. It has been explained before, so I'll not go through it. But what about the workflow? There is one rule which matters here. Order is essential. Go from the non-invasive towards the more invasive test while you are doing your examination. But again, there is a long list of diagnostics, which one we are going to choose and which one to start with. That really depends on what type of dry eye practice you want to adopt. In my opinion, there are 3 levels of dry eye practice. Tier 1, which is the slit lamp basic package that is available in any eye clinic. And Tier 2, you have to add more objectivity, you have to add point of care test, more non-invasive procedures, and better documentation for the symptoms and signs. And Tier 3, which is the dry eye and ocular surface specialized center that everything is dedicated to dry eye. What about the workflow in Tier 1? Tier 1 dry eye practice aims to establish diagnosis, identify the phenotype, start the treatment, adopt few metrics to assist your results. So let's go for the workflow. First, you start with a questionnaire, adopt 1 or 2 of the validated questionnaires, translate it to your local language, and trend it over the time. Then have an external eye examination with minimal manipulation to the eyelid and the eye surface. Look for the blinking pattern, look at the face, looking for rosacea. Ask your patient to look down, look for telangiectasia at the eyelid, collarettes, among other signs. Stain beautifully has been demonstrated in the previous talk, but what I want to highlight here, the way that you do your stain, the amount of fluorescein that you apply, and when to read the results of the stain in order for you to be consistent and have meaningful data that helps you to compare for the follow-up. And I agree that we need to use lissamine green more than what we are doing right now. This is how you evaluate the function of meibomian gland. Do not be angry with the patient and press too much as the video on the right side. Use a device which is really calibrated to deliver a certain amount of pressure, which is equal to the normal pressure delivered by the normal blinking. Count how many glands are functioning and grade the meibum that's coming out of the glands and come up with a score that would help you to evaluate your meibomian glands. So this is the same eye, just different techniques. You can see the difference. I do Shermer test when the tear meniscus height is low or when I suspect Sjogren or autoimmune disease, and I do the corneal sensitivity test when the pain is out of proportion in cases of stain with no pain or the opposite. At this stage, you can subtype your dry eye, which means look for the driver, documented evaporative aqueous deficiency, mixed tear breakup time, ocular surface stain. Don't forget to look for masquerades as well at this stage. What about Tier 2? When you gain more confident, you start to introduce more point of care tests and more imaging. What this would help you, it will give you more objectivity when signs and symptoms, they disagree with each other, a better patient engagement and understanding to their conditions, so they will buy and stick to your treatment plan, and delegation to train the staff that will cut down your chair time. Point of care test, osmolarity, and MMP9, whether do we agree on the way that we are doing it nowadays or not, but in my opinion, it's important to adopt it. It will develop the habit for you to keep looking for things, waiting for the pathfinder. Maybe that's gonna change the way how we look to dry eye disease management. Add more non-invasive tests, tear breakup time, non-invasive. Do meibography. It's a great tool for the patient to understand their condition. Even a proper slit lamp photo can help you, like you can see down between before and after Demodex blepharitis management. You can go for more quantitative corneal sensitivity test, Cochet-Bonnet, or even Braille non-contact at this stage. The workflow here is really, it's a team-based flow. So the front desk, you cannot do everything alone. The front desk should capture the symptoms and the risk factors. Your technician will do the minimal or non-invasive test. Then your job as a doctor to confirm the diagnosis, identify the driver, and initiate a targeted therapy at this stage. It's very useful at this stage to start adopting more in-office procedures like IPL, microexfoliation, thermal therapy, among others. What about tier 3? Tier 3 is basically everything is dedicated to dry eye and ocular surface. Here you have to adopt all the OCTs, the new machines, new devices that can help you to subtype even the drivers, vision quality assessment, even the new machines as well. Now, what about the follow-up? The follow-up, you have to adopt symptoms plus 2 objective metrics to follow up your results. In tier 1, go for questionnaire, staining of the eye surface, tear breakup time, and meibomian gland function. In tier 2, osmolarity or non-invasive tear breakup time, MMP9 when you feel that the inflammatory status of the patient is changing, and a proper photo documentation. In tier 3, do whatever you want by that time because it is a dedicated dry eye center. So always choose your level of dry eye that you want to start with, adopt a core diagnostic algorithm, and standardize the test order. Your test order should be standardized, do a proper documentation. And again, tier 1 is the fundamentals. Tier 2 and 3, they don't replace it. You can build on it. And thank you so much for your attention.
Thank you, Wassim. Any questions? I mean, I got one regarding the regular topography machine that we are using. Do you look at the stability, or I would say, people sometimes misinterpret the image when they become irregular, and so looking at the epithelium map in correlation to that, is it something that you integrate nowadays in your practice?
Yes, I agree with you that we do more and more epithelial mapping, and I believe this will fall under tier 2 once you start to adopt more objective tests to look into things in a different way. But even a simple autorefractometer, if you flip the lower eyelid, you can see your meibomian gland because it is an infrared camera. So it might be as meibographer.
Absolutely, yeah.
I thank you very much, Dr. Atroudi, and also I would like to thank Dr. Meda for your 2 complementary talks about the use of simple slit lamp plus adjunctive examination. I would like to ask you, both of you, a question. When you start examining a patient, what is the order of the examination? I mean, do you put the fluorescein staining first, or do you look at the eyelid first, or do you come back to the fluorescein at the end of the eyelid examination? Because in my experience, sometimes it may change what you can see on the ocular surface.
I can extend this even if you have the point of care test. For example, maybe the osmolarity is minimal invasive, but MMP9, you have really to touch the conjunctiva of the lower eyelid. So when to put it exactly, that's a great question. I don't have a specific answer for that. But what I do, questionnaire, a quick external exam, then I will do the stain, then I will do the meibomian gland evaluation. Tear breakup time, the osmolarity, I do it usually immediately after the questionnaire. And I keep the MMP9, not the technician will do it. I will decide whether to do it or not. But where to put it properly, I do it at the end. I don't know if that makes sense or not, if that's going to change the inflammation at the eye surface. Maybe someone has an answer for that.
I mean, I think that it's a great question because all of us nowadays, for looking at the chronicity, will check the conjunctiva. So as soon as you put any band or anything that you will touch it, may change by evidence.
Yeah, especially if you express the meibomian gland, that's going to change the whole thing.
Just a comment again on the same point about the staining. In fact, there is a paper that has been published a few years ago about the fact that if you put the fluorescein finally and you wait a few minutes and you put another drops, you will have another pattern. And we see that regularly in consultation. So there's this question at which how long you wait, and for me, for example, for my refractive cases, I put another drop later on to see if there is some staining. So it's the same comment as your presentation, which was very interesting, and you highlighted too. So what do you have any comment about that? How can we have a setting to have the same data, in fact. Really, it's a point for me.
Yeah, if I understand properly, always if the patient has put any drops within 2 hours before he comes to me, I don't do anything. I do just a routine exam because that's, in my opinion, could be not reliable, especially if they have contact lenses and just they removed it. So I don't do the whole battery, just I fix the acute thing that the patient came for, and I give him another appointment, because we do have lots of ladies as well that they do come with full makeup, you know, as if they are going to a party and they want to have an eye examination, and that's not practical at all. So you may adjust, but whether to put stain and after that how many minutes things might change or not, I don't have a clear answer for that.
Yes.
See, one of the, sorry.
I think that Chipti want to make a comment.
So I think the issue, at least in Bangalore, is many a times dry eye assessment, if you have a large volume, is done by an optometrist. And if you look at the dry eye machine, you have the non-invasive, and also few machines do ask for a staining pattern. So one tip would be to always do a dry eye assessment when you are there. So the non-invasive test can happen first, NIBUT. Always see the patient before even the optometry stains. So then they come back to me, and most of the dry eye workup is done after the NIBUT by me. So that's when you put because whenever you do a Shermas, however temporarily they put, that can touch the cornea. And also if there's a break in tear film in the conjunctiva, that can affect the corneal T-but as well. So best order would be, as said, as the patient is fresh, make sure your contact lenses is off for a few days. You do the NIBUT, then you at the slit lamp do a hanging drop, not touching the conjunctiva. So now you have even the liquefied fluorescent, which you can keep, or just do a hanging drop of the fluorescent in the cul-de-sac. Then I do the NIBUT, and then only the last test would be the Shermas. That's where you're touching it. And all of these are usually without anesthesia if your patient is cooperative, because you get to know the reflex as well, especially in Sjogren's, it's always without the anesthesia drop. So I think that is the routine. Yeah. And last, T-but, I think after your T-but you can do your MGD. It doesn't really matter for your Shermas.
You know, I still have questions regarding the non-invasive breakup time that everybody's, is using or is commenting at least. We are still meeting there the threshold of it, because many machines are providing different, even shape, even timing. So I think that it's our responsibility as the ophthalmology community to define what is the normality for it, even if we know that obviously it's good to try to define the breakup time without fluorescein. But we are still meeting the threshold,
yes,
right?
I agree. And whether to do head-to-head comparison studies between the machine, that's going to be great. But the most important thing is choose one machine and stick to it. And try to control the environment of the examination room, as explained yesterday by Dr. Rashid, as well, is very important.
CM?
Yeah, we're talking about staining. What about the lissamine green?
This is what I said. We need to agree that we need to use lissamine green more and more in the stain. It gives a better idea of inflammation.
What time? Before or after the fluorescein?
I think, answer me this question.
But I think that what we need first is a proper lissamine green. The problem with the strips, that the load is too low. There is no staining enough. So we need a bottle of lissamine green, but unfortunately lissamine green is unstable.
Yes.
So if you have a bottle, you have to put it in the fridge. But
you know what? I'm putting just one drop of saline on the strip, just really, and it gives an amount of...
It depends on the trademark of the strips, because some strips are so low in stain that you need at least 3 strips with 1 drop of saline to get the sufficient
concentration,
amount of dye.
And it's difficult to find, actually. In our place, it's difficult to find.
Actually, I was going to make this comment. It's more and more difficult to find lissamine green that day.
So can we move on? Because this session has only 10 minutes more to go. Thank you. So this has 2 small talks or discussion. One is, yesterday we had Dr. Madhu Jaraju speaking on the IPL. There are a lot of, we also had a discussion on the Quantal workshop. J&J is not keen, or I don't think they're going to take the LipiFlow forward. So We started using it close to 5 years back, especially during the COVID time. We call it the MeeboFlow Thermoflow, a thermal heating pad. Ava can quickly discuss, it does not have any consumables, so it got that value for money, and you can charge them, not too pricey. You can use it for your pre-op. And I think this is one thing which has made a huge difference, because I started using View LipiFlow even before J&J took control of it in 2008 or 9, and been a big fan of it, the way it worked, but the cost was completely a biggest barrier, and it was not possible to offer it to everybody. Then the IPL, which works wonderfully well, but IPL and this is like a combination, sometimes. But when you want to have one therapy, which is for both for your dry eye, and also I use more for your pre-op, cataract, refractive, and all these challenging patients, just worked wonderfully well. Initially, I was skeptical. It doesn't have that bulky feel of a machine, but it's a powerhouse. Just a simple thing about how you do this in your practice.
So there is a silver heated pad which we wait for it to preheat until 42 degrees Celsius, and we use a ultrasound gel which helps us to transmit the heat. We do it for 10 minutes per eye, and we do around 3 settings in gaps of 15 days, and we concentrate on the upper eyelid more, around 6 to 7 minutes. We do it in a downward direction with mild gentle pressure, and then we concentrate on the lower eyelid for around the rest of the 3 to 4 minutes.
So we have been, like I said, I started off being such a big fan of LipiFlow and IPL, and then slowly moved on to this for these patients. The results have been dramatic. There's something what Pooja had actually started off, because she was using it more frequently in her patients. And she used to tell me the patients who you advise for 3 sittings just come back after 1 sitting and say that it gives them tremendous relief. And like I said, the pad, I don't know, I should ask the company of how frequently you should change, but it is like you can charge it at low price. So even if you're looking at a pre-op patients, for example, here you are, let's say, assume that you are planning a PRK or a cross-linking on this patient, and you have these kind of people who have this low T-butt, and you can see that all his markers are very high. It's not writing today. And imagine operating on this is not going to be very, very good, because your dry eye scores are not good, meibography is good, but your T-butts are not good. We also calculated we also do like what Deepthi said, we also do this is just for the first line, we also do the flow she said. But when you do it within a short time, first sitting you may not have too much of it getting better, but slowly you can see that the markers start getting better. And if you feel that you want to have a perfect healing, I think this probably would have a huge impact in your practice. And one of the challenges what we see in refractive surgery, especially cataract, is patient coming back with chronic irritation and pain. And if you want to quickly do a, say, multifocal or a EDOF lenses, and you don't have the time to give a cyclosporin, because for the MMP9 to come down, it will take at least 3 to 6 weeks. Lifitegrast also works very well, maybe much faster, but you can see that within the first sitting only, the next, your biomarker starts coming. This is not one reading, the machine itself reads 3 times, so that it does have a repeatable value to it. So that is one place where I feel these technologies, which are not heavy burden on the practice, but have a huge impact in making your pre-op and post-op both in a much, much organized way. And for the patient, it's just a good feeling of heat massage, which works very well.
Who is making that platform?
It's made in US. Somebody from the company here. we just, it's made in US is what? It's an FDA approved also. It's an FDA approved product made in US, but it's not like they don't have that power of J&J and Quantil and all that.
It's very unusual to have something from the US that is cheap enough to be affordable.
I have a question.
Yes.
Apart from the price, because we know I'm a big fan of LipiFlow, I do it a lot, but it is expensive. And you've been mentioning here the cases which is pre-op, right? Which is pre-op. Apart from the price, do you have any feelings comparing MyboFlow to LipiFlow? Number two, what about the in day-to-day practice for MGD? When to use it, especially that we do have IPL and we do have the LipiFlow right now?
What happens is, from the clinical endpoint point of view, it may look very similar. And in fact, the feel of a patient is little better here because it's directly on the lids and it just has that heat. And yeah, so it's more, it's not as controlled as LipiFlow, but more organized, one. Two, from the biomarker point of view, both were very similar. LipiFlow, we published it also. But maybe somewhere a little faster in reducing the MMP9s. LipiFlow is to take at least 2 weeks, 2.5 weeks. But it's a little faster, like I said. But the problem for a lot of us is how this TNF-alpha works, because that's what we are interested in, all your haze and other factors. Even LipiFlow was also slow. IPL also was quite good. You can combine it with IPL. Like IPL is quite good with TNF because it works on the micro photomodulation. They have that biophotomodulation with the red light, and red light pretty works with this. So that is why sometimes when you know that, that's why I said yesterday the Genuis report is a very good indirect surrogate marker. For example, when you see this, you know your TNF-alphas and these factors are lower. So you can combine them well. But again, cost is a factor because refractive surgery costs are going up. And you add a LipiFlow cost to it, it becomes very challenging.
And one session of treatment is enough?
It needs 3 sessions.
Okay,
how
so like
how do we give it?
Okay.
And compared to LipiFlow, you said that the effect is sooner, but is it longer or as long as
It's the
LipiFlow?
same. It's the same.
The same?
Yeah.
Up to several months?
Yes. And those who work well work very well. Those who don't work well, they just doesn't work. So that's when you combine it. So we have to understand that the IPL, Sharon and me published a paper on IPL in cornea, and we had a LipiFlow. Their pathways are completely different, even though the mechanism is different. The IPL has that photomodulation. It works on the microvasculatures of the thing. It changes the whole pathways there. And some of them, like ICAM1, which is, they have much better work on IL-17, and the ICAM1, which is more of epithelial-driven one, works very well with the IPL. And what we found is the MMP9s and TNF, you need to have a combination of this. So that's how you mix and match, like how we do a mix and match with glaucoma and other predications. There's not a one machine which can combine both. That's what we have understood.
I think one point that we have with this device, so there is no expression. You are only applying a controlled thermal
pressure,
heat pressure. So unlike LipiFlow, where it's not only heat, but there is expression of the glands as well to express, there is no expression in this. So would adding a manual expression of the glands after doing a thermal thing would make it better?
Absolutely. And
because there are certain devices that we have seen, the disposable clips that you can, you do the heat and then you apply that so you can...
Yeah, because that was my question, to then after go for the expression.
Technically you should, that's how it is.
Absolutely.
This is the first step, and then you manually express on the slit lamp so that you express those liquefied stuff out, and then you continue with your omegas.
Yeah, because
and other
otherwise you keep the meba and it goes again to the solid.
That's going to be more painful comparing to LipiFlow. But I have here 2 things. How much time, the interval between the heating and the expression? Because we know that the mebum will get solidified very soon. That's number 1. Number 2, what about keratoconus patients? Since here we are doing heating and kind of massaging, is there any...
See, keratoconus is not a one-point incident where, you just put a pressure, it will go. This is a chronic process. And In fact, that is why, I used to do a lot of LipiFlow on my keratoconus way back in 2007 or 8 when, it's a pressure. So I think that that part is taken out. Like, I think earlier you express is better because it's got liquefied and you can do it. Yes, sir, Ella?
I just want to confirm, we've been using NabiFlow for more than 5 years now, and it's really very cost effective, very efficient, and we do the expression of meibomian glands immediately.
Does that make sense?
So we heat it, we do this massage, and immediately manual expression, and it's very efficient. I want to confirm also that most of the time patients will need one session, maybe will come later, not in 2 weeks, maybe in few months to have another treatment. So it's really very efficient, very cost effective. I just wanted to ask you, as you use it, because it's a big problem that we always have this exacerbation of MGD post-operative, particularly cataract, and patients are annoyed. Would you recommend that we do this routinely for those baseline cases without symptoms pre-operatively? If you do meibography and you see that there are dropouts, you do it like 2 weeks for all cases or not?
No, I don't think so. It's an overkill to do for every case because most of them are well balanced. You do it when you have a more dropouts. What I would do is when I see dropouts, when I see these changes, if I'm doing a surface ablations, then it's got a big role in it. Or when you feel that these patients would heal differently. Otherwise, body has its own mechanism to correct itself. I mean, it becomes too much of a overkill.
I do have a question, if it's possible. Just a comment about the biomarkers, if you can highlight this point. It's a bit, is it strange that the interleukin-10 is high with inflammation? It should be lower because it is an immunomodulator. What can you make a comment about that? It's because there is inflammation and interleukin-10 is high too. Is it a regular thing for you?
No, that's green. Green is good. That's the only one band which is on the green side.
Yes, it's a good one, but it should, because it is decreasing the inflammation in interleukin-10. It is a modulation.
If you see here, it is, if I see here, this is the same. It's not changed at all.
Yes.
It's the same.
But it's normal that it's high at this stage of the disease. It's, for you, it's a normal thing.
In fact, when it's too high, it means that it's trying to balance the others. Yeah. That's what it says.
Yes.
Thank you.
So right, it's 10 a.m., so it's up to you. Should we move to the symposium?
Yeah, we move to the symposium, and then I'll add the resveratrol in my omega-3 along with the omega-3 because they both say the same thing. Photographs. All the speakers also can join the stage.
Minutes. Okay, so now we will talk about the Quantel C-Suite, which is a combo for exploring and treating dry eye and MGD. So we've done a little duet with CM, our president, but I will begin. So. First, the platform. So we know that now there are dedicated machines for diagnosing dry eye, and I would like to present this new platform, which is called C-Diag, for diagnosing dry eye. When you have the classical tests, knee, but lipid layer, with interferometry, okay. Siham,
Interferometry.
Thank you, Siham. Meniscus height, mammography, and analysis of the blink, which is very important. So it's a very quick test. Within 5 minutes, you do all the tests. And what is interesting is that you have an automated analysis because you have artificial intelligence in this machine. And at Fondation Rothschild, where I work, we provided a set of pictures of images on patients with this machine, and they trained the algorithm on the pictures. So it's very robust, and all the automated analysis is generated by this IA training. So just to see, so in terms of analysis, you will have analysis of the evaporative part of the dry eye with the non-invasive breakup time, mammography, lipid layer, and also the aqueous deficient dry eye component with the meniscus height. It's a very interesting part, this meniscus height. We use it a lot. I think it's very informative, especially in Sjogren patients, to show the increase of tears after plugging, for example, and also the blinks. Blinking is very important, and it's easier to analyze the blinks on these kind of machines. Also mammography. Well, mammography is very interesting. It gives you an idea about the atrophy of the glands, about the dilations, but you should also test the meibomian quality, because it does not tell you if the meibomian glands are obstructed or not, or if they are, and how is the meibom. So it does not prevent you from doing the clinical examination. Siham, do you have any preference? What would you use as an information? What for you is the most important test?
First of all, ocular surface has the bad reputation that it's very time consuming. And with this machine, we are gaining time, because in 5 minutes we are exploring the whole ocular surface. And for me, if I need only one test from this all tests, it will be the non-invasive breakup time. Not only because it's the criteria now, because we are in the era of the Q3, but also it's given us even it's a Sjogren, it gives us something like information about the stability of the tear film, which is the most important thing in the matter of dry eye.
Okay, so and you have other tests with you can take pictures and do a zooming, and you have scales and so on, and with a dedicated compte rendu. Now I will talk about IPL, because it's a very important new treatment for MGD. Just recalling that IPL is not monochromatic, it's polychromatic, very intense light. Usually it's red light, but it's polychromatic red light. And just talking about the pulses, why we call it IPL is because it's pulsed light. So you have pulses of light with spaces in between the pulses, which is called the relaxation time. And why are there these spaces? Because if you do a continuous stimulation, you will have a burn of the skin. So this parameter is very important. So in order to not burn the skin, you have the length of the pulse, the intensity of the pulse, and also the relaxation time. Why do I talk about this? Because it's important when you consider the kind of treatment that you do. So this is the first version of the IPL, which is version 1, and you have a single handpiece and also single parameter, only the power. So this machine was made for eye only, just only for dry eye. You have machines that can treat also the skin with multi-parameter, but it's complicated. And the lab, the company Quantel, they decided to do a closed machine, and you could not change the parameters. So the advantage is that there are no mistakes, and you should not burn, so it's okay. But you cannot adapt this to pigmented skin, for example. So the new version, so you have a multi-parameter here. You can change the relaxation time, the time of the pulses, the intensity of the pulses, and hence you can also adapt these parameters to different pigmentations of the skin. The more pigmented, the less intense you have and the more relaxation time you should have. Okay, so this is implemented in this machine, and in my opinion, it's a very important improvement. Second improvement is that in the first version, you had a single piece, which is a large piece, which was not adapted for treating the eyelids. Now you have two hand pieces for treating the eyelids, this one for the whole eyelid, and I think it's the only one that has a specifically developed device for the eyelids. And this one for the chalasia, so you have a single spot, very small, so you have two hand pieces, and in my opinion, it's also very interesting. So now, Siham, can you present your cases?
Okay, now I will talk to you about the real life, what we are seeing in our clinic. Just before that, just a reminder that we have a whole workshop on the both machines, the system and the CDIAG, maybe at 12? At what time is your workshop?
12.
With two stars,
1:30.
Dr. Serge Douane and Professor Mohamed
after the
Shafi.
meal.
Then I will present you two cases from my clinic. One is very
Nice.
Both are nice. Okay. Then
Very nice.
Both of them, just to raise the debate, both of them are kids, because I'm at the origin I'm pediatrician. Then both of cases are for kids. The first one is a 6-year-old girl. She decreased vision in 4 years. She had red eye, and at the beginning it was only one eye, and with time it was the both eyes. And she was treated for herpes keratitis at the beginning when it was one eye, one red eye, and then for ocular allergy, and then she had any medical history. And when she came to me, she was totally blind, like this. This is both eyes. And she was referred to me, I was just as the last hope, and also to be oriented for the blind school. Really, it was not, she was hopeless, not her, no, the parents were hopeless, and she was oriented only for the last examination, and also for the orientation. And then she doesn't have any medical history, in spite of she had herpes and she was treated for. She went to the hospital 1 month and 1 month for infectious keratitis and for allergy. And then what I think I will start from the beginning, and I will just see what's happening. Then I did a deep questionnaire. I asked her if she was with her father. I asked her father what is the history? He told me, I don't know. It started with one eye, and she became more and more severe, and now she's totally blind. And I did the full examination at slit lamp. Okay, you saw the picture. Very, very severe, no vessels, scars. And I stopped all aggressive medications because she has everything, steroids, antiviral, antibiotics. She had everything. I stopped everything, and I did for her mammography, a lot of drops, as you see. At 6 years old, she was stage 4, I think. And the surprise, when I did the questionnaire, I asked her father, did she have any history of chalazion? He told me, yeah, but it was when she was 1 year old. Yes, but she has several episodes of chalazion. And that's it. And then she has rhinitis, okay, as all of us. And at the beginning of this disease, it was only the left eye, and it was bilateral after that. Then I thought recurrent chalazion, red eye. What do you think? Yeah, I treat her as an ocular rosacea. My regimen, I'm using it since 15 years. Topical azithromycin twice a day for 5 days, and I repeat it 3 months. For the first course, I add steroids, dexamethasone 6 times per day. And because she's a kid, I don't rely on the eyelid hygiene in kids. Then I did microblepharoexfoliation, exfoliation, IPL, and I recommended for her the Blefasteam. It's the warm goggles. And the surprise, after 2 weeks, after 1 month, after 2 months, and see how she is now. This is the beauty of the cornea and the ocular surface. Then, what is the take-home message? Don't wait for the skin rosacea. It comes later and later. Then, if we need to have the diagnosis, just the eye can be earlier. The ocular manifestation can be earlier for many years before the skin manifestation, and always ask for the history of the disease. The recurrent chalazion was the only word in the history that happened. Another case, but this is really the daily life. These are the cases that I'm seeing every day. Recurrent chalazion, recurrent history of fiery eyes. It was 6. Also, it's a kid. And then I will just show you at the examination at day 0, you see no vessels, corneal infiltrate. These are sterile infiltrates. And she was treated before for corneal abscess. This is not abscess. This is inflammation and not infection. And after 2 weeks of treatment, the same regimen, these are the results. Serge, do you have something?
No, it's okay. I think we don't have time. So the reason. So what treatment did you do in this kid at the first examination? What did you prescribe, and how did you do
Dexamethasone 6 times per day for 6 days, and I stopped without tapering. And topical azithromycin 2 times per day for 5 days, and that's it. And eyelid hygiene.
So 5 days.
Yes, and
okay.
IPL.
So I don't use IPL. Who uses IPL? You use IPL?
In kids.
So who uses IPL in kids?
Dr. Anoud, Dr. Wasim, Joanna. Only Middle East.
So Sihem.
Lebanon, Dubai, Saudi Arabia.
So Sihem, how do you use IPL in kids? Do you adapt the parameters? Do you do the same?
No, I do the same.
Okay.
You know, the youngest one I treated was 3 years old. Miriam also, there. You are North African and like me. Yeah, because the face is small.
So how many shots?
Yeah. But I don't adapt.
3? Yes. So 5 shots? 3 shots? Or 4 shots? Okay. Who says 3?
It depends on the face. But
okay.
I don't adapt any parameter.
And what do you think about the size? So do you flash only on the skin, or sometimes you flash also on the eyelids?
No, only the skin.
Only the skin. Okay. And and did you try to treat some patients only with IPL? Not those kinds of patients, but some patients do not need steroids and do not need antibiotics and so on. Some patients just only have chalazion, children or adults. Do you have this experience of only IPL treated with chalazion and lid hygiene? And how?
Yeah, of course. This regimen is for this extreme cases with corneal infiltrate, with no vessels, with inflammation. If it's only MGD without corneal involvement, I'm not giving steroids. I start by the eyelid hygiene, which is my first line treatment, lubricants, preservative-free lubricants, and the IPL.
Okay, and what about meibomian expression in the kids? Is it possible, or do you anesthetize, or? Do you do maybe a membrane expression after
I'm a bit
IPO?
aggressive because I'm treating also VKCs and I'm putting supratarsal injection without any anesthesia that
I know
I'm
that.
doing. You know
Yeah,
that, yeah.
she's very. She knows how to do with the kids. Okay, don't move. I treat.
No, but I do.
It won't hurt. No, it does not hurt. Stop to cry.
No, they don't cry, really.
Can we move on to the next session because we have a keynote address at 10:30.
Okay, we'll finish. Thank you very much.
So we have two small discussion of nutraceuticals. One is resveratrol, and the other one is the omega-3 fatty acids. And then we have the keynote address of this Deoss by Dr. Henry. So Swami will speak about the resveratrol, the biology of it, which is just come into, it was an anti-aging drug. It had a huge role in many aspects of the health of the body. And now I think it's come into ophthalmology, and we need to know where and how this has an impact in our practice. Yes.
Dr. Shetty, can I just give one comment before they start? These kids with recurrent chalasia, in my practice, I have found that they have vitamin deficiency, a lot of them. So just stress on the idea of double checking on their vitamin levels, especially vitamin D, because once you correct this, everything is balanced back again. And my daughter is actually one of them. I did not recognize this until I double checked on her vitamin D.
Vitamin D has a huge role in ocular surface and all the mebum secretion, so it is directly linked to it. And many times we practicing in, say, India, Saudi or Dubai, we think that because there's too much of sunlight, we don't have it. Vitamin D, we'll anyway discuss about it in the afternoon session. Vitamin D receptors gets changed with inflammation. So you may have lots of vitamin D, but the dry eye can knock off the receptors, so you may never have a vitamin D. So when you increase with others, see, this is exactly, I mean, I think she was reading our mind, or you must have seen the slides yesterday. So what happens is the vitamin D receptors gets knocked down with the hyperosmolarity stress. And we are talking about the receptor here, because the receptor is very important because you have this cornea here, and these are all the vitamin D receptors. So let's assume there are lots of vitamin D. So every vitamin D gets one receptor. So it starts sending genetic code to immunomodulate, that means reduce the inflammation. But let's assume that the receptors are not there. Right. The receptors just not there. And what happens? You have a free-floating vitamin D, but no receptors. When there is no receptors and free-floating, what does it do? It doesn't do anything because it's just water there. And then what do you do to improve these receptors is the most important thing. And who knocks these receptors is your hyperosmolarity. The minute you have hyperosmolarity, your receptors gets knocked off. So that is the whole concept of vitamin D, which we need to be aware of. It is not, see, most of us are all working on this, the free-floating vitamin D, but if the receptor, that's why our entire work, when we started our work, we were looking at the vitamin D itself, then we moved continuously to the vitamin D receptors. And the challenge with vitamin D receptors is you have to do a conjunctival impression cytology on the cornea or ocular surface to get the vitamin D levels of receptors. It's not just from the blood. So that is a huge challenge out there. Absolutely. If you're looking at a vitamin D thing, let's assume you treat with an injection of vitamin D. So what happens is more and more things come. But remember this, if you don't have those receptors, they're never going to start. It's like a lock and key. You need a lock key, and then it's ignition. And if you don't have that, it doesn't work. So what you do is, how do you improve this? Of course, with giving more. And the most important thing is reduce the inflammation. all the drugs we spoke about, say lifitegrast, your cyclosporins, and the resveratrol, and omega-3 improves the vitamin D receptors. So improve the vitamin D receptors, give the injection or tablets, it works very well. That is the way we have to treat the vitamin D deficiency. So it's a simple image here will probably, and the problem is it's very difficult to look at the vitamin D receptor, because receptors, or you have to look at the protein secreted out, but the best way to look at what we do in a purely academic setting is conjunctival impression cytology, but it's not easy and it's not possible at all. Like if you want to do it on a child, strictly no, because you have to put a BCL and all that. So resveratrol increases it. What else increases it from orally?
Genistein.
But we don't have
We
genistein.
don't have.
I'm talking about what is available in the omega-3.
Omega-3 would do.
So for example, you see this here, it's knocked off. That means whatever vitamin D I give them, it's knocked off. But minute we give resveratrol or lifitegrast or trehalose increases it. Taurine increases it. They're all autophagy inducers, which reduces even Optiv hydration, Optiv medication. Optiv helps in osmolality, and that increases it. And Optiv, and these things increases this. Now we have space for the receptor. So this is the benchmark of how you work on the vitamin D.
So we
go back to this. This slide is important about what resveratrol does.
Its primary action is via this modulation, but you can see the amount of beneficial effects you get is enormous. So it goes through a series of signaling pathways, but this is its primary modulator. So it is a very versatile agent if you have understood it well and at the appropriate concentration. And at NN, we have shown a few things here. So in the presence of any kinds of stress, this is epitheliopathy, this is inflammatory onslaught on the surface, this is abnormal collagen remodeling, and of course we just talked about vitamin D receptors. All these things happen to the cells, including your HCEs, that is epithelial cells, fibroblasts, and all of them, if you have these stress. But resveratrol is going to stop this. It prevents epitheliopathy, it reduces the inflammatory factor levels, improves favorable collagen remodeling. And we say this based on evidence here. So you could see here, the green color which you see here is because of increased ROS. Oxidative stress is the main thing. The moment you had resveratrol, the green color drops down. So this resveratrol work is primarily done by Dr. Debashis Das, who's sitting at the end there. And you could see that there is a reduction in oxidative stress. With reduction in oxidative stress, you get enormous effort in reparative response. You could see hydrogen peroxide is also reduced. We look at more than one way to prove that what we are seeing is not an artifact and whether that is in fact beneficial to the cells. We have already looked at the vitamin D receptor, and then we also looked at the importance of inflammation or inflammatory stimuli. TNF-alpha increases your classic inflammatory.
Only big disclaimer here is the dosage.
Dosage, yes.
This works very well, but this is again, we know it works biologically, but what dosage, it's a challenge to study. But if you take a resveratrol, you do see them in the tears. That means that it is reached there.
Bioavailability is there.
If it's reached, that's a surrogate marker. For example, if you take it orally and then you take the tear film and then you check the resveratrol byproducts in it, and if it's there, that means it's reached there. And we see both reaching there. So if it's reaching there, then these things work. But it depends on your own metabolism. Everybody's metabolism is different, and sometimes if it's not reached, then it may not reach there. But sum up on this, the most important thing for me is if you want the vitamin D to work well, then this is one way of looking at it. And the second is, it's an anti-aging drug. Everybody knows about it, but there are certain really good ways in which even this shows that it builds collagen. So that means it does have in children who are prone for eye rubbing. If they're prone, go back to that slide, please. Not this. Yeah. Yeah, you can see that it does have a lot of work on collagen matrix itself. So that means that it is changing the collagen for good. That much we know. Any questions on this? So this is, like I said, it depends on how your belief, but I use it more for people who are on vitamin D or post-refractive surgery. And one thing which is interesting is in the last 3 days, people who are with us in the VORS, we spoke a lot about alpha SMA, and this is something which causes all your fibrosis, cross-linking. And fibrosis is also driven by the vitamin D, both of them. So if there's one drug which does both, direct has an effect on the alpha SMA and TGF, plus it has an act on fibrosis through vitamin D. That means it does have a role. So we have to give somebody something when you see a scarring. So when you see a scar, PRK is cross-linking. So that means that, or in a chronic scar like losartan, losartan also works on the same pathway. So this also has, this has orally, but tomorrow somebody looks at it from a drops format, then this, I think, has a very good role in modulating a lot of factors. So this, I feel, is something which should be, is something which you should think for the future. Omega.
So there's a lot of clinical trials which has been done. On the oral front, the best one ranges between 100 to 500 mg per kg, I think. So they've done quite a wide variation, and they found a safe, effective dose without adverse effects. All the clinical trials put together. Yeah. But not for topical. Yes, please.
I see an increased role for this because what we're looking in the systemic conditions in the body, if you have vitamin D without vitamin K, it leads to buildup of calcium in the body. So many of our patients who are given a lot of vitamin D, I tell them the store is your liver. It's like a bank. You got the dollars there. You don't got the Korean dollars. Nothing is going. You're not going to get your Samsung phone, right? So the K is important, and there are vitamin K receptors in the eye. So with the vitamin D, you start generating the MGPs and the other things, and without the vitamin K, it won't work. So what role this plays here is that you take those patients off their vitamin D, so that the liver is not this thing, and instead you give this. The oral is not required, the systemic is not required, the drops are there, and they will increase the uptake of the vitamin D. So that makes more sense in patients with systemic disorders, and you can take away their vitamin D supplementation, probably by adding that.
So, and also, many times when we speak about any of these vitamins and how it works, it has to be in the context of the receptors. Receptors get damaged because there is inflammation. See, omega-3 also has, we have seen this many factors. We'll run to, can we go to the, yeah, please.
Dr. Rohit, does the fact that vitamin D is fat soluble make a difference to the way in which the formulation happens?
Could be.
Do you need to also, in addition to a receptor, include a substance that will dissolve the vitamin better, for it to reach the receptor or get accepted better?
See, what we have seen is, we did this experiment where we divided people into low vitamin D and moderate vitamin D. And we took the conjunctival impression cytology of these patients, not patients, these were our local staff, because we could get the receptors. So when you give an intramuscular dose of vitamin D, a bolus, the receptors increase suddenly. And orally, it took long time, but it was more sustained. That means intramuscular increased, but it was not sustained. So you give an intramuscular, sustain with oral, and then the receptors, and then take care of them with resveratrol and other anti-inflammatory. That would be the way the vitamin D has to be managed. But when you do not do that, and you keep it only with just orally, it takes a longer time, and it takes longer time. How did we do it? We measured the vitamin D receptors for more than 30 people. And this is very important, because we are talking about it now here. You can see that this is the vitamin D receptors. This is from my colleagues in the hospital who had deficiencies, and your intramusculars and oral. And you can see that you can explain this. So you can see that there is some totally change in the way the vitamin D would function based on quickly.
So this is vitamin D supplementation between intramuscular and oral. You could see there is a steady increase. These are the medians over there. There is a steady increase in vitamin D receptor in both oral and intramuscular, and there is a steady reduction in basal inflammatory, systemic inflammatory factors like IL-6 and TNF-alpha, as well as a little bit of MMP9. So it is effective. It is bringing down systemic inflammatory status down, not suppressing it. It just brings it down a little bit and also improves the vitamin D receptor, because it is known that the vitamin D induces the vitamin D receptor expression.
You will explain?
So we were comparing between intramuscular and oral, and we
go.
were seeing this particular patterns.
So now that Dr. Shyam is getting ready for the keynote lecture, but this is exactly the way I think vitamin D works. And this is exactly what she was speaking about, the role of it in, say, chalazions or any of those things. You can see that that box is very important. So,
Tears also.
and this is from the tears also. I mean, both ways, both the cytokine and tears show the same factors, that intramuscular works very fast, but it's not sustainable. It will drop down immediately, the receptors. Shehan, this is how you do the conjunctival impression cytology of the con. We use the I-prim, and it works very well because it has a filter paper in it. And you take that from the cornea or the conjunctival area, and then we run we can do an mRNA isolation and do the process. Shyam, we are ready for the session, and then omega-3 I'll finish after the keynote. Any questions till she getting ready? Yes.
What's your thoughts about the new anti-evaporative treatment, hydroxyperfluorocarbon, the MIBO eye drops that's coming from Bausch & Lomb?
Not used it. I have not got access to use it. When it comes, maybe we'll try out and let me know. I mean, it shows promise, but I can't comment on.
Thank you.
Can I give a gentle comment? This is not new. It is already available in Europe in other names.
Yeah.
It has been used before, and it works very well. And I think it will be an add to our medications, because
we're going to have it soon in the UAE.
It will come soon, yes. But it is, as a concept, it's not new. It's been there in Europe for a very long time.
But people, they complain of it, the people in Europe. I don't know, they did something to the formulation, make the drop very small. Maybe that changes.
I don't know about this.
Can I have a comment, please? Just one comment regarding patients with recurrent chalazion. I think there are multiple reports in the literature that one of the most common incriminating factors is Demodex. So in my practice, patients with recurrent chalazion, I always do a eyelash microscopy to rule out Demodex. And as far as the IPL treatment for Demodex is concerned, even in the depth trial which evaluated lotilaner eye drops for the FDA approval in the USA, even they have mentioned IPL as an adjunct treatment for Demodex. So it does have a role, but I think it is still important to, to find out if Demodex is there or not and treat it accordingly.
So, Dr. Shyam,
Yes,
you're ready?
yes. I have a case
Yes. And we move on to the keynote lecture of today, the hidden science of dry eye formulation by Dr. Henry Schubert from France, the founder and director of, chairman of TIA Labs. And like I was telling yesterday, his father discovered the BAK, and he discovered the preservative-free drops. They were the first to make a preservative-free drops in the world. And we're very fortunate to have you here, sir. I think Dr. Shafiq will do the official introduction now.
Good morning, everybody. Please, Mr. Henri Chebret, can you come here to the podium? We have to applaud this man. In the name of Deoss, I have the honor to honor and celebrate not a man, he's a legend in the field of pharmaceuticals and industry dedicated to the ophthalmology. We're actually honoring 3 generations in the name of Mr. Henri Chebret. And they are now 5 generations. I got to know this now. 5 generations of dedication to pharmacy, to science, and to ocular surface in particular. A man, he is in himself 5 generations together, dedicated to this, to the refinement of pharmaceuticals. May I invite also Professor Beatrice Kostner to the podium? Because those in the audience who know this man are many. And you know this man in the form of every single eye drops that we have used for the 5 generations. Mr. Henri Chebret is a moving legend, because of that, we are commemorating him. Maybe the Legion d'honneur he's having is one that is given to the head of the states and to the innovators. This is, I got to know, from the French government. I leave the microphone to the president of Deoss, Dr. Sam Lazareg, to talk about him.
It's really my pleasure and honor to introduce Mr. Henri Chebret. We cannot talk about ocular surface without mentioning his name. His 5th generation of dedication to ophthalmology. The grandfather created the French Society of Ophthalmology, and please, Professor Marc Labetoul join us as the secretary of the French Society of Ophthalmology. The grandfather created the French Society of Ophthalmology. In the family, the uncle created the YAG laser. Henri's father created the preservative, and he was behind the benzalkonium chloride in the eye drops. And then Henri Chebret, 30 years ago, was behind the preservative-free. He created TEA 30 years ago, and he was behind, I will show you, this is the legacy. You see, all the Chebret, this is the Chebret family. They created many societies. It was Chebret. They created, the grandfather or the grand-uncle created the first ointment in ophthalmology. And I was telling to Henri and to my friends that in Algeria, all the grandmothers, the oldest people, for them, all ointment in ophthalmology is Chebret. Whatever it is they created the first ointment. It was penicillin. It was the first antibiotic, the first ointment in the history. This is the grandfather of Henri. And then, as you see, and they know all the history that he will say to you, how we started from nothing, and then with time we had the bottles, the glass bottles, and then the plastic bottles, and then the preservative, and then the preservative-free. Then, as you see, he created also many other companies. He was with Merck, and he's the 4th generation, by the way, and this is his brother, and he created another society, Transfito, and then he is the inventor of the ABAC, A as eye privative, BAC, benzalkonium chloride. This bottle is a technology in itself, and it was the first preservative-free bottle, and he is the inventor. Then I think this is Henri Chebret. And this is the 5th, Jean-Frédéric Chebret is the 5th generation, and he is now the CEO of TEA, and they are still innovating. And as you see, they are in allergy, anesthesia, antisepsis, in every field in ophthalmology, they are here, and they are still innovating and still creating for us many and many new products. And behind that, we have also a loyal, a very generous, and a very, very funny guy. For me, is as a father, a brother, and a friend. Please, a standing ovation to Henri Chibret.
Perhaps if you can name a single name in the field of industry who benefited the field of ocular surface in the world, you can name Henri Chibret. He is the man that most known to benefit this field in the form of pharmacology and industry. So because of that, we are honoring this man today. We can give him a lot of applause for this, and we will listen to a legend through his lifetime and the lifetime of his family. I may give also the microphone to my friends, because you can talk few words for Mr. Henri Chibret.
I think that I'm first of all a French, so proud of Thea, because I think that if there is something that for once we can bring around the world, it's definitely all the product that Thea has made. So on behalf of France, thank you to Thea. And I think that according to what I've seen, along these few days, regarding the values that you are defending so hard here, in one single guy, you are summarizing everything that we are looking for. You are representing science, humanity, culture, and heritage. So I think that you got here the values in one single great guy. No, please. And of course, on top of that, as you see here, it's humility. And humility in science is definitely what you need also to keep in mind. Thank you for everything that you've done. And you know that you have, again, 100 years to accomplish in front of you.
Thank you.
And as the General Secretary of the French Society of Ophthalmology, I would like to thank you, Mr. Chibret, for all what you did for the ophthalmology throughout the world. And you made the French ophthalmology shining a little bit more, thanks to you. As a doctor, I would like to thank you, Mr. Chibret, as well, for all what you did. And you provided one of the first, bag-free bottle. I remember I was a resident at that time. I was impressed by the idea and by the technology. And as a human, I would like to thank you, Henri, for your kindness. You are somebody very special. And this is an honor to me to know you and to share with you some time.
Thank you.
Thank you so much.
And I will say some last word. As an ophthalmologist, I have to thank your previous idea of back-free eye drops. And as a friend, I would like to add, this man is incredible. He's a genius in ophthalmology. He's historic, encyclopedic knowledge of all the world history. And he has a passion of art we share together. Art contemporary is a very complete man. As you say, his heritage, culture, humility, and transmission. So thanks a lot to be who you are.
We forget something very important to know. For the YO, you are the only laboratory, even for Europe, to defend the young generation. You are providing grants, and you are devoted to charity. So some things that we can also celebrate, because it's really uncommon to have the industry working for free to defend the YO. Thank you for that.
And I just add a small trivia here. His family also helped Michelin star, and they were one of the biggest supporter of, they had a big share of Michelin when Michelin was introduced. So when we had dinner with him on the day one, he liked the dinner very much here. He called the chef and I said, I'll give you 1 star. He did not understand what he meant. I mean, he knows Michelin. Then I said, he's the family who gave Michelin to the world.
I hope that you can give me a Michelin star also.
Let's work.
We're eager to listen to you, Mr. Henri. Please, the mic is yours.
Est-ce que j'appuie là? Oui. Okay, and I can back here. Yeah.
Non. Là?
Oui.
Vous avancez toujours.
Well, it's a lot of emotion. I like compliments, but they are too much today. And I would like first to congratulate CM and all the board for the organization of this very interesting symposium. And also I would like to congratulate Professor Shetty. I know that you have a worldwide reputation, but the first time I am coming here and I could see this is reality. Thank you for all the publications you are doing, for the incredible equipment we have seen, and we must applaud it. So I am 85 years old. Nobody is perfect. But it gave me the, I could see all the evolution and the revolution of the last decades. Of course, new molecules, you know better than I do, surgical tools, optical devices, diagnostic tools, and we have seen many examples here in Bangalore. But today I would like to speak about something else, which is the how we develop eye drops. This is a topic which is not very frequently mentioned. And there have been many revolutions in this pharmaceutical field. The first revolution concerned the containers. For many centuries, ointment were used, but extensively in the first half of the last century, with a huge campaign in trachoma, where penicillin eye drops, but ointment were used extensively. Later on came azithromycin tablets, which replaced the ointment, and also I developed azithromycin gel, which is used in some campaigns of trachoma. Ointment were easy to manufacture, they were cheap, but the patients didn't like it too much. And I remember the children in the trachoma campaign, they didn't like it at all. It's greasy, it's not easy. There was some attempt to develop a glassware bottle, but it was fragile, expensive, handmade. And the first revolution came with the penicillin dropper in glassware. But it was not sufficient. The plastic bottle came in the 50s with a lot of difficulties because the plastic were full of impurities. But nevertheless, this has become the standard unit today. The next step was the unidose developed in England. They were at that time very expensive, but today with special equipment, we could go lower the cost. And the last revolution has been, of course, the preservative-free in 1995, yes. So today you have a lot of containers. You have plastic, bottle, you have glassware, you have injectable, and recently you have what we call dropless medication, which is you instill into the eye sustained release steroid. And you have also insert for mydriasis. The second revolution has been the control of method of control. And it started with a thin layer chromatography in the 50s, 60s, and which give you some 2 or 3 spots. This is a spot of pilocarpine. When my father discovered that pilocarpine was not stable, there was pilocarpol and pilocarpine, he decided to lyophilize pilocarpine. And later on, by changing the excipients, he could stabilize and have a good tolerance pilocarpine. But thin layer chromatography was not very accurate. The big revolution, which have changed anything in the industry, is the HPLC, which give you very accurate information on impurities and on the active ingredient. I will come back later on. And more recently, mass spectrometer, which is a very expensive machine, and there are two machines in Bangalore, cost 500,000 euro? 7, okay, which give you more detailed information on identification of the impurities and also on some micro content. So HPLC is, I'd say, is a passport which is used all along the development and later on manufacturing. Oh, okay. The third revolution has been preservative-free eye drops. My father introduced mercury derivative in 1950. It was very active, but it provoked allergenic reaction, dermatitis of eyelids. So he asked the chemist of the company, can we replace it by something more active, less... As I say, well, why don't we use detergent used in washing machine, for instance? And BAK was introduced, it was active, but little by little it came that if it is detergent, it's good for the bacteria, but it's not so good for corneal and conjunctival cells. So 10 years, no, 20 years later, I launched ABAC, which was the first preservative eye drop. It took about 10 years to develop this device, and today I think there's most of the new eye drops are preservative-free. And there is an excellent paper from Professor Baudouin about preservative, the good, the bad, and the ugly. So how we do develop? The first step, the first step is to choose the active ingredient. You must know that there are many producers. It's your point? No.
I think if it's something.
But with different qualities and different products. So you must carefully choose the producer. Why they are different? First, they use different starting materials. And that's for patent reason, for other reason. And these starting materials don't have always good quality. Then you are going to use different reactors. And so finally, you don't have identical raw material, and you have different impurities that HPLC give. This is an example, for instance, of latanoprost HPLC. Not only you have the big peak, which is latanoprost, but impurities. You cannot avoid impurities. Authorities accept impurities if it is a low dosage, and if you can quantify and qualify each impurities. And you must keep this level of impurities all along the life of the product. You cannot change from one batch to another. So you must have a very reliable producer. So once you have selected the active ingredient, you have to make the choice of excipient. Excipient represent 90% of the formula. And this is, again, a challenge. Why the excipients are very important? For instance, in the case of latanoprost, it has been, we could solubilize the product, stabilize the product, and this is very important for tolerance and biodisponibility. Also, we have this problem of content-container, which I'm going to explain. So excipients are also different. We have to make the choice of we make the choice of the highest pharmaceutical quality and also, this is very important, reliable supplier. And also, we have to make some tests with animal models or cells models in order to evaluate the biodisponibility and the tolerance. Then, once you have a formula, a solution, you must choose the best containers. And this is a plastic bottle, glass bottle, single dose, tube. And again, you must select the most reliable plastic or glass supplier. And you will understand later on why. We must select only pharmaceutical quality material and reliable producer again. Why it is important to select a reliable producer of plastic? Because there is a migration of the solution into the plastic, but also migration from the plastic into the solution. And I remember when my father developed the first plastic bottle, that was a major problem. Plastic release a lot of impurities. So this has to be evaluated. And also something maybe you don't know is the migration of the plastic and the glue of the label into the bottle. And this is HPLC again has allowed that to study. And more recently, we know that the printing ink of the box can also penetrate into the bottle. HPLC, thank you, and mass spectrometry too. Once you have finished the development, you must do long-term stability, 2 or 3 years, and at various temperatures, from minus 40 to plus 40, depends the territory. In Sweden or Canada, we don't have the same requirement that in India or other countries. And you must calculate the shelf life and also the expiration date after opening the bottle. Then there is something which has been always a problem, is patient comfort. You have patients who complain to you, it's difficult to squeeze, it is difficult to expel a drop, and we have different equipment for evaluating, for example, unscrew the first opening. Sometimes it's difficult for the patient. We have also to squeeze, we have to calculate the strength for pressing and also the size of the drop. So this, okay. So at each step of the development and later on of manufacturing, we will have to do HPLC and other control. And then we have to select the best container. But today I'm not to speak about manufacturing. It's another problem, especially sterility for non-preserved eye drops. And also the scale-up. When you develop eye drops, you have maybe 1 or 10 liters, and you have to scale up to 600 or even more. So that raises problem of manufacturing. So in conclusion, I will take again the latanoprost example. Syntheses are different from producer to another one. Excipients are different from the one, and containers. So you have difference in terms of tolerance, penetration, stability, and activity. Now, you know that many eye drops are still preserved. Why it is difficult? because you have to do a lot of studies to justify to get rid of the preservative. But I will show you in a 2 minutes movie the example again of Latana Prost. Okay, that's the end. Thank you very much.
Thank you, Henri. And on behalf of Deoss, please, Dr. Shetty, can you come? Yes.
I'd like to request Dr. Jyoti Shetty, who has been a senior glaucoma person from Karnataka, because I think you are the one of the people who can understand how what he just spoke changed the way we practice. Our President-elect, Dr. Brandari, who's in a new avatar today. Come.
when I was at the army, they don't have helmet for my size. So I could do the military exercise because I didn't have the helmet. And today it's again the king size, but
It's okay, it's okay.
anyway, thank you so much. It's a major honor, and thank you.
We now break for coffee for 15 minutes. The coffee is served at the second floor, right? Let's go up and we'll be back by 11:35.
Viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface. Causes of dry eye with better efficacy and tolerability through advanced delivery system, Nextane, the next generation sodium hyaluronate eye drops. Dry eye disease, DED, is a multifactorial condition that affects millions worldwide and is increasingly recognized as a significant public health concern. It results from an imbalance in the tear film, leading to ocular surface inflammation and damage. Despite being common, it is often underdiagnosed and undertreated. Introducing Nextane, sodium hyaluronate, 0.1% ophthalmic solution for the management of dry eye disease. Nextane from Microlabs is formulated with the advanced Novelia bottle system, an airless, preservative-free technology that ensures sterility, precise and consistent dosing, and eliminates the risk of contamination. This innovative packaging provides extended shelf stability without preservatives, safeguarding both efficacy and ocular health. Nextane's unique formulation combines the hydrating power of sodium hyaluronate with a targeted blend of 4 essential amino acids: leucine, lysine, proline, and glycine. This combination not only provides immediate lubrication, but also supports the natural healing process of the ocular surface. Patients using Nextane experience longer-lasting comfort, reduced frequency of installation, and improved tear film stability, allowing them to go about daily activities with fewer interruptions from dry eye symptoms. Sodium hyaluronate-based eye drops, like Nextane, may also serve as an effective alternative for patients who do not respond adequately to carboxymethyl cellulose or other conventional lubricants. The unique features of sodium hyaluronate eye drops includes that it binds naturally to mucins on the ocular surface, increasing residence time and tear film stability. Dual action viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface cells. Clinical studies demonstrate sodium hyaluronidate's superior efficacy in improving tear film stability and significantly reducing dry eye symptoms. Nextane, sodium hyaluronate 0.1% ophthalmic solution, offers the patients with DED a comprehensive, preservative-free solution that provides outcomes beyond temporary relief. Nextane addresses the underlying causes of dry eye with better efficacy and tolerability through advanced delivery system. Nextane, the next generation sodium hyaluronate eye drops. Dry eye disease, DED, is a multifactorial condition that affects millions worldwide and is increasingly recognized as a significant public health concern. It results from an imbalance in the tear film, leading to ocular surface inflammation and damage. Despite being common, it is often underdiagnosed and undertreated. Introducing Nextane, sodium hyaluronate, 0.1% ophthalmic solution for the management of dry eye disease. Nextane from Microlabs is formulated with the advanced Novelia bottle system, an airless, preservative-free technology that ensures sterility, precise and consistent dosing, and eliminates the risk of contamination. This innovative packaging provides extended shelf stability without preservatives, safeguarding both efficacy and ocular health. Nextane's unique formulation combines the hydrating power of sodium hyaluronate with a targeted blend of 4 essential amino acids: leucine, lysine, proline, and glycine. This combination not only provides immediate lubrication, but also supports the natural healing process of the ocular surface. Patients using Nextane experience longer-lasting comfort, reduced frequency of installation, and improved tear film stability, allowing them to go about daily activities with fewer interruptions from dry eye symptoms. Sodium hyaluronate-based eye drops, like Nextane, may also serve as an effective alternative for patients who do not respond adequately to carboxymethylcellulose or other conventional lubricants. The unique features of sodium hyaluronate. Eye drops includes that it binds naturally to mucins on the ocular surface, increasing residence time and tear film stability. Dual action viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface cells. Clinical studies demonstrate sodium hyaluronidate's superior efficacy in improving tear film stability and significantly reducing dry eye symptoms. Nextane, sodium hyaluronate 0.1% ophthalmic solution, offers the patients with DED a comprehensive, preservative-free solution that provides outcomes beyond temporary relief. Nextane addresses the underlying causes of dry eye with better efficacy and tolerability through advanced delivery system. Nextane, the next generation sodium hyaluronate eye drops. Dry eye disease, DED, is a multifactorial condition that affects millions worldwide and is increasingly recognized as a significant public health concern. It results from an imbalance in the tear film, leading to ocular surface inflammation and damage. Despite being common, it is often underdiagnosed and undertreated. Introducing Nextane, sodium hyaluronate, 0.1% ophthalmic solution for the management of dry eye disease. Nextane from Microlabs is formulated with the advanced Novelia bottle system, an airless, preservative-free technology that ensures sterility, precise and consistent dosing, and eliminates the risk of contamination. This innovative packaging provides extended shelf stability without preservatives, safeguarding both efficacy and ocular health. Nextane's unique formulation combines the hydrating power of sodium hyaluronate with a targeted blend of 4 essential amino acids: leucine, lysine, proline, and glycine. This combination not only provides immediate lubrication, but also supports the natural healing process of the ocular surface. Patients using Nextane experience longer-lasting comfort, reduced frequency of installation, and improved tear film stability, allowing them to go about daily activities with fewer interruptions from dry eye symptoms. Sodium hyaluronate-based eye drops, like Nextane, may also serve as an effective alternative for patients who do not respond adequately to carboxymethyl cellulose or other conventional lubricants. The unique features of sodium hyaluronate eye drops includes that it binds naturally to mucins on the ocular surface, increasing residence time and tear film stability. Dual action viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface cells. Clinical studies demonstrate sodium hyaluronate's superior efficacy in improving tear film stability and significantly reducing dry eye symptoms. Nextane, sodium hyaluronate 0.1% ophthalmic solution, offers the patients with DED a comprehensive, preservative-free solution that provides outcomes beyond temporary relief. Nextane addresses the underlying causes of dry eye with better efficacy and tolerability through advanced delivery system. Nextane, the next generation sodium hyaluronate eye drops. Dry eye disease, DED, is a multifactorial condition that affects millions worldwide and is increasingly recognized as a significant public health concern. It results from an imbalance in the tear film, leading to ocular surface inflammation and damage. Despite being common, it is often underdiagnosed and undertreated. Introducing Nextane, sodium hyaluronate, 0.1% ophthalmic solution for the management of dry eye disease. Nextane from Microlabs is formulated with the advanced Novelia bottle system, an airless, preservative-free technology that ensures sterility, precise and consistent dosing, and eliminates the risk of contamination. This innovative packaging provides extended shelf stability without preservatives, safeguarding both efficacy and ocular health. Nextane's unique formulation combines the hydrating power of sodium hyaluronate with a targeted blend of 4 essential amino acids: leucine, lysine, proline, and glycine. This combination not only provides immediate lubrication, but also supports the natural healing process of the ocular surface. Patients using Nextane experience longer-lasting comfort, reduced frequency of installation, and improved tear film stability, allowing them to go about daily activities with fewer interruptions from dry eye symptoms. Sodium hyaluronate-based eye drops, like Nextane, may also serve as an effective alternative for patients who do not respond adequately to carboxymethyl cellulose or other conventional lubricants. The unique features of sodium hyaluronate eye drops includes that it binds naturally to mucins on the ocular surface, increasing residence time and tear film stability. Dual action viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface cells. Clinical studies demonstrate sodium hyaluronidate's superior efficacy in improving tear film stability and significantly reducing dry eye symptoms. Nextane, sodium hyaluronate 0.1% ophthalmic solution, offers the patients with DED a comprehensive, preservative-free solution that provides outcomes beyond temporary relief. Nextane addresses the underlying causes of dry eye with better efficacy and tolerability through advanced delivery system. Nextane, the next generation sodium hyaluronate eye drops.
Rescue and structural restoration. The moderator for the session is Dr. Serge Dion.
Dry eye disease, DED, is a multifactorial condition that affects millions worldwide and is increasingly recognized as a significant public health concern. It results from an imbalance in the tear film, leading to ocular surface inflammation and damage. Despite being common, it is often underdiagnosed and undertreated. Introducing Nextane, sodium hyaluronate, 0.1% ophthalmic solution for the management of dry eye disease. Nextane from Microlabs is formulated with the advanced Novelia bottle system, an airless, preservative-free technology that ensures sterility, precise and consistent dosing, and eliminates the risk of contamination. This innovative packaging provides extended shelf stability without preservatives, safeguarding both efficacy and ocular health. Nextane's unique formulation combines the hydrating power of sodium hyaluronate with a targeted blend of 4 essential amino acids: leucine, lysine, proline, and glycine. This combination not only provides immediate lubrication, but also supports the natural healing process of the ocular surface. Patients using Nextane experience longer-lasting comfort, reduced frequency of installation, and improved tear film stability, allowing them to go about daily activities with fewer interruptions from dry eye symptoms. Sodium hyaluronate-based eye drops, like Nextane, may also serve as an effective alternative for patients who do not respond adequately to carboxymethylcellulose or other conventional lubricants. The unique features of sodium hyaluronate eye drops includes that it binds naturally to mucins on the ocular surface, increasing residence time and tear film stability. Dual action viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface cells. Clinical studies demonstrate sodium hyaluronidate's superior efficacy in improving tear film stability and significantly reducing dry eye symptoms. Nextane, sodium hyaluronate 0.1% ophthalmic solution, offers the patients with DED a comprehensive, preservative-free solution that provides outcomes beyond temporary relief. Nextane addresses the underlying causes of dry eye with better efficacy and tolerability through advanced delivery system. Nextane, the next generation sodium hyaluronate eye drops.
Dr. Radhika Natarajan and Dr. Shushmita Shah.
Okay, so We are going to begin a new session on ocular surface reconstruction, surgical rescue, and structural restoration. I guess the first presentation is cancelled. Am I right? Okay, so François Majot. Where is François? Okay, so we will begin with François Majot from Lausanne. How to manage stem cells deficiency in aniridia. Thank you, François.
Thank you, Serge. I would like to thank the organizer, Professor Chetty, Professor Lazreg, and Professor Mohamed Shafik for inviting me, and I'm really pleased to be here. It's a wonderful congress. So my purpose is, if I succeed in my presentation, just to open a little door in your mind about a strong dogma that is in our field, and just to tell you a story about aniridia-associated keratopathy and how to manage it according to what we know today. So the consensus today is that aniridia-associated keratopathy is a Lambel stem cell deficiency. And if you look to the last publication of a panel that is following this disease, it has been classified in congenital aniridia as a hereditary Lambel stem cell deficiency. What are the therapeutic options? Today, when we see this kind of patient, with a total destruction, opacification, and neovascularization of the superficial of the cornea, we based our logic and our approach to the fact that there is no stem cells remaining, with no exception, because all the stem cells are located in the limbus. So, according to the model we use, we claim that, in fact, the cornea becomes opaque because of no stem cells or migration of conjunctival cells with chronic ulcerations, change in the final differentiation. What are the therapeutic options? You can do a PK. As you know, the result will not be very good for the long follow-up. You can do lumbal allograft with a PK and amniotic membrane. It works, but not for a long time. And lumbal stem cell culture with penetrating keratoplasty, not so many data on that. You can do a Boston keratoprothesis. That is a possibility, but it's also an issue with time. You can do a DALC, but you have a problem of rejection. And you can do a lambodalc, that is a special technique. Now, if you go in molecular biology, and we are here with a group that is very focused on that, as you know, aniridia is related to PAX6 deficiency, but there is also NOTCH1 that is involved, and PAX6 is involved, this locus is involved in 90% of aniridia. But PAX6 is also regulating another gene that is important. It is NOTCH1, and NOTCH1 is involved in neurogenesis, and it is downstream to PAX6. You will see why it's important to focus on that, because, in fact, NOTCH1 has been analyzed in human samples in aniridia, and they found, looking for different pathways, that in aniridia, NOTCH1 is downregulated in human. In human, if you look with an OCT, the cornea, you can see that you have a normal stroma in aniridia, and you have a neostroma, according to the fact that there is also PAX6 that is missing, but NOTCH1 that is downregulated. Now, if you go to animal model, in fact, we published a few years, 17 years ago now, a model of downregulation of NOTCH1 in mice. It's a model where the mice were born with the gene, and you can downregulate it using a Krelok system that is, I cannot go further in this presentation. But if you look at the cornea of these mice with time, you can see that they have a huge scar with a cornea that becomes completely abnormal. And they have an hyperplasia of epithelium with a stroma that is abnormal and a normal stroma below. And because the gene is downregulated in the epithelium, you have a wrong crosstalk between the epithelial cells and the stroma. And you have made the connection between the human disease and the mice disease. It means that the crosstalk is not working properly in this mice, but also in human. It's what we can, what we can think about the mechanism. So according to that, I was working on my cases of aniridia. And I was thinking that perhaps we can just remove the neostroma and the penis as a first stage. So I was using a laser or a microkeratome. And removing it, after that I get a stroma with no cells, so I had to put cells on that. But because there is no stem cells in an area, and it's a model of when there is no palisade of Vogt, so according to a model today that is used, there is no remaining stem cells. So performing a SLET, a simple lumbar epithelial transplantation, that has been published by Sangvan, is impossible. So I decided to take conjunctival cells and call it a SET, a simple conjunctival epithelial transplantation. So, in fact, I did the same thing. I've removed the penis, and I harvest the conjunctival cells. I split the sample in 15 pieces, and I put it with fibrin glue and a contact lens. I get one patient and 2 eyes, but I have more now and other techniques, but just to presenting this case. So it's very advanced aneurysm with nystagmus. And we looked for the expression of cytokeratin and cytokeratin 3 and 12 that are specific for epithelial cells, corneal epithelial cells, were missing. And it was conjunctiva. Now I have 4 years follow-up for the right eye and 2 years follow-up for the left eye. So the patient was really dependent and could not move on his own. And after the surgery, now 4 years and follow-up in the right eye and 2 years, he could improve his vision. He has, of course, an amblyopia, and the cornea remains transparent. He has to live with contact lenses, soft one, but we change each month, because if he doesn't have it, he will have a complaint with the surface with time. So if you look for the positive results as curing lumbal stem cells, we had no conjunctivalization back, but we haven't checked the immunostaining. We had no persistent recurrent epithelial defect and nevascularization. Inflammation was low, and scarring was not back, and the comfort on the vision was good for the patient. So does it mean, usually when we have a dogma and you have cases that are not working properly with a theory, this is what a French physiologist said: when we meet a fact with contradict a prevailing theory, we must accept the fact and abandon the theory, even when the theory is supported by great names and generally accepted. Just now, why thinking out of the box? I will open a bit the discussions. So we have this narrative that all the stem cells are in the lambus, and they are migrating like that with another flow above. We have published now, a long time ago, 17 years ago, a paper where we were able to look for stem cells in vitro or in vivo. This publication was in Nature, and we found stem cells, a huge number of cases, in vitro using a clonal analysis in 5 different kinds of animals, of mammals. And in human, we found marrow clones that are cells that can divide a lot. This was ex vivo. Now, if you look in vivo, the way to demonstrate the presence of stem cells has been demonstrated by 2 researchers in Canada, Tills and McCulloch, and they did that in the 60s. They got a prize. They were the first to demonstrate the existence of stem cells ever. It was the key demonstration. And they used serial transplantation. What have they done? They took the blood of a mouse, and they inject the blood in a mouse that has been irradiated. So the cells were able to repopulate the bone marrow and create a new blood. After that, they harvest the bone marrow, and they put it in a second recipient, then a third recipient. It's a serial transplantation. It's how they demonstrated the presence of stem cells in vivo. In fact, we did the same in the mice, and we did serial transplantation. It means we got a first donor. We harvest the central cornea that has no stem cell theoretically. We put it in the lambus, we perform a wound, cells were migrating, so we could follow the cells with a graph with in blue. And we harvest the central cornea, we put it in a second recipient, and we could see that it could repopulate the cornea. So these central cells have a huge power, as you can see, and we can use it in a clinic in a way. So our model is that there is stem cells everywhere, also a lot in the lambus, but there is another flow, and the change in the differentiation is not a problem of stem cells, it's a problem of microenvironment. Just to tell you that today, most of the literature is using animals that have stem cells in the central cornea, according to our model, but we are still living like that for years with many data. So just as a narrative, do you have to change the narrative? I'm a bit long, but just it's important for you to understand why I'm there. Just this is Bruce Lipton, he's an American biologist, and he's the first that was talking about epigenetics. He's speaking 3 minutes.
Bonsoir.
So you understand the result. The result is that from one cell, you can do different cells according to the microenvironment. I just finished now in vivo. We were able to, not me, but the lab I was working with, they were using adult samples like lambus cornea and conjunctiva. They put in embryonic skin using a special surgery with pregnant mice, and we could follow what the cells were doing. And you can see that taking these 3 samples, they were able to find hair follicles on epidermis. It means you can change the fate of adult cells in another adult tissue. And if you see, the central cornea was able to create some follicles on epithelium. And only stem cells can do that. So just, this is another experiment showing that central cornea has a huge power. So based on fundamental biology and clinical cases, the conjunctivalization of a cornea is not a Lambert stem cell deficiency. In our view, it's a final differentiation that has changed, and the corneal epithelial stem cells that are located in the central cornea. So according to our data in Aniridia, it's a problem of crosstalk between the epithelial cells and the matrix. So you don't have to think it's only a problem of migration, that is not the case there. It's a problem of crosstalk on creating a new cornea that you have to remove, and you have to cover the surface. Now, my message is that if it was only a problem of cells, in these cases, you just have to scratch the cells, not removing the penis, and put cells, and you will have rescue the system. But it's not the case. In fact, for me, we have misnamed the disease. It's not a problem of only a stem cell deficiency. And as you know, we manage these cases doing different things. We work on systemic disease, inflammation, conjunctiva, lambus area, normalizing the microenvironment, and after that, working with transparency. And doing that, we build back the environment of corneal epithelial cell, and it's not about stem cells. We reload the system to have a normal differentiation. And if you look at all the Lambert stem cell deficiency, they have all chronic inflammation of the corneal stroma on the ocular surface. They have a loss of human privilege of the cornea and partial denervation. Almost, I have finished. It's my last 2 slides. How to rescue the transparency? So treat the chronic inflammation of the ocular surface, and we are speaking about inflammation for all these days, and I think you're right. This is the story. This is the target, nothing new. And finally, this inflammation is driving and change the cell fate. Rescue the human privilege of the cornea is very important, and rescue the partial corneal denervation, that is also important. So clinical entity, for me, that is associated corneal human privilege deficiency, partial denervation, and the switch of the corneal epithelium phenotype. And to rescue that, to normalize that, you need to increase the human privilege using TGF-beta, all the markers we have seen, alpha MSH, VIP, and diminish the fact that you have a cell-presenting antigen. And you have to create a new lambus that has a filter effect. So thank you for listening to me and to this view.
Okay, François, this is very nice presentation. I think we have one question.
Yes.
Yes, please.
Can we have the next
2
speaker?
questions.
yeah, next speaker to be ready, please, so that we finish. Dr. Shafiq, you're the next speaker.
So that is an excellent presentation. And yesterday in the evening, we were talking about neurotization cornea nerves we're taking from the sural nerve and putting it into the eye. And there are many of our cases in which the corneal opacity is regressing, going away. So the milieu that the nerve gives there to the cornea, it allows the corneal opacity to regress and disappear in some cases. So what probably does happen is that we are not only taking the nerves there. So one of the things that I was talking about, the nerves are a very important aspect there to maintain corneal transparency and the stem cells, stemness of the stem cells. So if you add your talk to what we were talking about, probably in the future we may not need to do a corneal transplant. So what are your thoughts on that?
I'm not sure I got all your questions.
You can, I think it's an echo there. You can come here, and Dr. Sunil is here. I think we can discuss here because there's an echo we couldn't hear. The one thing I wanted to add to, I mean, you were not there, so yesterday we were seeing this, one of your presentation, is the nerve growth factors need TGF-beta. It's a very important one. So when you use any lubricant which blocks TGF-beta, like this is a very, very important take-home. Like we have a tendency to use, say, a cyclosporin or not rifetigrast or any of these things, or even trehalose. So this is what we call the butterfly effect in our thought process. The smallest things make the biggest difference. The smallest thing about what to use, because for you need TGF-beta. For scarring, we don't need it. So even your lubricant you use post-surgery has an impact on the outcome. So Dr. Major, if you can come here, then you can talk to him about it.
Okay.
Mark has a question, then with quick question, then because Shafiq has to go up to do the workshop.
Very quick question for you, François. In one of your slides, you said only one cell is sufficient. Did you test it by increasing dilution of the cells you harvest from the limbus or from the central cornea before putting them in the skin of your mice to know what number of clonal cells and what number of stem cells were present in your initial biopsy?
No, we haven't done that. We just took a sample, and it's a mix of cells. As you know, it's stem cells and post-mitotic cells. However, we could assume the fact that only stem cells, to change the phenotype, you need the stem cells. The post-mitotic cells cannot change its final differentiation.
Okay, thanks.
Thank you. We have Professor Shafiq now, who's going to speak on PRP.
So a very good morning, ladies and gentlemen and dear colleagues. And I changed today the title of my slides to be PRP/growth factor intralacrimal gland injection for severe aqueous deficiency dry eye disease. It's a total new field to explore for resurrection of the dead, resurrection of the atrophied lacrimal glands in very special cases. And I hope that we can refine this with time and with perfection of the doses and the amount. Again, before I start, I would like to thank, in the name of Deoss, the board and the steering committee, our host, Professor Shetty, and the wonderful team of Narayana Natarlaya and Dr. Pooja Khmar for the excellent, more than excellent preparation, taking care of us, organization of the meeting, and the wonderful city of Bangalore, which I'm visiting for 4 consecutive years, and I'm having a lot of memories with a team that I consider them now a family. This is my financial disclosure. And before I start, I would love to advert your attention to a small piece of history. The 3 layers that we divide the lacrimal tear film is O2 1946. Wolf, one of the great physiologists in the history of ophthalmology, who defined the tear film that we have in 3 layers. And this man, thanks to him, all our knowledge comes from. I mean, even the classification, the wonderful classification of the pathophysiological spectrum, this by Deoss, is thanks to his division to the layers into a mucus, watery part, and the lipid layer. Without this classification or without this stratification of the lacrimal field, we couldn't define what we're going. And of course, you know better than me that the aqueous deficiency dry eye disease is a part of the spectrum, and the other part is the evaporative one, and no single case is 100% aqueous deficiency, except for very few cases, and the majority of them is a mix of those. To address the aqueous deficiency dry eye disease, which is a part that I'm talking today, I'd like to advert to this new classification that I would like by Professor Mark Rabitul and his colleagues that was published to define to divide the tear substitutes into 3 generations. The first, second, and third, and the first one is a wetting agent, the second is the replacement, and the third is a modulator of the ocular surface, which is the 3rd generation. Nevertheless, we are bombarded with hundreds, and I'm sure that every country has hundreds of tear substitutes, and you can't define which is which in the majority of cases. But in the severe aqueous deficiency dry eye disease that I am referring to, the case is too ugly. Like in the Sjögren syndrome, where there is no watery part secretion, and the patient is actually subjected to the real dry eye, in which it have consequences that could lead to blindness, corneal perforation, and these are the extreme cases that I am addressing now. Like Sjögren and the primary or secondary, in which the cornea and the tear film is severely deficient, the aqueous part. So you can't resort to the tear substitutes and even to the lacrimal punctal plugging, because this is for a mild to moderate one. And we have to go to the regenerative medicine. And the regenerative medicine is the future. And now it's the present, but it will be the future, and you will see that we will go to the regenerative medicine. How? Now we have in hands 3 tools, either the autologous serum, or the platelet PRP, the platelet-rich plasma, and the human umbilical cord serum, which I am intending to use, and maybe next year, but I need some regulations, because to use the fetal umbilical cord blood or serum needs a lot of regulation, even in my country. So the platelet-rich plasma, and Professor Shetty and his colleagues know better than me, is the richest source in our human body of the growth factors. You can name that. The platelet growth factor, the nerve growth factor, the transformation growth factor, the insulin-like growth factor, and many cytokines and chemokines that hundreds of them can regenerate and resurrect the dead lacrimal gland. And the beauty of it, if you prepare it well, you can have a shelf life in the freezer of 3 months. And what's the difference between this and the autologous serum is simply it is double the fold in the growth factors than the autologous serum. So at least double the fold. So you have to resort to PRP, which is much better in those cases than the autologous serum. You will be surprised that I mentioned yesterday in the session that the first mention of using a human blood into the eye was in Ebert's papyrus. You can find it in the old Egyptian museum. It's dating 31 centuries ago, 3,100 years, when the old Egyptians mentioned that you can use the blood inside your eye. And this is a piece of information, a wonderful one. They were too observant that the blood can cure. And of course, they used it for other reasons, and maybe also for dry eye. I'm not inventing what I'm doing now, because it was by Marcel Abela who did the first trial of injecting the PRP into the lacrimal gland to rejuvenate the lacrimal gland. And I followed his step in the first study with my team and colleagues in Alexandria University, and it was like a pilot study in 28 eyes of 14 patients, and we left 1 eye of them as a control, and the other eye we injected, as Marcel Abela advised, 0.4 milliliter inside the lacrimal gland of PRP freshly prepared, and we did the control. 4 injections, a monthly one. And we did the control, and we published this study in the year 2022 with the results, which were really marvelous in all aspects. In the lacrimal tear film height, in the meniscus height, I mean, in the Schirmer test, and even in the lipid layer. So the regeneration was taken apart to rejuvenate the ocular surface, not only the lacrimal gland. When we rejuvenate the lacrimal gland, everything returns back to normal. So the current work that I am leading, and I have Dr. Ala who's here with me, and you can stand up because you will lead this. Stand up, Ala. Ala is one of my fellows in Alexandria University, and she's taken one arm of the study. And this arm is to inject those people. Again, we have a definition of a severe dry eye, as you see on the, I don't want to repeat what I'm writing. The OSDI is more than 33, less than 33, and the Schirmer test is less than 0.6 millimeter. And we inject now 1 milliliter of a freshly prepared PRP. And in another arm, I am injecting in the inferior fornix. It's not the work of Ala, but this will be another work. So we have different ways and different approaches to inject it. A quick way how to prepare the PRP in our laboratory is simply you take a sample of the blood, 9 milliliter over 1.5 milliliter of citrate dextrose, and then you rotate them in a low velocity for 5 minutes. This will separate the layers into the serum and the RBCs, or the cells of the blood. You take again those layers above, which is 55, and you centrifuge them at a high speed of 20 minutes. And this is to separate the PRP. And before you take the PRP, you just activate it with calcium gluconate immediately before you inject, because to degranulate the cells. And then we go and inject it into the eye. What I'm doing now also this is the same way of injection. As you see, it's a very simple, it's an office work the way. You can do it in the operating theater or an office work. It's a transcutaneous now into the lacrimal gland. But what I'm using newly now, since 2 months, is the purified growth factor. A genius in Egypt has invented that, and doing it in a lyophilized form, of course, after inspection of it against AIDS and hepatitis. And I'm using it now the same way of application, either transcutaneous inside the lacrimal gland directly, or in this inferior fornix to rejuvenate the accessory lacrimal glands, or both ways. And the results are really marvelous using PRP or using the purified growth factors, the platelet growth factors. So to cut the story short, what the platelets do is when you degranulate the platelets, or you extrude outside the growth factors, you have all the growth factors, as I mentioned, that will promote cellular proliferation, lacrimal gland regeneration, and the restoration of the ocular surface by increasing the aqueous layer production. And this, of course, is a new hope for those patients, not only the severe dry eye, we will find a new hope for many other diseases to regenerate them. So in conclusion, PRP injection, whether it is a pure PRP1 or the purified growth factor, is a new way to resurrect the dead lacrimal gland in severe aqueous deficiency form. The regenerative capabilities should be explored for further indications, and the subconjunctival route, especially in the inferior fornix, could be an alternative or an adjunctive to the injection into the lacrimal gland. We need many things. We need a long-term follow-up. We need the dosing. We need the frequency, because I will tell you a small piece of knowledge. When I injected people with the purified growth factor, they needed only 2 injections, and they were extremely severe dry eye for more than 10 years. And I can count on you the testimony of them. One of them is a professor in my university. She's a refined doctor, and she told me that she got total cure. Even she's not using now, except for 2 drops of artificial tears, sodium hyaluronate, after she was using it every day. This is the sea that is very far away from India. I think Bangalore, Dr. Shetty needs a sea. So either you bring Bangalore to Alexandria, or you bring Alexandria to Bangalore. We need to make a bridge between the 2 cities, because I feel home here. but what I miss is the sea. So we should bring a sea next time to the meeting. So please.
Or all those who want to see the sea can come there.
And we'll create a Dr. Shafiq's canal.
Yeah. Okay, so thank you again and again for the hospitality, for the wonderful meeting that we had. We will miss you starting from tomorrow when we go back home, but our hearts remain here in Bangalore.
Thank you, sir. Thank you.
Thank
so
you.
just to continue on this, then we can have some questions. We did some work. There's been question asked, what should we use? Autologous serum, platelet plasma. This is something which is the major question, which is the best and which is better. You know, this is, I think, every clinician would want to know. So we thought we should do a study of the growth factors in them, because what does these things contain is the growth factors, and growth factors are the ones which makes the whole thing to heal. So after this, we may have a few questions, and then Dr. Shafiq has to conduct a workshop. So let's, Swami, quickly, let's go through this.
Quickly, yes. So if you take, not so quickly.
So quickly also, because you missed something very important. Go back to the previous one. Yes, this is important. Because we need to know what does corneal epithelial cells need. It needs insulin growth factors, no growth factors, TGF, PDGF, and all those which I don't know what they are full forms of, but VEGF. So basically you need all of them, and that is where I think the whole concept of IG, insulin growth factors, come into play. Now, the question is, in healing, you need everything. And each types of, for example, a chemical injury, acid burn injury, dry eye, or genetically Stevens-Johnson's, each and everything have different growth factors which are deficient, and each one has their own challenges. So now you can go back to the next one.
Thank you, sir. So if you look at it, the most important things which you're going to get benefit on the ocular surface is going to come from the blue colored one and the red colored one. And the red colored one, the growth factors is what we are talking right now. Sorry. Yeah. So these are the growth factored one. And they not only have growth factors, they also have secreted receptors. So we now have quite a clear idea of where the beneficial effects are coming from. One is a lot from the immunoglobulins. They can mop up the unwanted stuff, like how an IVIG would do. And the reparative works comes from the growth factors. And that's the question we had. And we went on to go do an experiment from a grouped sample. Thanks. From a group sample, and we found a very distinct difference here. A group of these factors are not high in your autologous serum or PRP, and these are the group of factors which are high in your PRP or autologous serum, but less in the tear fluid that is on the ocular surface. That's where the major benefit is going to come from. And this is the overall outcome of what they are. So you have a lot more NGF, BDNF, insulin, HGF, PLGF, and thymocyte, lymphopoietin, thymocyte, stromal lymphopoietin. These are all reparative factors which are going to be very useful.
Now, from a clinical point of view, if you're using an autologous serum versus a PRP, this is important because this has to translate to a clinician now. Which one do you use and where, based on what you've done here,
right.
And then experience is a completely different ball game based on the factors what you analyze. That's a no growth factors.
So these are the things which you might be needing. An autologous serum has a lot more, but it is comparable to the PRP. But only BDNF is much lower, but the NGF is similar. And if you come back to...
So for example, if Sunil Morekar wants, after this corneal neurotization, he is very keen to use one of them, though he needs the BDNF.
Yes.
So he needs BDNF, so for him, if somebody comes and tells him there's a new thing called platelet-rich plasma, it's not about platelet-rich plasma there. For him, it's still the age-old autologous serum. So this classically explains about old is gold. You may have a new way of manufacturing certain thing, but it doesn't mean that it has all the factors. And that is, yes, Sunil? Swami, keep.
So
Okay.
that's a very important point because there are some cases in which we used autologous serum as an additional thing, and maybe that's the one which worked and the cornea didn't. And the second part was that when we talk about VEGF, all right, there are 6 different types of VEGF: VEGF A, B, C, and D. So many times people told me use an anti-VEGF because you want the vascularization to go away. But when you use an anti-VEGF, you destroy the VEGF A as well as the VEGF B. The VEGF B is important for neuralization. Neoneuralization. So very important point, the autologous serum, but very important point that we can't use the whole anti-VEGF. You want to block only anti-VEGF A.
Well said. So what is TF here, which is so high here? Where do you think the TF have?
fluid.
No, that's a TF film. Okay. So look at this. So more or less, autologous serum has something very similar as. Now this is where the autologous serum does not have anything. So where do you think this has a role in healing?
So in terms of GM-CSF and G-CSF are colony stimulation factors. They are essential for more of the immune cells to proliferate and come. So we are not too concerned about its role in.
So even having high or less doesn't make a difference.
Makes sense, yeah.
So if Dr. Shafiq has to go back now and do a second part study comparing his work, so you still think that he should look at these two, autologous and this one, and see, and will it work? And there's one interesting point is the insulin. If you go back to the previous one, the insulin is quite high in the tears.
The autologous serum and PRP, it's lower in the tears.
Tears and autologous is, that means autologous serum also has insulin. So it's not that when you have an autologous serum, it needs not have to give a loaded with insulin. This is very interesting. Let him finish the next slide, and then we'll open for 5 minutes for discussion because it will complete the whole picture. There's never been, we had a German student as a fellow for a month, and he worked on this. We have a lot of these international fellows coming for a month, and we give them a very, very interesting topic, which becomes the life-changing topic. And is so impressed with this now. He keeps talking about it. And this is one of his studies. And he did the whole thing in a month. And anything else you want to add before you open up for questions?
So the cytokines will be altered as well, so we have to be a bit more careful when we are using it. If you have a systemic circulation of high inflammatory factors, that may impact and override the growth factors effect. So you just have to be careful about that. That's about it.
One thing which is interesting here is that IL-10, which is the most important one, is PRP, it's quite high, and PRGF, it is not so good. So if you want to have a protective effect, then PRP might, at least on this data out here. So now we open up for questions. I know this having...
I can't wait to comment, please. I want to make sure that this study was done. Tear film analysis is on normal patient, correct?
All of them normal.
So if anything from here, from this data in front of me, I will understand that nothing is equal to your tear film. And that is why we are looking for alternatives that would have a little bit of balanced equilibrium of nutrients, anti-inflammatory drugs, antimicrobial growth factors, healing factors that would mimic your tear film.
Absolutely.
So this by itself tells you that what's the big difference between autologous serum and platelet-rich plasma? Now, I know Dr. Shafiq should answer this, but I will just give a little comment because yesterday I found that there is a gap in understanding this. Autologous serum is prepared after the clot happens. And if a clot happens, it means that you have already given the signal to the platelets, I need this kind of growth factor, or I need this kind of inflammatory mediator. That's why you will have abundance of inflammatory cytokines in autologous serum, and that's why if you give autologous serum to patients with Sjogren's syndrome who are not controlled, they will get worse. However, when you use platelet-rich plasma, as described by Professor Shafiq, the platelets are preserved with all this, and they have the store of all the growth factors that are untouched, unsignaled. And that's why when you take them as they are and just plot them inside the eye will utilize what it needs without any outside signal. And that's why it works much better than autologous serum. Yet, this autologous serum, the platelet-rich plasma, has a very, very strong analgesic effect, which means after you inject it properly, Professor Shafiq will mention this, the very first impression the patient has is, I am pain-free, no more pain.
Exactly. I agree totally. This is number one symptoms that they notice. No pain. And this is quite interesting because we need to analyze that. By the way, before I step down, we started without naming a new club for PRP growth factor. Dr. Anoud Saadi is taking care of that in Saudi Arabia.
Yeah.
Dr. Deldar is taking that in Kurdistan, Iraq. And Professor Mark Rabitul, I think he will start in France also. And of course, we will join Narayana Natarlaya team to define which is which. But we are talking, we can't compare apples to oranges, as I understood from Professor Shetty and from Swami, Dr. Swami. This is not the same thing that we're using. First of all, the growth factors that I'm using is a lyophilized one, non-self. And this non-self will carry no antibodies or the cytokines of the disease. So I'm a little bit worried to use self-blood to prepare this. So the moment that I will use another blood tested, of course, against AIDS and hepatitis and all the things, I will be free of using the same patient's own blood with all the harmful antibodies carrying in it. Maybe good, maybe bad, we're going to see. But what I noticed is that a double injection of the lyophilized growth factor makes marvelous thing, and I'm going to change this soon.
And the other thing for the comparison between autologous serum and the PRP, that the PRP is rich in platelets. And if you use active platelets, they are they will orchestrate the problem in the ocular surface. That means they release the good factor depending on the needs of the ocular surface. So it will release depending on how we need in the ocular surface. We need PRG or which growth factor is needed.
Mm-hmm.
That is very important to use a fresh PRP with active platelets.
Okay.
Professor Shafiq, I have a quick question for you. Here, I have a quick question for you.
On the podium.
Yeah, hi. So we have used all of these, autoserum tears, the platelet-rich plasma, and an indigenously made growth factor derivative alone. And you were right in saying that progressively each works better than the previous one. But then the way we understand things is that, the growth factor injection or drop is like an energy drink to the ocular surface or the lacrimal gland. While it boosts their activity present time, we've not been able to get the patient off the supportive medication. The systemic medication or controlling the inflammation has to be an ongoing process. It's not one or the other, because once the effect of this injection or drop reduces, the baseline problem is going to, take over. So our experience has been that it works better when the other medications or the systemic control is also in place. It's not instead.
Totally agree. If we're talking about a systemic disease, I'm talking about controlling locally the end result, which is the atrophy of the lacrimal gland, both the main lacrimal gland and the accessory ones. Okay? But of course, as a systemic disease, we're talking about Sjogren's syndrome, whether primary or secondary, you have to control it, of course, systemically, because it's not the only manifestation that dry eye. The dry eye is not the only manifestation. You have a lot of manifestations.
Professor Shafiq, we will continue with the post-lunch session.
Yeah.
You have to go up for the workshop,
Yes.
and we need to finish this by 12:45. We have a session in the afternoon.
Thank you very much. Yeah.
We'll continue on that.
Thank you very much.
And probably next year we should have a session comparing those with
Absolutely.
clinical results.
Absolutely. I think this is something which is very important to look at, because a lot of times it's prescribed by everybody. We have Boston Keratoprosthesis Journey from Patient Selection to Long-Term Care by Dr. Yatish Shivanna. He's here.
Yes.
Yeah. Here. Yatish?
No. Is it on the left one? Right one? Left
Yeah.
one?
Oh,
Yes,
yeah.
please go to the other one.
He's ready. Okay, left.
Good afternoon, ladies and gentlemen, aficionados on the dais and off the dais. I should thank Dr. Rohit first. It's his magnanimity that I'm here. It's a great pleasure to be speaking in this fantastic meet. It was the year 2009 when Dr. Rohit told me that we'll have to train in keratoprosthesis, and believe me, I had the same expression as this artist has here now. So from 2009 to this year, 2026, we've come a long way in Boston keratoprosthesis, upwards of 250 keratoprosthesis. We have had our set of failures as well. Right, having heard all these talks on the management of microenvironment on the ocular surface, ours is a tad bit different, managing the macro environment, but it still has its place. Right, we've come a long ways from the initial era of the collar button keratoprosthesis. We have varieties, of course. We have the Pintucci keratoprosthesis, the biointegrated one. We also have the MOOKP, plus we have the alpha core down to the right. Alpha core, of course, has fallen into disrepute with us. We still persist with Boston keratoprosthesis, type 1 primarily. Right, we do have the type 1, which is the regular one, what we do, the picture on the left. But we can also do the type 2 keratoprosthesis in advanced cases of ocular dryness. Right, for those of you who wonder how the Boston keratoprosthesis looks like, we have front plate and we have the back plate. Back plate, of course, has got a lot of perforations to allow the aqueous humor to hydrate the carrier graft being the normal human tissue. And we have the locking ring from posteriorly, which keeps the front plate, back plate, and the carrier graft in place. And initially it was only PMMA, but nowadays we do have the titanium back plate, which prevents the retroprosthetic membrane formation, which was known to be a significant cause for failures in Boston keratoprosthesis. Traditional indications have been 2 or more failed grafts which have poor prognosis for repeat regular keratoplasties, and bilateral vision of visual acuity of less than 2200 in the operative eye. And most importantly, it should have good potential for improved visual acuity. Patient selection is paramount. We should always take keratoprostheses which have good tear production for Boston type 1, which don't have, it's a strict no. Likewise, always assess for good eyelid function, and those which have poor eyelid function is not a contender for Boston keratoprosthesis type 1. They go in for the type 2 variety. And it's best to avoid the severe ocular surface diseases for Boston type 1, as I've said. But we have had our cases wherein we've tried Boston type 1 keratoprosthesis for severe ocular surface diseases as well. For example, this is the one which multiple thrice failed keratoplasties, and we've done the Boston keratoprosthesis type 1 and clubbed it with an EGV, and this is how it looks post-surgery. And this is the ocular surface, a 10-year-old kid whom we had with severe grade 4 chemical injury. And this is following the Boston keratoprosthesis type 1, he's now a 24-year-old kid. He's doing extremely well. We can also do it in cases of severe Stevens-Johnson, wherein if it is bilateral, we don't have the stem cells to cultivate and use it. And they also do very well with Boston type 1 keratoprosthesis, maintaining good vision for over 15 years now. We've also done Boston type 1 keratoprosthesis for severe ocular cicatricial pemphigoid. Of course, this is an elderly 84-year-old lady whom we did Boston type 1 keratoprosthesis. Of course, she also had age-related macular degeneration, which kind of reduced the post-op visual outcome. But being one-eyed, she had regained considerably good vision with Boston keratoprosthesis type 1. If you want to see as to how it could be done, this is a case of multiple failed grafts. We do remove the original failed graft. So once this is peeled off, we should be careful if there's any tube inside to preserve the AGV tube, not to cut that. remove the graft in place. So once that is done, we need to assemble the K-Pro. Right, just trim the remnants of the earlier graft. Now this is the 3 mm punch in the human corneal graft. Now place the K-Pro front plate upside down, over which the corneal graft comes, and this is the back plate. Now the back plate is pressed over the front plate, the stem of the front plate. So you can notice this is the PMMA back plate. Now once this is done, we need to keep the locking rim so that it clicks into position. Now there. Now we need to just press it so that it snaps into place and the complex is ready. Once it is done, it is sutured in place. Most paramount to note here is that the locking ring has to be adequate, otherwise complications can ensue. It's always easy to do it in multiple failed grafts, but then believe me, there are certain cases when ocular surface is improper, and like in Stevens-Johnson, wherein complication rates may be pretty high. Right, once this is done, it's the regular suturing as we do for keratoplasties. Now, post-op management would include prednisolone topical, QID, tapered over many months, but we always maintain them on topical fluoroquinolone for life. And some of the known complications include the retroprosthetic membrane formation, which is pretty common, and now this is circumvented by the use of instead of using the PMMA, we use the titanium backplate. Can also include corneal stromal necrosis, which is pretty common. Can also have infectious keratitis despite the use of regular fluoroquinolone topical. Endophthalmitis is quite a dreaded complication, but then once we use the locking ring correctly, the chances of endophthalmitis has reduced. Glaucoma is a pain, and the management is a total ball game altogether. These are some of the complications what we've had: severe corneal infections, the cataract infections, melts, severe melts exposing the backplate. And this is the one whom we've done the refurbishment of the keratoprosthesis. And this is the one which had CF vision, and post-op at 3 months has come up to only 1 month because of posterior segment complications. This is the one who had advanced glaucomatous disc damage and severe infections of the carrier graft. This is how it melts, the carrier graft melts, and we had to refurbish it with another K-Pro. This is how you can see the inferior melts of the carrier grafts and exposure of the Boston keratoprosthesis, which would require a refurbishment. Now, we've done something called as a refurbishment. We use the same Boston keratoprosthesis instead of using a fresh one. Now, this is how it is done. I'm almost done. So we remove the carrier graft, which is normally around 8.5 mm in size. Now, once this is carefully done, avoid the back plate, injury to the back plate. Just remove the carrier graft. Here you can see it is already melted inferiorly. So once that is done, we carefully remove the back plate we release all the adhesions. Once the underlying adhesions are released, we remove the entire complex in situ. All right, see there it comes out.
Itish, if you can sum it up, please.
Once this is done, we refurbish it and utilize the same Boston keratoprosthesis. Thank you so much for this great honor. It was a pleasure talking to you all.
Thank you, Itish.
Thank you.
Thank you. We'll finish the next one by Dr. Seema, and then let's see if we have time for a quick question. Till she's getting ready, anybody here has a quick question or anything to add? Yeah, so one question.
Question to Dr. Francois. Very elegant technique and the way you retrieve the surface in that NIRIDIA patient. Now, you talked about the microenvironment and also the possibility of stem cells in the center of the cornea. Now, NIRIDIA, as we know, is a congenital LSCD. And do you think, and how, I mean, but majority patients that we see are all acquired LSCD post chemical injuries and pathologies like that. So do you think something like this would work in an acquired condition as well?
I don't know, yes. So thank you very much for your comment and your questions. I did some cases. I have one case I did on burn patient that had the two eyes. The left eye had a keratoprothesis that was going wrong and had glaucoma. So he had a single eye and he had very low vision. In fact, I did in 2 steps. I did a lamellar graft, I removed the penis, and I did a set with conjunctiva. And finally, I was thinking that the posterior part of the cornea the scar will disappear with time. In fact, it has not disappeared. So I did secondary, the posterior lamellar graft using a femtolaser. So I think these surgeries in few stages could be used like that. You have to really to preserve the human depression in the eye, the arcade, the human privilege in the eye, not to open the eye like that, and to go step by step and to see how it works, because each cases, as you know, are different. So I think there is a logic there that we can use. I don't know if I answered to your question.
No, yes.
So Dr. Seema is head of cornea refractive surgery at Arvind Eye Hospital, Chennai. All yours.
At the outset, good afternoon, and my gratitude to Dr. Rohit Shetty and Dr. Pooja Khamar for having me here for this wonderful Deoss Congress. My topic, Beyond the Acute Storm, Secondary Corneal Ectasia, an uncommon sequelae of Stevens-Johnson syndrome. I'd like to revisit this title at the end of the presentation. Dr. Rohit Shetty asked us to present stories. So this is my story number 1. A 59-year-old female, a homemaker, who had allergy to sulfa medication in 1994, more than 30 years back. And recently, of recent time, 2 to 3 years, she has developed diabetes mellitus, systemic hypertension, and to top it all, rheumatoid arthritis as well, for which she is on immunomodulators. So it started more than 30 years back with the allergy in 1994, and she was managed conservatively at multiple places. And during the course, she had a right eye penetrating keratoplasty, which was done somewhere else. Eventually, when she presented to us in 2018, she had poor vision in both eyes, right eye with only perception of light, and left eye with a 460 vision. She had chronic cicatricial changes in both eyes and severe dry eyes. She underwent multiple epilations for the trichiatic complications, keratin debridement, and eventually, unfortunately, in 2022, she had a panophthalmitis of the right eye, wherein her right eye needed evisceration, so left eye was the only remaining eye. After 2 years in 2024, more recently, she had a further decrease in vision in her only seeing eye, the left eye. The vision dropped from 560 to 160, and right eye had a severe contracted anophthalmic socket, which looked like this. And coming to the left eye, her only seeing eye, this is the irregular thickened lid margin with the, not just the lid margin, the entire tarsal surface seems keratinized, and this is the cornea that it looks like, with diffuse congestion and superficial vascularization, total limbal stem cell deficiency, with corneal thinning and ectasia. When we examined her, comparing her slit lamp images from 2021 to 2024, you see that there is thinning and anterior forward bowing of the cornea. So when we did the MS39 ASOCT of this eye, we found that there is definitely thinning. You see to the tune of 200 microns. There is anterior-posterior elevation, inferior steepening overall, all the signs of keratoconus. So this is a post-SJS ectasia, which I would like to call a secondary keratoconus. Management for the lid margin complications, we could consider a mucous membrane graft, but she also had Sjogren's. So she had rheumatoid arthritis, and taking a mucous membrane, her labial mucosa was not giving good secretion. So we did not want to complicate things with that. Scleral contact lens, of course, is a possibility, but we need to have a good fornix because of symblepharon. There wasn't a good fornix, so we could not really offer her scleral contact lenses. And with her past episodes, she was not willing for any further surgical interventions as such. So we continue to manage her medically with lubricants, topical steroids, and antibiotics, apart from her Sjogren's management. Story number 2. 47-year-old male who had a Stevens-Johnson's following intake of nevirapine because he was suffering from HIV in 2008, had a nevirapine-induced Stevens-Johnson syndrome. with ocular manifestations, underwent multiple treatments, and when he actually presented to us in 2021, he had a vision of right eye 160 because of corneal scarring and left eye 636. Now, we managed him conservatively, but his vision dropped in the left eye. We were considering a cataract surgery for the left eye. This is the right eye showing the leukomatous opacity, and the left eye showing a nebulomacular scar, corneal thinning, immature cataract, and this is the lid margin keratinization for both eyes. So when we thought of cataract surgery for him, when we started looking at the IOL power, we found that the K reading, again, the cornea is quite steep, irregularly inferior, steepening, posterior float elevations, similar, and there is a peripheral, paracentral posterior float elevation in these cases. Again, a post-SJS ectasia. Why is this happening? So he underwent phacoemulsification and he got a vision of 612 after surgery. But just 4 months after the phacoemulsification, he presented like this, with a central corneal scar, with bulle, corneal edema, and wow, there is a DM break sitting there. So this is acute hydrops in a case of secondary keratoconus post-SJS. So again, we thought of managing the hydrops similar as we do in our routine cases. He underwent 20% SF6 decimetopexy, gas decimetopexy, and eventually, after decimetopexy, 6 months later, he retains a vision of 660. We gave him a lid margin keratinization, was treated with mucous membrane grafting, and he was fit with scleral contact lenses. He's maintaining the vision in his left eye at 660. So this is just a summary of both the cases, right eye as well as left eye, both the patients. And coming to discussion, I would like to say that chronic features of ocular SJS have been symblepharon, punctal occlusion, limbal stem cell deficiency, meibomian gland disease, entropion, trichiasis, lid margin keratinization, corneal vascularization, you name it. But where is ectasia? Ectasia somehow has been missed in our literature so far. So when we, it has not been described commonly as a common ocular sequelae of SJS. So our reports suggest that this could be a potential complication. We know that corneal ectasia is triggered by inflammatory mediators. And in SJS, there is blink-related microtrauma and ocular surface inflammation, all that is needed, essentially, for even keratoconus. For primary keratoconus also, we've known that it is clinically non-inflammatory, but significant subclinical inflammatory component is present. Then why in SJS? As in regular keratoconus, ocular SJS has the inflammatory markers which are elevated, TGF-beta, TNF-alpha, IL-6, MMP-9, and these eventually trigger the cascade, which cause keratoconus. So when we looked at SJS with corneal ectasia in PubMed, we saw that there were only 5 results, and out of this, the initial in 2016 was an American journal publication which said that Stevens-Johnson syndrome and corneal ectasia management can be a case for association. What they found is when they treated these patients with PROS, they looked at the keratometry for all these patients and they found that there is a high prevalence of ectasia in SJS patients compared to the normal population. So they thought it was an association. But then, this is a study from RP Center Ames, again from American Journal of Ophthalmology. They did a prospective study of 15 cases with SJS, and they found that definitely ectasia is, it's prospectively when they studied, they still found that these patients did not have a baseline ectasia, but over a course of time, they have started developing ectasia. Again, corneal higher order aberrations are more than expected in SJS wherever it is possible to document these aberrations. But when we looked at SJS, ectasia, and acute hydrops, there are no results published yet. So our second case probably is the unique triad where acute hydrops is also presenting in a case of secondary keratoconus. So my take-home message is chronic ocular surface inflammation in SJS drives secondary keratoconus. Acute hydrops in this scenario can be managed, like in primary keratoconus. Both cases highlight a possibly underreported manifestation of secondary keratoconus in SJS. So is it actually, like my title slide said, is it an uncommon sequelae? Maybe not. Maybe it's just an unreported, less reported sequelae of SJS. So my questions here to the forum, to the panel, why SJS alone? Why not other ocular surface diseases like OCP? I've looked at literature, I'm not really finding those many cases or any cases reported. And also dry eye disease is an inflammatorily mediated. So why not the association with dry eye disease, not VKC, but dry eye disease as such? These are questions which we could ponder on.
So we will we'll use this question for the end of the session. And then we will come back to this. Only one comment which I have before we go to the next session is the kind of topography, getting a reliable topography on them is also a challenging. That is the challenge would be to see if the OCT or one of the other.
So the OCT based, the MS39 was more reliable than the Shine Plug.
Thank you.
Thank you.
So we go to the next session here. We start with Dr. Ikeda Lal, Sjogren's syndrome and dry eye, a case-based approach. The same panel will continue for the next one also.
A very good afternoon to everybody. And before I begin, I would like to thank Dr. Rohit Shetty for inviting me to this amazing meeting. And I've learned so much in the last days. And the whole team at Narayan Nethralaya. So I will be talking about Sjogren's syndrome essentially to two different cases. So my case one is that of a 57-year-old female patient who came to us with intermittent irritation and redness, which was associated with blurred vision in both her eyes. She was more symptomatic in her left eye than the right. She also had history of occasional dryness of the mouth, and when we asked her specifically, she said that she needed to drink water, especially while she was eating food. And on further probing, she gave us the history of associated dental cavities for which she had undergone interventions. There was no history of stiffness of small joints, which is an important question to ask at this point because she could have associated rheumatoid arthritis, and no history of skin rashes or repeated mucosal ulcerations. She had history of hypothyroidism for which she was on levothyroxine and medications for cholesterol. Now, the important history here to look for and to specifically ask these patients is the medication history, because sometimes they might take some drugs for anxiety or allergies, and we could be looking at a drug-induced aqueous deficiency dry eye as well. Now, when we examined her, her best corrected distance visual acuity was 20/60 in her right eye and 20/80 in the left. And we can look at the ocular surface staining here. We can see that there is significant amount of interpalpebral staining. There was no scarring in the conjunctiva that was noted. In the left eye, she was more symptomatic than the right, so we actually had to decrease the illumination to capture the images at this visit. Now here I would just like to show, we took these films of ocular surface staining. We can see that the blink is complete, but as soon as the tear film moves up, there is the area break that is typically being described for these kind of aqueous deficiency dry eye. So this could very beautifully be documented in this patient. And we also tried to look at the palpebral lobe of the lacrimal gland, which can give us a clue to further diagnosis. We could see some tear flow, but it was reduced, and the gland did not look as pink as it does in normal cases. Her Schirmer's was reduced to 8 millimeters in the right eye and 6 millimeters at 5 minutes without anesthesia, with eyes closed. It's important to do it in the particular way and have your own protocol in which way we test for Schirmer's. She also had cataract and an ERM in the left eye. So at this point, our clinical diagnosis is aqueous deficiency dry eye with a probable primary or secondary Sjogren's syndrome. Now let's look at the ocular management first. We started her on tear substitutes along with cyclosporin eye drops, and also started her on surface steroids, which will be tapered by the time the cyclosporin starts acting. But the important aspect of management here is a rheumatology referral for further diagnosis of Sjogren's syndrome. So these are the typical tests that I would like to highlight that can be ordered in a patient like this. So we have the CBC, ESR and CRP, and ESR and CRP can both be raised. Rheumatoid factor can even be raised in patients with primary Sjogren's syndrome. So anti-CCP antibodies are actually more specific for patients who have rheumatoid arthritis. An ANA profile might be ordered to look for SLE. Anti-ROLA antibodies, again, to look for primary Sjogren's, a thyroid function test, and serum ACE levels. So after consultation with the rheumatologist, they found no underlying autoimmune disorder, but she was anti-Ro antibody positive, serology positive for Sjogren's syndrome. So here, the final diagnosis was primary Sjogren's syndrome, which was made by the rheumatologist. And they did not start any immunomodulatory therapy at this point, because primary Sjogren's, if associated with extraglandular manifestations, might require further immunomodulation, and she was just given oral pilocarpine. So this is the typical criteria that usually the rheumatologist use to diagnose Sjogren's syndrome. And if we look at this criteria, it is the patient either needs to be an anti-SSA, or we call it as anti-Ro antibody positive, because that is more specific, or labial salivary gland biopsy positive. So at 1 month follow-up, her surface looks much better. It is stable, and we followed her up, maintained her for 6 months, discussed the role of punctal cautery with her as well. Her vision was worsening because of cataract, and it is important to understand that the surface has to be absolutely stable before we take these patients up for cataract surgery, and we do not need to rush into cataract surgery for these patients. So a few precautions that I would like to highlight during cataract surgery for these patients is first, limit incisional damage, avoid any astigmatic keratotomy or LRIs for patients like this, avoid using excessive topical anesthetic as well as povidone iodine eye drops, and NSAIDs both preoperatively and postoperatively need to be avoided. Coating the ocular surface with a dispersive OVD during the surgery helps us in avoiding the ocular dryness that we may experience. These patients can be extremely symptomatic, so reduce the illumination or make use of retroillumination techniques. And a word of caution for flax, because the suction ring can actually cause some amount of goblet cell loss and conjunctival damage. And we need to be very careful and gentle with ocular surface. So just to go through a quick video, I'm not using limbs here, just using the chopper to create the paracentesis and coating the ocular surface repeatedly with the dispersive OVD to make sure we do not have any drying of the ocular surface. These are the steps that we can take, making the use of retroillumination technique again, and importantly, using a monofocal IOL, avoiding premium IOLs for these patients, especially who have severe ocular surface disease. This is 6 months after cataract surgery. We see that the surface is relatively stable. Left eye, we still see some punctate staining, but she's maintaining a decent vision, and she's being maintained on tear substitutes as well as cyclosporin. And it is important to keep these patients on follow-up and guide them to see the rheumatologist whenever needed. Now, my case 2 is that of a 52-year-old patient who had blurred vision, pain, and redness in the left eye since 15 days. There is history of right eye keratoplasty, which was performed elsewhere 2 years ago. She did not have any records, and she was not keen on getting her right eye examined well. She had history of associated rheumatoid arthritis, and she had been non-compliant with the treatment. She had stopped all her immunomodulatory treatment. And when we look at the left eye, along with a dry ocular surface, we can see the tear film is breaking up. There is also this peripheral ulcerative keratitis, a little atypical because normally in rheumatoid arthritis, we find it extremely juxtalimbal. But she had a PUK associated with an aqueous deficiency dry eye because of her underlying rheumatoid arthritis. Now, here in this case, it is very, very important to tell her that she needs to seek rheumatology consult, and her RA factor was extremely raised. She was further started on methotrexate as well as oral hydroxychloroquine by the rheumatologist, and explained to her that her eye manifestations are related to the disease. And in terms of ocular management, she was managed with tear substitutes, cyclosporin, and for the PUK, we started her on tapering doses of topical steroids. This is after 5 days. We can see that the PUK is healing and she's symptomatically better. These patients need to be continued on systemic immunomodulation, which is the most important, and the topical steroids were tapered and stopped. So with this, I come to my final slide, that it is very important to have a good collaboration, like Dr. Geeta was stressing yesterday in her talk, that we need to talk to a rheumatologist and have a good conversation with them regarding when we are dealing with patients like this. And for a primary Sjogren's syndrome, just for the aqueous deficiency dry eye, a lot of time, these patients will not be started on systemic immunomodulation until and unless they have extraglandular manifestations, which can happen in patients with primary Sjogren's syndrome. Whereas for secondary Sjogren's syndrome, if there is an underlying RA or SLE, systemic immunomodulation is the key to the therapy, and long-term maintenance is important. If we take care of the systemic immunomodulation, the surface itself improves. With this, I would like to end my talk. Thank you so much. Thank you for having me here.
Thank you. And we'll finish the talks, and let's see, we combine everything and have a discussion. But one of the things, apart from how beautifully you have explained about managing about it, one is that even rheumatologists in this use high-dose curcumin and resveratrol. Both of them, especially in the US context, they're using a lot of these, which might help in as one of the additions to this planning.
Thank you.
Thank you. The next speak is about autologous platelet gel for non-healing corneal ulcer. Dr. Mariam? Yes, sure.
Hello, everybody. Thank you very much for the kind invitation of Deoss, my dear Siham, and all the board of Deoss, Dr. Rohit. Thank you very much. And I will talk about what can use as a new therapeutic approach for severe corneal ulcers. So why we think about PRP for the cornea and ocular surface? Because it mimics physiological wound healing milieu, provides balanced growth factor without xenogenic component, support epithelial regeneration while limiting stromal fibrosis. This with the platelets and with the content of the plasma. So we have a rapid epithelialization, controlled stromal remodeling, and minimal inflammation and neovascularization. What does the literature say about PRP? All the studies or publication and papers in the literature that PRP, thanks to its growth factors content, would be effective for ocular surface wounds throughout its anti-inflammatory and regenerative effects. But this is a problem. Why? Because there are several types of PRP, and there are several preparation protocols. So what about the quality of PRP to be effective on ocular surface disease? And it must be adapted to ocular surface. So we have a critical determinants in the composition of the PRP. The first one is the leukocyte content. The leukocyte poor PRP, it's the more effective, and because the reduced pro-inflammatory cytokine, lower matrix metalloproteinase activity, and improved epithelial tolerance. Leukocyte-rich PRP associated with increased inflammation and stromal haze, not recommended for corneal application. The second critical determinant is the platelet concentration. More is not better. Why? Because optimal platelet concentration demonstrated is 2 to 4 times baseline blood platelet content. That can ensure sufficient EGF, PDGF, and IGF-1. It avoids excessive TGF-beta mediated fibrosis, and it preserves epithelial proliferation capacity. The third critical determinant is the activation status of the platelets. Physiological release is preferred, so we must have no activated PRP. Gradual, sustained release of growth factors better mimics in vivo platelet activation, reduce the risk of fibrotic signaling. So how we have for the platelets, it's intelligent cells that the first detection of tissue injury with active platelets. So these platelets are the first biological sentinels at the site of injury. And the second thing, the platelet signaling, the platelet as a biological communication platform, membrane receptors initiate, coordinate signaling. Other factor is the growth factor profile for corneal repair. So we must have more EGF and EGF-1 for epithelial proliferation and migration, more PDGF for controlled stromal repair, and more HGF for antifibrotic effects. But less TGF-beta and VEGF to limit fibrosis and neovascularization for the cornea. And the last one, we must have in the PRP low fibrin content to prevent excessive matrix opacity, preserve corneal transparency, and facilitates diffusion of growth factors. That's why we chose the Regin PRP. It's a PRP for ocular surface disease because it's standardized leukocyte poor PRP. It's moderate platelet concentration, low fibrin content, and controlled growth factor release. So the rationale for use is mimics physiological corneal wound healing environments, minimize inflammation and fibrotic response, and high tolerability for topical ophthalmic application. So this region PRP had also in a preparation in a closed circuit, ensuring safety for the patient and for the operator, reducing the risk of microbial contamination and bruise exposure, and the operator and dependent PRP isolation, therefore standardized and reproducible preparation, so we have a constant quality. So now we have to use PRP for severe problem in the ocular surface. Like this patient, we have a perforation of the cornea. We need not so drops of PRP, so we think about preparing something solid to repair this surface. So we prepare for autologous platelet gel. This preparation is we prepare the PRP in one tube, and we prepare autologous serum or autologous thromboserum in the other tube, and we mix by 0.1 millimeter of ATS and 0.9 millimeter of PRP to have like something the solid. So this is the combination with PRP and the ATS, and we will obtain autologous platelet gel. It's a 3D fibrin matrix in which platelets rich in growth factor are interrupted. This we have the list with all the growth factors that are in the platelets in the autologous gel. This is the patient that I saw. So for the perforation, and this is the preparation of the gel and of the membrane. So we have a membrane that is very strange, it's solid, we can suture it, and we can have the mini material to solve the problem. This is the surgery. So we take a little piece of gel and we put in the perforation. We add the glue. It's also autologous glue prepared with ATS and the PRP, and we put an overlay the membrane of autologous fibrin. This is the follow-up, and we show that we have a cicatrization, we have the healing of the ocular surface, and after 45 days, sorry, it's good, but we have a very inflammation, so we must treat this inflammation to not have another recidive for the ulcer and perhaps the perforation, another perforation. So if we manage this inflammation of ocular surface by treating the inflammation by IPL, corticosteroid, doxycycline for 3 months. And we have the results with this patient, good results. Now we have for other patients, we treat for perforation ulcers in the perforation with the glue, with the gel and the membrane in overlay on the surface, covering the cornea, the limbus, and the conjunctiva. This is another patient with puke. It's a lady who have resistant to treatment for this puke on rheumatoid arthritis. So they have also scleritis, and the same surgery, and we have the nice results in slit lamp and in OCT. And it's another one, such to show that the gel, autologous gel, has a good effect on the inflammation and the regeneration of the patient. This is ulcer, neurotrophic herpetic ulcer, and we have a huge neovascularization of the cornea, and it's resolved by this surgery. This is the first consecutive cases of this severe ulcer and the perforation treated by the autologous platelet gel. The indications are 40% for perforated ulcer and for Gauche-Gauche and 20 for Gauche-Gauche, sorry. So we have a good anatomical and functional results, and the visual acuity was very, very nice, and we gain and obtain improve in the visual acuity in all cases. So we can now conclude that autologous platelet gel could replace amniotic membrane tension? Yes, and more. So we have its collagen and filling of loss of substance, support for matrix healing, remarkable anti-inflammatory effect, strong potential for regeneration of the corneal epithelium and corneal nerves, so PRP quality and active platelets managing ocular surface inflammation. The philosophy is autologous products, rapid preparation, simple procedure, available immediately before surgery, and least cost. Indication, all regeneration of ocular surface, namely refractory ocular ulcers, severe dryness, conjunctival surgery, and preparation for keratoplasty when we have limbal stem cells deficiency. Thank you, and is this my publication for my 10 cases for treated by autologous gel. Thank you for your attention.
Thank you, and we'll move to the next talk, and then at the end of it, before lunch, you can just ask a few questions. So Dr. Sumit Lane, who has a practice in Mumbai, and he's going to speak about ocular surface lesion, what you need to know.
Good afternoon, everyone. Thank you, Rohit sir and the organizing team for this kind opportunity. So my topic is ocular surface lesion, but covering all the ocular surface lesions in 8 to 10 minutes becomes very difficult. So though we can divide these ocular surface lesions into a very simple terms like good, bad, and the ugly ones. For today, we are going to focus on certain ugly part of it and OSSN most likely in this. So this is one of my favorite slides where we show these 3 pictures, and when those 3 are seen differently, then you know this could be something else. And you know, one is actinic keratosis, other is epitheliomatous hyperplasia, and one is OSSN. But when you see it differently, it becomes very difficult to understand what are you looking at. This is again a slide where the 2 pictures look same, but if you see closely, there is some difference. So that's how the tumors, they speak for themselves, and there are certain signs, very subtle, which if you know, you will never miss the tumor. So just going to the basics, when you see this kind of a lesion, see for the location on the growth, there are feeder vessels, there is keratin, there is intrinsic vascularity, and there is a rose Bengal staining. So when you combine all this, you can clinically diagnose any OSSN between almost 98 to 100% for sure. Now, is this everything about OSSN? No. Now, what is the intention of all this presentation? The intention is that at the end of the presentation, all of us should know that all of these are types of OSSN and we need to diagnose them without missing. And secondly, again, all this type of OSSN, all of us should be aware that how do you treat them. So just to show, this is pre and this is post, all of them are treated with the various modes of the treatment. Now moving ahead, there are other additions of investigation which we'll discuss as we go into the treatment. Now treatment has multiple modes from excision, chemotherapy, radiation, brachytherapy, and going up to the exentration. Now everyone knows, just to recall the basics, that how do you treat? You basically make a 4 mm clear margin, you take a double freeze thaw, you do a keratoepitheliectomy, if needed sclerectomy. But doing an excision is not the complete treatment of the OSSN. The treatment actually starts later when you send it for the histopathology. And so whenever you send it for the histopathology, it has to be on the filter paper, well marked for the margins. So your pathologist can give you diagnosis, are you done with the treatment or it's still pending? Now what happens when the pathologist gives you a bad result? What is the bad result? That something is positive, either margin or the base. What happens when the resection margin comes positive? Your pathologist says the margin is positive, but it is only dysplasia in situ. You can just simply observe the lesion. When your pathologist says that the margin is positive and you have an invasive squamous cell carcinoma, then you need to re-excise. The worst is when they say the base is positive, it is only focal, localized, then the cryo will go away with. But you have a diffuse involvement, then you need to go with the plaque brachytherapy. So this is very important, that only doing an excision is not, you need to see the pathology report as such. So as everyone followed, the surgery is a very good treatment for this, but there was a variable results, like people have reported 15 to 52% of the recurrence post-surgery, and especially when we are so good surgeons and high volume surgeons, what to do when this kind of a lesion comes. Even if you want, any surgeon cannot excise this fully because there will be more of the complications than the benefits of the surgery. So we know now we need a topical chemotherapy. And when do we need topical chemotherapy? Very 5 simple indications. There is more than 2 quadrant conjunctival involvement, there is pupillary involvement, there is more than 180-degree limbal involvement, and patient is not willing for the surgery. Now all of us are aware about all this, so I will not go into detail of MMC, 5FU and interferons. And interferon was the most surface friendly one, but now it is very sparsely available. So we are stuck with the 5FU and the MMC. Now, these are certain results. When you see this kind of a lesion, though it appears exactly like a keratitis, but this was nothing but the OSS in which we treated with the interferon injection. Similar kind of the treatment where the whole cornea is involved and it got cured. Now the question here for the today's world is not that when do you start? The question is when do you stop? So I'll give you 2 good examples here. This is one of my patient presented with the corneal lesion. We diagnosed on the OCT, yeah, this is OSSN for sure, we treated. And when clinically we see everything clear, which you also can see, we stop the treatment. We stop the treatment, patient comes back after 2 months with this kind of a lesion. Try to see it very closely. You'll see at the limbus, again there is some kind of recurrence which you can actually stain and see that tumor has come back. Now what went wrong here? We treated, we followed all the precautions, we treated for more time, and clinically when it was not visible, we stopped. So what we missed here is that you do a ASOCT pre, you do on finishing your treatment, and you feel clinically I am all done with here. But you see still there is some hyperreflectivity of the epithelium still present. Now in this case, if you stop the treatment, the tumor will reoccur, what happened in our case. So what do we need to do? We still continue the treatment based on the ASOCT that though clinically you cannot see the tumor, but it is actually there. And when do you stop? You stop when you see this kind of a picture where you get your hyporeflective epithelium back and nothing is there even on your imaging. That is the time when you stop your chemotherapy. Again similar, you see a lesion like this, though looks like a pterygium, but you know the ASOCT and clinically there is a keratin, and now you need to treat. Now we treated this patient for the 6 months, and at the 6 months we realized that the hyperreflectivity is not completely disappearing. This is the place where you should know now the chemotherapy is not going to work further. This is the time you need to stop, and now you need to add on a surgery as a measure. So chemotherapy and surgery go hand in hand, and it's not that only this or only that will work. And of course our pathologist reported as we were suspecting clinically, there was only dysplasia that was left. So looking at this lesion, please do ASOCT for every patient for every follow-up. Now what do we do in a worst of the cases? When do you have this? You do a imaging, and the imaging is showing that there is orbital involvement. And once you have orbital involvement, then it has become very difficult and you need to go ahead with the exenteration. So finishing with my last case here. So discussing everything, do we know everything? Now this is one 55-year-old gentleman presented with this kind of a lesion which is not progressive, but patient was suspected to be immunological disease and did all the workup for immunological panel, everything was negative. Now problem here was there was absence of pain, there was no improvement on the steroid, and the size was increasing. Now points are going into contraindication of the diagnosis of the scleritis which were done. We did a very simple test which comes back from the basic that you just do a simple rose bengal, and this was a infiltrative type of the OSSN, which again confirmed on a ASOCT, which resolved again with the topical chemotherapy. So at the end of the day, when you see this kind of a lesion, the smaller ones can be treated with the surgery. The large one will need a injection interferon. The very large one will always have invasive component, and it will need an addition of plaque brachytherapy. And the diffuse ones having only a flat conjunctival involvement can be treated with the chemotherapy. I acknowledge my mentors for guiding me and about the basics and the treatment of the disease, and thank you all for the patient listening.
The last talk is by Dr. Geirik, and then let's see if we have time for a few questions.
A very good afternoon to one and all. I thank Rohit sir for the opportunity to speak. I'll be brief. It's an interesting series of cases on eye pain. We spoke a lot about dry eyes. A lot of patients who come with just pain, and pain being the predominant symptom. And it's imperative that we understand that there could be various history aspects which we need to take out. And with the advent of the pandemic, which we've had, a lot of us have, of course, suffered personally, it's important that we find out history about COVID. And specifically, these two cases talk about how post-COVID triggered neuropathies are still a challenge in many of the cases which are presenting to a clinic. So case one is a patient. He's a dermatologist, a doctor. So he was diagnosed in COVID as late as Feb 2024. He was a really finicky patient, and that's the reason specifically he did a COVID PCR for diagnosing his, when he came with viral fever. But the interesting part is that he actually developed complications. He was in the ICU for almost 3 weeks. And it is then, after almost a month after coming out of the ICU, is when he started complaining of non-specific aches, pains, pains and, tingling sensation of the peripheral extremities. This is when he was, went doctor shopping multiple places. Neurologists, he went to ophthalmologists because he also had eye pain. Now, it's imperative that in such scenarios, your routine checkups and your routine evaluations is, of course, done. And in many of these scenarios, invariably in this case, it was normal. He himself actually self-medicated. He started vitamin B injections, magnesium, selenium, it still did not get better. And this is where he went. He was referred to a neurologist in NIMHANS. NIMHANS is actually a premier neurology center located in Bangalore. It's a national institute. They did an EMG, and it is then when one of the neurologists diagnosed this patient as having a query small fiber neuropathies. Now, what is a small fiber neuropathies? These are patients who present with non-specific peripheral tingling pains. It invariably involves the peripheral cutaneous nerves, and this can also affect the eye. The interesting aspect of this is that in addition to a neurological diagnosis, you also need a skin biopsy. Now, because that is invasive, many of the times these are patients who are sent for an ophthalmological evaluation. And when this patient came to us, slit lamp evaluation, we saw a few prominent corneal nerves. In addition to that, many of the dry eye parameters was normal. But confocal microscopy, I think it's been spoken in great detail over the past few days, is what we noticed is that this patient, in fact, had a microneuroma. And this, in fact, is very specific, and a confocal previous literature has shown is, in fact, one of the diagnostic entities to diagnose small fiber neuropathies. He also had some amount of inflammation, if you see dendritic cells, but a microneuroma kind of clinched, confirmed the diagnosis which the neurologist had in this scenario. So we went ahead and did a little detailed analysis of the confocal parameters. We look at confocal nerve length, the branch density, and what we found is that many of these parameters was much lower in the eyes which presented with this pain in the patient with small fiber neuropathy as in comparison to a normative database. We went ahead, at our institute, we do go ahead and look at biomarkers. Now, an important aspect is that this patient might have only had pain, but some amount of subclinical inflammation in the eye might have still been there, and that is where the role of tear biomarkers came into the play. And interestingly, in this patient presented with chronic eye pain in the peripheral extremities, IL-17A was actually elevated. Now, IL-17A, as Rohit sir spoke about, there are specific targeted treatments. You're looking at IPL therapies, but in this specific patient, it not only was elevated, it also correlated with the decrease in those confocal nerve parameters, which we saw, in the C-symmetric analysis on the confocal nerve analysis. Now, the second case, this is a patient who had a more chronic history. Way back in 2020, this patient presented with, COVID. Patient did not have an ICU stay, but since then has been having on and off symptoms of headaches, again, peripheral tingling, nerve sensation. It's again then when the patient presented to an ophthalmologist. Now, the patient presented with pain to such an extent that some of the neurologists, in fact, even advised radiofrequency nerve ablations. And this is when the patient actually presented to us for a detailed eye evaluation, because eye pain, again, in these patients was one of the symptoms which did not go away with traditional treatment. Generally, people tend to categorize this as patients having dry eye. Even in these scenarios, we looked at a confocal microscopy and we saw microneuromas. But what is interesting is dendritic cells was very sparse as you compared to the first case, though microneuromas was present in both of these cases. So what we did and what we went ahead is, this is what an entity of, a confocal plays an important role in diagnosing these patients presenting with non-specific neuropathies. CC matrix is one of the aspects of analyzing specific tools, and even in this patient, we had decreased parameters of corneal subbasal nerve plexus. But interestingly, the biomarkers, it kind of correlated with the dendritic cells. It wasn't very significant inflammation of the ocular surface. It was predominantly pain, neuropathic pain, which showed up as microneuromas, but the tear biomarker analysis revealed many of them within normal limits. So, COVID has shown, COVID-related neuropathic pain is an entity. There is a lot of established case reports, case series on that. And small fiber neuropathies is also something which people have associated with triggers such as COVID. Though traditionally it is associated with diabetes and autoimmune factors, but patients presenting in this day and age with a past history of hospitalization due to COVID, this is something which we need to look at quite closely. In addition to tingling sensation, how do you distinguish this with large fiber neuropathies? Is there will be autonomic dysfunction seen in small fiber neuropathies in the form of sweating, digestive issues, and that is a way of clinching through the history if they have any other symptoms here. Vaccination is also important because there have been reports where, in addition to the infection, vaccination-induced small fiber neuropathies have also been reported in these scenarios. And that is where it's important to understand that even in scenarios where patients present with non-specific pain, confocal plays an important role. We did an AI study on looking at various parameters of patients presenting with eye pain, and what we found is microneuromas was one of the top parameters detected by the AI in distinguishing such patients. So we had these two cases with COVID, one with ICU admission, one without ICU admission, but both of them fit the bit in a component which is known as small fiber neuropathy. One, interestingly, had a raised biomarker level, one had a relatively normal biomarker level, and management, in addition to treating their inflammation on the surface, can also include gabapentin, pregabalin. I think that is open for discussion. Homaturin and duloxetine also has played an important role in terms of neurologists treating them, and as ophthalmologists, nerve regrowth factors, taurine associated lubricants have also played an important role. So it's important and imperative that you take a detailed history. Make sure that history in terms of past history of COVID is something which is very important. Confocal as an important tool in analyzing what exactly is the cause of eye pain is very important, and customized treatment is, I think, the key. Thank you.
Thank you. We have 5 minutes before we break for lunch. Any questions to any of the three speakers?
Yeah.
Yes.
To Dr. Ikeda with a nice presentation on Sjogren's syndrome is easier.
Mike.
Do you think that the contact scleral lens could be really useful sometime in Sjogren's syndrome and be a key for the strategy of treatment of ocular surface sometime?
Hi, so I think we are talking about scleral contact lenses, if I hear that correctly.
Scleral contact lenses, yeah.
Yes, scleral contact lenses can help in these patients with poor ocular surface for sure. And they can, if the surface is not improving with our traditional methods, especially if we have a primary Sjogren's syndrome and they do not have any extraglandular manifestations and the rheumatologist is not going to start any immunomodulation, then definitely I feel sterile contact lenses can improve the surface and will improve the patient's visual acuity as well. An interesting thing that Dr. Rohit brought up, because in primary Sjogren's lots of times they will be only given oral pilocarpine. So maybe we can look at curcumin and other substitutes which can help with the inflammation associated as well.
Thank you. Any other questions to any of the speakers?
One comment to Dr. Sumit, very elegant presentation and very wide variety of cases. So the question he put up about when to stop, I think it's a very tricky situation as far as OSSN is concerned. His case had a recurrence, I mean, some kind of a residual tumor, and that got a recurrence. We had a similar case of corneal OSSN, which was covering almost 2/3 of the cornea, and we had to keep her for almost a year on interferon. And after we stopped the interferon, we saw whitish lesions in the limbus, and the ASOCT was not telling anything conclusive. So we did a excision and did a biopsy, and it turned out to be a limbal hyperplasia. So that again, because we have to understand that the interferon is it's an immune thing, and so it kind of plays around with the ocular surface, and once we stopped it, there was some kind of limbal hyperplasia. The limbus started growing and gave rise to a lesion. So once we excised it and put amniotic membrane, everything was clear. We have published it as well. So that question of when to stop is very critical, and I think patients need a very, very close follow-up after that. And I think it's also recommended that you need to continue the IFN for close to 2 months, even after you've seen a clinical resolution on the anterior segment OCT.
One point about, a quick point about Dr. Yatish's presentation. It was a beautiful presentation for those uninitiated. I think it showed the gamut of how you go about doing the Boston keratoprosthesis. But then it is also very imperative that when the keratoplasties fail, when the graft was clear before that, to document the best vision that the patient had and how the disc looked like. Because quite often during the tertiary or the referral time, we only see the ocular surface in the cornea being poor. So without knowing the visual potential, because we can't check the pressure, we can't take a look at the nerve, and ultrasound only says so much. So it is imperative that even if the graft is going to fail, we take a look at the risk and go back and revisit what was the best vision that was recorded during the keratoplasties to prognosticate these procedures.
A question to Dr. Arush, is possible? Do you think that autologous platelet gel could be useful to help Dr. Sima to manage second syndrome, Stevens-Johnson syndrome, to remove semblepharon to allow after, with a better wounding, to allow scleral adaptation? It's a key point for acuity visual in this pathology.
If I understand, you can use autologous blood gel to treat
to remove semblepharon of the allergic syndromes that she's treated.
Early now, because our utilization of platelet gel is for to repair ocular surface in the cornea for ulcers, the limbus, and for if we have like semblepharon, we can use it with the mucosa of labial mucosa, oral.
Yes, but in this pathology of the name don't want to go to my brain. I'm sorry. She managed. Is sometimes difficult because our allergy, all the mucus are in pain. So less you touch mucus. That's why I said with membrane amniotic and your gel, perhaps she allowed her to remove the semblepharon to permit to adapt contact lens. That's a key point to have the better acuity vision. I think you can try.
So Priyanka we discussed on the group about all the biologics, what can happen, and I think this is prepared by Swami. So we managed to get a laminated one so that every biologics, what is the primary action, secondary action, the tertiary actions, and so you can just keep it in your office. It will give you an insight on the complete biology of it.
A last question, Beatrice?
We should upload you for that. No, I mean, we should upload you. And by the way, that's mine. Thank you.
I can give you one more.
No, I mean, just a quick question to Dr. Kundu. I was just wondering, for the two cases after COVID, were we talking about long COVID and very severe COVID to start with? I mean, were they going to the intensive care? Because, I mean, we are all talking about cytokines, big storm in all the body. So were they feeling pain all over the body, so that's a question of severity for the disease to start with.
So for long COVID, the definition is should have been in the ICU for at least 2 weeks. The
Yeah.
first case did fit that, where the patient was in the ICU for 3 weeks, and post that developed that. It's just to highlight that long COVID is an aspect, but any viral infection can trigger it. So the second case, it was a home-based treatment, was not a very severe case of COVID, but the patient was diagnosed as COVID in 2020 and still has the symptoms in 6 years. So the trigger, whether it's long COVID or whether it's any other viral infection, is something important. And that can, I think, trigger the cascade of various other aspects which I spoke about.
Thank you for that, because the neurogenic effect.
So we break for lunch so that we come here at 2:30 for the summary of, we have a 1 hour of summary of last 2 days of the biologics and how. So it'll be interesting discussion, and the last session is about case-based scenarios. Thank you.
Ophthalmic solution for the management of dry eye disease. Nextane from Microlabs is formulated with the advanced Novelia bottle system, an airless, preservative-free technology that ensures sterility, precise and consistent dosing, and eliminates the risk of contamination. This innovative packaging provides extended shelf stability without preservatives, safeguarding both efficacy and ocular health. Nextane's unique formulation combines the hydrating power of sodium hyaluronate with a targeted blend of 4 essential amino acids: leucine, lysine, proline, and glycine. This combination not only provides immediate lubrication, but also supports the natural healing process of the ocular surface. Patients using Nextane experience longer-lasting comfort, reduced frequency of installation, and improved tear film stability, allowing them to go about daily activities with fewer interruptions from dry eye symptoms. Sodium hyaluronate-based eye drops, like Nextane, may also serve as an effective alternative for patients who do not respond adequately to carboxymethyl cellulose or other conventional lubricants. The unique features of sodium hyaluronate eye drops includes that it binds naturally to mucins on the ocular surface, increasing residence time and tear film stability. Dual action viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface cells. Clinical studies demonstrate sodium hyaluronidate's superior efficacy in improving tear film stability and significantly reducing dry eye symptoms. Nextane, sodium hyaluronate 0.1% ophthalmic solution, offers the patients with DED a comprehensive, preservative-free solution that provides outcomes beyond temporary relief. Nextane addresses the underlying causes of dry eye with better efficacy and tolerability through advanced delivery system. Nextane, the next generation sodium hyaluronate eye drops. Dry eye disease, DED, is a multifactorial condition that affects millions worldwide and is increasingly recognized as a significant public health concern. It results from an imbalance in the tear film, leading to ocular surface inflammation and damage. Despite being common, it is often underdiagnosed and undertreated. Introducing Nextane, sodium hyaluronate, 0.1% ophthalmic solution for the management of dry eye disease. Nextane from Microlabs is formulated with the advanced Novelia bottle system, an airless, preservative-free technology that ensures sterility, precise and consistent dosing, and eliminates the risk of contamination. This innovative packaging provides extended shelf stability without preservatives, safeguarding both efficacy and ocular health. Nextane's unique formulation combines the hydrating power of sodium hyaluronate with a targeted blend of 4 essential amino acids: leucine, lysine, proline, and glycine. This combination not only provides immediate lubrication, but also supports the natural healing process of the ocular surface. Patients using Nextane experience longer-lasting comfort, reduced frequency of installation, and improved tear film stability, allowing them to go about daily activities with fewer interruptions from dry eye symptoms. Sodium hyaluronate-based eye drops, like Nextane, may also serve as an effective alternative for patients who do not respond adequately to carboxymethylcellulose or other conventional lubricants. The unique features of sodium hyaluronate eye drops includes that it binds naturally to mucins on the ocular surface, increasing residence time and tear film stability. Dual action viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface cells. Clinical studies demonstrate sodium hyaluronidate's superior efficacy in improving tear film stability and significantly reducing dry eye symptoms. Nextane, sodium hyaluronate 0.1% ophthalmic solution, offers the patients with DED a comprehensive, preservative-free solution that provides outcomes beyond temporary relief. Nextane addresses the underlying causes of dry eye with better efficacy and tolerability through advanced delivery system. Nextane, the next generation sodium hyaluronate eye drops. Dry eye disease, DED, is a multifactorial condition that affects millions worldwide and is increasingly recognized as a significant public health concern. It results from an imbalance in the tear film, leading to ocular surface inflammation and damage. Despite being common, it is often underdiagnosed and undertreated. Introducing Nextane, sodium hyaluronate, 0.1% ophthalmic solution for the management of dry eye disease. Nextane from Microlabs is formulated with the advanced Novelia bottle system, an airless, preservative-free technology that ensures sterility, precise and consistent dosing, and eliminates the risk of contamination. This innovative packaging provides extended shelf stability without preservatives, safeguarding both efficacy and ocular health. Nextane's unique formulation combines the hydrating power of sodium hyaluronate with a targeted blend of 4 essential amino acids: leucine, lysine, proline, and glycine. This combination not only provides immediate lubrication, but also supports the natural healing process of the ocular surface. Patients using Nextane experience longer-lasting comfort, reduced frequency of installation, and improved tear film stability, allowing them to go about daily activities with fewer interruptions from dry eye symptoms. Sodium hyaluronate-based eye drops, like Nextane, may also serve as an effective alternative for patients who do not respond adequately to carboxymethyl cellulose or other conventional lubricants. The unique features of sodium hyaluronate eye drops includes that it binds naturally to mucins on the ocular surface, increasing residence time and tear film stability. Dual-action viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface cells. Clinical studies demonstrate sodium hyaluronidate's superior efficacy in improving tear film stability and significantly reducing dry eye symptoms. Nextane, sodium hyaluronate 0.1% ophthalmic solution, offers the patients with DED a comprehensive, preservative-free solution that provides outcomes beyond temporary relief. Nextane addresses the underlying causes of dry eye with better efficacy and tolerability through advanced delivery system. Nextane, the next generation sodium hyaluronate eye drops. Dry eye disease, DED, is a multifactorial condition that affects millions worldwide and is increasingly recognized as a significant public health concern. It results from an imbalance in the tear film, leading to ocular surface inflammation and damage. Despite being common, it is often underdiagnosed and undertreated. Introducing Nextane, sodium hyaluronate, 0.1% ophthalmic solution for the management of dry eye disease. Nextane from Microlabs is formulated with the advanced Novelia bottle system, an airless, preservative-free technology that ensures sterility, precise and consistent dosing, and eliminates the risk of contamination. This innovative packaging provides extended shelf stability without preservatives, safeguarding both efficacy and ocular health. Nextane's unique formulation combines the hydrating power of sodium hyaluronate with a targeted blend of 4 essential amino acids: leucine, lysine, proline, and glycine. This combination not only provides immediate lubrication, but also supports the natural healing process of the ocular surface. Patients using Nextane experience longer-lasting comfort, reduced frequency of installation, and improved tear film stability, allowing them to go about daily activities with fewer interruptions from dry eye symptoms. Sodium hyaluronate-based eye drops, like Nextane, may also serve as an effective alternative for patients who do not respond adequately to carboxymethyl cellulose or other conventional lubricants. The unique features of sodium hyaluronate eye drops includes that it binds naturally to mucins on the ocular surface, increasing residence time and tear film stability. Dual-action viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface cells. Clinical studies demonstrate sodium hyaluronidate's superior efficacy in improving tear film stability and significantly reducing dry eye symptoms. Nextane, sodium hyaluronate 0.1% ophthalmic solution, offers the patients with DED a comprehensive, preservative-free solution that provides outcomes beyond temporary relief. Nextane addresses the underlying causes of dry eye with better efficacy and tolerability through advanced delivery system. Nextane, the next generation sodium hyaluronate eye drops. Dry eye disease, DED, is a multifactorial condition that affects millions worldwide and is increasingly recognized as a significant public health concern. It results from an imbalance in the tear film, leading to ocular surface inflammation and damage. Despite being common, it is often underdiagnosed and undertreated. Introducing Nextane, sodium hyaluronate, 0.1% ophthalmic solution for the management of dry eye disease. Nextane from Microlabs is formulated with the advanced Novelia bottle system, an airless, preservative-free technology that ensures sterility, precise and consistent dosing, and eliminates the risk of contamination. This innovative packaging provides extended shelf stability without preservatives, safeguarding both efficacy and ocular health. Nextane's unique formulation combines the hydrating power of sodium hyaluronate with a targeted blend of 4 essential amino acids: leucine, lysine, proline, and glycine. This combination not only provides immediate lubrication, but also supports the natural healing process of the ocular surface. Patients using Nextane experience longer-lasting comfort, reduced frequency of installation, and improved tear film stability, allowing them to go about daily activities with fewer interruptions from dry eye symptoms. Sodium hyaluronate-based eye drops, like Nextane, may also serve as an effective alternative for patients who do not respond adequately to carboxymethyl cellulose or other conventional lubricants. The unique features of sodium hyaluronate eye drops includes that it binds naturally to mucins on the ocular surface, increasing residence time and tear film stability. Dual action viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface cells. Clinical studies demonstrate sodium hyaluronidate's superior efficacy in improving tear film stability and significantly reducing dry eye symptoms. Nextane, sodium hyaluronate 0.1% ophthalmic solution, offers the patients with DED a comprehensive, preservative-free solution that provides outcomes beyond temporary relief. Nextane addresses the underlying causes of dry eye with better efficacy and tolerability through advanced delivery system. Nextane, the next generation sodium hyaluronate eye drops. Dry eye disease, DED, is a multifactorial condition that affects millions worldwide and is increasingly recognized as a significant public health concern. It results from an imbalance in the tear film, leading to ocular surface inflammation and damage. Despite being common, it is often underdiagnosed and undertreated. Introducing Nextane, sodium hyaluronate, 0.1% ophthalmic solution for the management of dry eye disease. Nextane from Microlabs is formulated with the advanced Novelia bottle system, an airless, preservative-free technology that ensures sterility, precise and consistent dosing, and eliminates the risk of contamination. This innovative packaging provides extended shelf stability without preservatives, safeguarding both efficacy and ocular health. Nextane's unique formulation combines the hydrating power of sodium hyaluronate with a targeted blend of 4 essential amino acids: leucine, lysine, proline, and glycine. This combination not only provides immediate lubrication, but also supports the natural healing process of the ocular surface. Patients using Nextane experience longer-lasting comfort, reduced frequency of installation, and improved tear film stability, allowing them to go about daily activities with fewer interruptions from dry eye symptoms. Sodium hyaluronate-based eye drops, like Nextane, may also serve as an effective alternative for patients who do not respond adequately to carboxymethylcellulose or other conventional lubricants. The unique features of sodium hyaluronate eye drops includes that it binds naturally to mucins on the ocular surface, increasing residence time and tear film stability. Dual action viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface cells. Clinical studies demonstrate sodium hyaluronidate's superior efficacy in improving tear film stability and significantly reducing dry eye symptoms. Nextane, sodium hyaluronate 0.1% ophthalmic solution, offers the patients with DED a comprehensive, preservative-free solution that provides outcomes beyond temporary relief. Nextane addresses the underlying causes of dry eye with better efficacy and tolerability through advanced delivery system. Nextane, the next generation sodium hyaluronate eye drops. Dry eye disease, DED, is a multifactorial condition that affects millions worldwide and is increasingly recognized as a significant public health concern. It results from an imbalance in the tear film, leading to ocular surface inflammation and damage. Despite being common, it is often underdiagnosed and undertreated. Introducing Nextane, sodium hyaluronate, 0.1% ophthalmic solution for the management of dry eye disease. Nextane from Microlabs is formulated with the advanced Novelia bottle system, an airless, preservative-free technology that ensures sterility, precise and consistent dosing, and eliminates the risk of contamination. This innovative packaging provides extended shelf stability without preservatives, safeguarding both efficacy and ocular health. Nextane's unique formulation combines the hydrating power of sodium hyaluronate with a targeted blend of 4 essential amino acids: leucine, lysine, proline, and glycine. This combination not only provides immediate lubrication, but also supports the natural healing process of the ocular surface. Patients using Nextane experience longer-lasting comfort, reduced frequency of installation, and improved tear film stability, allowing them to go about daily activities with fewer interruptions from dry eye symptoms. Sodium hyaluronate-based eye drops, like Nextane, may also serve as an effective alternative for patients who do not respond adequately to carboxymethylcellulose or other conventional lubricants. The unique features of sodium hyaluronate eye drops includes that it binds naturally to mucins on the ocular surface, increasing residence time and tear film stability. Dual action viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface cells. Clinical studies demonstrate sodium hyaluronidate's superior efficacy in improving tear film stability and significantly reducing dry eye symptoms. Nextane, sodium hyaluronate 0.1% ophthalmic solution, offers the patients with DED a comprehensive, preservative-free solution that provides outcomes beyond temporary relief. Nextane addresses the underlying causes of dry eye with better efficacy and tolerability through advanced delivery system. Nextane, the next generation sodium hyaluronate eye drops. Dry eye disease, DED, is a multifactorial condition that affects millions worldwide and is increasingly recognized as a significant public health concern. It results from an imbalance in the tear film, leading to ocular surface inflammation and damage. Despite being common, it is often underdiagnosed and undertreated. Introducing Nextane, sodium hyaluronate, 0.1% ophthalmic solution for the management of dry eye disease. Nextane from Microlabs is formulated with the advanced Novelia bottle system, an airless, preservative-free technology that ensures sterility, precise and consistent dosing, and eliminates the risk of contamination. This innovative packaging provides extended shelf stability without preservatives, safeguarding both efficacy and ocular health. Nextane's unique formulation combines the hydrating power of sodium hyaluronate with a targeted blend of 4 essential amino acids: leucine, lysine, proline, and glycine. This combination not only provides immediate lubrication, but also supports the natural healing process of the ocular surface. Patients using Nextane experience longer-lasting comfort, reduced frequency of installation, and improved tear film stability, allowing them to go about daily activities with fewer interruptions from dry eye symptoms. Sodium hyaluronate-based eye drops, like Nextane, may also serve as an effective alternative for patients who do not respond adequately to carboxymethyl cellulose or other conventional lubricants. The unique features of sodium hyaluronate eye drops includes that it binds naturally to mucins on the ocular surface, increasing residence time and tear film stability. Dual action viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface cells. Clinical studies demonstrate sodium hyaluronidate's superior efficacy in improving tear film stability and significantly reducing dry eye symptoms. Nextane, sodium hyaluronate 0.1% ophthalmic solution, offers the patients with DED a comprehensive, preservative-free solution that provides outcomes beyond temporary relief. Nextane addresses the underlying causes of dry eye with better efficacy and tolerability through advanced delivery system. Nextane, the next generation sodium hyaluronate eye drops. Dry eye disease, DED, is a multifactorial condition that affects millions worldwide and is increasingly recognized as a significant public health concern. It results from an imbalance in the tear film, leading to ocular surface inflammation and damage. Despite being common, it is often underdiagnosed and undertreated. Introducing Nextane, sodium hyaluronate, 0.1% ophthalmic solution for the management of dry eye disease. Nextane from Microlabs is formulated with the advanced Novelia bottle system, an airless, preservative-free technology that ensures sterility, precise and consistent dosing, and eliminates the risk of contamination. This innovative packaging provides extended shelf stability without preservatives, safeguarding both efficacy and ocular health. Nextane's unique formulation combines the hydrating power of sodium hyaluronate with a targeted blend of 4 essential amino acids: leucine, lysine, proline, and glycine. This combination not only provides immediate lubrication, but also supports the natural healing process of the ocular surface. Patients using Nextane experience longer-lasting comfort, reduced frequency of installation, and improved tear film stability, allowing them to go about daily activities with fewer interruptions from dry eye symptoms. Sodium hyaluronate-based eye drops, like Nextane, may also serve as an effective alternative for patients who do not respond adequately to carboxymethyl cellulose or other conventional lubricants. The unique features of sodium hyaluronate eye drops includes that it binds naturally to mucins on the ocular surface, increasing residence time and tear film stability. Dual action viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface cells. Clinical studies demonstrate sodium hyaluronidate's superior efficacy in improving tear film stability and significantly reducing dry eye symptoms. Nextane, sodium hyaluronate 0.1% ophthalmic solution, offers the patients with DED a comprehensive, preservative-free solution that provides outcomes beyond temporary relief. Nextane addresses the underlying causes of dry eye with better efficacy and tolerability through advanced delivery system. Nextane, the next generation sodium hyaluronate eye drops. Dry eye disease, DED, is a multifactorial condition that affects millions worldwide and is increasingly recognized as a significant public health concern. It results from an imbalance in the tear film, leading to ocular surface inflammation and damage. Despite being common, it is often underdiagnosed and undertreated. Introducing Nextane, sodium hyaluronate, 0.1% ophthalmic solution for the management of dry eye disease. Nextane from Microlabs is formulated with the advanced Novelia bottle system, an airless, preservative-free technology that ensures sterility, precise and consistent dosing, and eliminates the risk of contamination. This innovative packaging provides extended shelf stability without preservatives, safeguarding both efficacy and ocular health. Nextane's unique formulation combines the hydrating power of sodium hyaluronate with a targeted blend of 4 essential amino acids: leucine, lysine, proline, and glycine. This combination not only provides immediate lubrication, but also supports the natural healing process of the ocular surface. Patients using Nextane experience longer-lasting comfort, reduced frequency of installation, and improved tear film stability, allowing them to go about daily activities with fewer interruptions from dry eye symptoms. Sodium hyaluronate-based eye drops, like Nextane, may also serve as an effective alternative for patients who do not respond adequately to carboxymethyl cellulose or other conventional lubricants. The unique features of sodium hyaluronate eye drops includes that it binds naturally to mucins on the ocular surface, increasing residence time and tear film stability. Dual-action viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface cells. Clinical studies demonstrate sodium hyaluronidate's superior efficacy in improving tear film stability and significantly reducing dry eye symptoms. Nextane, sodium hyaluronate 0.1% ophthalmic solution, offers the patients with DED a comprehensive, preservative-free solution that provides outcomes beyond temporary relief. Nextane addresses the underlying causes of dry eye with better efficacy and tolerability through advanced delivery system. Nextane, the next generation sodium hyaluronate eye drops. Dry eye disease, DED, is a multifactorial condition that affects millions worldwide and is increasingly recognized as a significant public health concern. It results from an imbalance in the tear film, leading to ocular surface inflammation and damage. Despite being common, it is often underdiagnosed and undertreated. Introducing Nextane, sodium hyaluronate, 0.1% ophthalmic solution for the management of dry eye disease. Nextane from Microlabs is formulated with the advanced Novelia bottle system, an airless, preservative-free technology that ensures sterility, precise and consistent dosing, and eliminates the risk of contamination. This innovative packaging provides extended shelf stability without preservatives, safeguarding both efficacy and ocular health. Nextane's unique formulation combines the hydrating power of sodium hyaluronate with a targeted blend of 4 essential amino acids: leucine, lysine, proline, and glycine. This combination not only provides immediate lubrication, but also supports the natural healing process of the ocular surface. Patients using Nextane experience longer-lasting comfort, reduced frequency of installation, and improved tear film stability, allowing them to go about daily activities with fewer interruptions from dry eye symptoms. Sodium hyaluronate-based eye drops, like Nextane, may also serve as an effective alternative for patients who do not respond adequately to carboxymethyl cellulose or other conventional lubricants. The unique features of sodium hyaluronate eye drops includes that it binds naturally to mucins on the ocular surface, increasing residence time and tear film stability. Dual action viscoelasticity, has anti-inflammatory and antioxidant properties, provides superior moisture retention, stimulates wound healing in damaged ocular surface cells. Clinical studies demonstrate sodium hyaluronidate's superior efficacy in improving tear film stability and significantly reducing dry eye symptoms. Nextane, sodium hyaluronate 0.1% ophthalmic solution, offers the patients with DED a comprehensive, preservative-free solution that provides outcomes beyond temporary relief. Nextane addresses the underlying causes of dry eye with better efficacy and tolerability through advanced delivery system. Nextane, the next generation sodium hyaluronate eye drops.
I'd request everyone to settle down, please. There's a post-lunch small session of poetry. Dr. Rasika Thakur will be presenting her art along with the poetry. So I'd like to welcome her on stage, please.
Hi, good afternoon, everybody. It's a short break from Dryeye. So the art that heals, where poetry, painting, and vision meet. So my medicine trained my hand, but poetry trained my heart. Because of Dr. Rohit sir, intrigued me to think about poetry more in details. So today I present why I started writing in first place. Today when I woke up, I thought of this day, what new I would learn, and experience that will stay. Standing here today, I started to think, why did I start writing? What was that connecting link? When I write, I pour my emotions out. When I write, I don't need to shout. A perfect way I found to express what I feel. Life is an art, and art helps to heal. I found my art, and so would you. If you are an ophthalmologist, you are an artist too. But just sit back today and dig a little deep, unburden those thoughts, and then let them seep. Poetry helps me calm, it helps me respond. My mind and heart works perfect when they bond. Find some art or sports you may play, something you do just for yourself and not for display. Art has taught me to be present and mindful. So be kind to yourself because life is short but beautiful. Thank you. I would just like to thank Rohit sir. I've written few lines for him and I would like to recite them even now. An inspiration you are, sir. The kind of research work you do, connecting every single dot, it's not an easy thing to do. From tear film to gut health, so much more to know. Biology-driven discussion, perfect way to go. When ophthalmology and psychiatry together they meet, a conference like this, it's a pure bliss and treat. Thank you so much, sir, for giving me a voice at this stage. Thank you.
Thank you. There are two poets here. Mark is a poet, Dr. Bandari is a poet. I think both of you should say something, or if you have anything to say.
Do you want to compete? I would not be able to compete like this. So if you let me just...
I think this is a very nice thing. I don't know if you can... Healing vision is our skill. Seeing the human behind the eye is our art. Can you just put that on this thing, please? I think this is a very nice way of how, they summarize multiple aspects of our practice and how you bring artists in every one of us. Mark, Dr. Bandari?
Yes, I stopped writing 33 years back. In college, I used to compete in St. John's and Mount Carmel College. They used to have a essay competition. I loved St. John's because of the environment to write. After 33 years, I just took a pen and as usual, Rohit will give you the hint of this is the topic for you. And then I started off and I wrote some AOS times as 2 or 3 of mine, which all started with Muscati starting the poetry session there. If there are young poets and want to publish, you can go for AOS times. And yes, I stopped reading, so my vocabulary is confined to some bad language or a little bit.
But you start performing now, like we saw you yesterday.
Yeah.
I think you should perform more.
Yeah, in the
I get that if you dance, as you can write, should be great.
It's nice to read more so that you write more, and we all think it's trivial to write. Unless we start writing, we don't know where we are heading. And some profound poetry I have written, and I never knew I was such a deep inside person because I always like to jump and make joy and tell jokes and stand up and a lot of other things. But you have to take, after 40, 50 years or 30 years of practice, you should have some of the art form to just release. And only when you read your poetry, you'll know whether you're good, bad, or ugly. Yes.
Anybody else? Amrita, Sushmita, any poets there? Maju?
I'm sorry, I missed. I was a bit late.
This whole session for 5 minutes, just to break into the postprandial one, we thought we'll discuss about art and poetry. So anything you do, art or poetry?
I read a lot of things out of medicine. Yes, I'm enjoying to open to other field and to understand that finally the way other field are thinking is also in our field, and we are also how to say that. It's not such a good way of thinking in the world, and we are also involved in that sometimes, so just taking care of that. So I don't know if I'm...
So I think there's also some people here are telling that Mark is a painter, musician, singer, artist, and ophthalmologist. So.
No, I'm not a painter, I'm not a poet. I'm first a doctor. I really believe that if you want to be a doctor, you have to take the things in an holistic way. This is very important. Not to see only the eyes, but also to see the patient that is behind. And in France, we have the heritage of what was called encyclopedia. Encyclopedia was in the 17th century. The idea was that skilled people have to learn a lot about everything because this will nourish all their knowledge coming from different ways to improve their relation with the others and to improve their comprehension of the world as a whole. So this is typically a French heritage, and I really believe in it, and I would like, including in our universities, that we come back to that, because we are, at least in France, moving to an American way of thinking, which is very focused on one specialty, and I really believe this is not the optimal way. As you do in your lab, if we try to understand the things as a whole, as something that is complex, but however logical, we may be much better in the future for our patients, but also for ourselves and for our friends, is my belief.
Thank you. Thank you. And now that we are all in that space of thought process with the art and extra beyond ophthalmology thoughts, I think it's time we start our session. And Swami will start it. So we'll all try to discuss a few things. What has already been discussed, but in small points, so each of your panel can add your viewpoints, or anybody can add. This is an open discussion. We don't have a presentation here. So, Swami, can we start? All of you got the laminated version of that printout? If you don't, then we have some here. We'll send it across to you.
You have some additional form because you didn't get any of them.
Good afternoon. So this is a summary which we had compiled based on all the discussions we had yesterday and even day before yesterday. So this table cannot be crowded with a lot of information, so there's only basic information here. So there was some discussion about 2% also, so you can see that I've included the 2% as well. So the most important and interesting part is over here, because everybody is familiar with the primary indications and the primary mechanisms. So what we are adding now is the secondary indications and secondary mechanisms. So there gives us the ability to use an approved drug for additional indications with some amount of rationale based on what we already know either in our lab or in published results. So can I summarize this? Yeah. So if you know, we always talk about calcineurin inhibitors and T cells only. So, but what I've written here is we have to think about that it can act on other immune cells also beyond T cells, one. And the other important thing cyclosporin does, as we have shown in keratoconus as well, it can help in ECM remodeling as well. So these are all new indications because of their mechanisms associated with it. So the next one is, do you want to add in something? So the next one here is about the tacrolimus. Of course, it's potent calcineurin. We had a talk yesterday as well on its capacity. But here, once again, because of the effect, like cyclosporin, the tacrolimus can also have an effect on the non-immune cells, that is the structural cells. That is point two.
So how does it help is that when you're using cyclosporin, it not only helps about your dry eye thing, it helps to modulate what we said yesterday. So when we use it for a refractive surgery patients, you're looking at for three reasons. See, the concept is, most of the concept is driven at primary indication, and this is what has got your study approved. Somebody would have got it approved for because Restes has got it for it, or Sequa or one of these has got approved for a particular one. And companies will not talk about the secondary mechanism, because that is not what they were approved for. But the question is, we as clinicians have to look at how. So for example, how you look at a minoxidil. Minoxidil is antihypertensive, damage hair growth, and multiple things, even Ozempic. See, the secondary is where the real advantage of a drug comes in. So for everything. So you start now, the whole idea of this meeting today is about primary, everybody knows. It's about secondary. So for example, if I use cyclosporin for 4 months for all my refractive patients, I'm looking at not only about this, but I'm looking at how I can balance the epithelial cells, how I can balance my collagen. For me, it's most important. So that is how I look at it. So tacrolimus.
So can I add something?
Yeah.
Last year in DEOS, Dr. Mark showed that cyclosporin, he showed increased corneal nerve parameters improvement as well, if I remember right. So there is another aspect which was brought in about cyclosporin's
That means if you're doing a LASIK surgery and you want the nerves to regrow better compared to a silk or smile, then this is definitely a role for that. So that is, see, each of these drugs which is put has a, but most of you look at this, all of them have primary as, except for losartan, which is not an accepted, not something which is commercial. So lifitegrast, the same thing, it's caused dry eye. Now, if you're using a lifitegrast, it has its indication in pain, which is something which is important because it has a work on neurotropic changes. It also have an implication on working on some place of ion channels maybe, and some allergy we don't know. And because of this, it has a big role in scar. So that is why if you are looking at, you're looking at a PRK, this is a fantastic post-operative medication because you're looking at something which reduces your dry eye, something which reduces your pain, and something which is a completely TGF-induced fibrosis. This is important because we as clinicians are only driven by what has been published. The question is, everything in the biology is not be true also, but at least it gives you some direction to think. And when you start thinking, things get better. Like we heard the wonderful talk by the Henry today. If he's not thinking out of the box, we would have still been in the bottle, glass bottle. So see, what we do is that the disclaimer, I'm on record here, I may be completely wrong, I'm okay being wrong, because that is when you learn. So but I'm speaking more from a biology, and this is what I practice. Whatever I've written is what I practice. When I write a lifitegrast, I write it for my PRK patients. I write it for my dry eye patient. Dry eye, it's there for everybody. You can write lifitegrast. I write left and right. I'm talking about post-op. So you're looking at cataract. So this also brings in a concept. This is for people who do a lot of your dystrophies. Like you see your TGF-driven. All dystrophies are TGF beta-driven dystrophies, your lattice, macular dystrophies on the cornea. Now, I think Kaushik was here. We did some work that if you want to reduce the dystrophies, you want to control inflammation. So all dystrophies don't progress to a keratoplasties. Yes. And one thing is that patient, you don't have an idea about what you give it to them. And we found that organoid-based work where we took the dystrophy cells, we grew it in the lab, and when you add that, later we can show, when you add that, it stopped the dystrophy cells to function. So that means that
the protein aggregation was stopped.
Yeah.
Gut formation equivalent.
So that means we never ever looked at, because when you define something in a box, our late chairman used to always say, work like there is no box. People will laugh at you, it doesn't matter. You work, when there's a box, then you think like a box. Everything has to be in the box. So we started looking at the whole TGF beta dystrophies, a bunch of them, as could be a dry eye. So when you can modulate that, this would be a guess one. And because it is, and lifitegrast is a phenomenal symbiotic drug. if there's one drug one is Trehalose on this because it works with, Trehalose also is not too symbiotic because it's chloroquine and some things it will not work. Yeah. But Trehalose, the lifitegrast somehow has a beautiful symbiotic relationship with everybody. That's what it is. And if you clean it, Pani. Yeah. Okay. Now, Trehalose we have discussed, Pani, clean Manidu? 1 minute. Trehalose we have discussed a lot about it. Again, Trehalose is theofilm instep. But look at it. ECM regulation, remodeling, stress tolerance, all that is good. This is where the whole game changes. That means why I use this as one of my most preferred post-op lubricant is because whether you do cataract, I think there was a beautiful talk yesterday that cataract, I think Dr. Sunil Morekar was talking about, there's a paper about you make an incision of plexus, the nerve incision goes and the neurotropic factors would change. So if you are using anything where you are changing the nerves or plexus, I think it works wonderfully well as an extracellular remodeling. This is an extracellular remodeling because both of them would work well. That's what I said. For my post-op medications, if I'm not dealing with anything on the surface, I would look at this and then add a cyclosporin. But if I'm looking at something where I'm looking at where there's a chance that I would use scarring or there is a scar, PRK, cross-linking and multiple things, then I would be a little careful. But lifitegrast in a very early stage or even cyclosporin in a very early stage of cross-linking may do opposite because the TGF-betas is necessary for some amount of cross-linking to happen. So biologically, these are small things which might offset the effect of cross-linking. So it is impossible maybe in our lifetime to exactly match the TGF whether it's working or not because there's no machine which will measure the in vivo. But from a biology, using the TGF blockers is not good at a very early stage of cross-linking because you want that to happen. You want the TGF-beta to manipulate it. We have spoken about insulin and what is the secondary work of insulin is neurotropic support. We have seen that it helps in epithelial migration. But once you migrate, then it also increases the TGF-beta, right? So that is why if you are using it for persistent epithelial defect, use it till the defects heal, then maybe wean it out and then add one of them or Trehalose. That's how would be the way to do it because or if you're using for only for pain, like if you're looking at pain, then you can continue. There's a colleague of mine who said, you people confuse me. You said first you use for 6 months. I said, I want to clear here is that you only for the epithelial defects cases, you stop it. For if you're using for pain, if it's working well, I think you can continue for longer time also. I'll come back to it again, but this is just a summary. And losartan, there are different doses. Whatever the dose we have put is what is the majority of the publication work has happened. And all of it works on fibrosis. Fibrotic. So it's a completely fibrotic drug. But losartan itself, in different doses, concentration, absorption, because it's not a drug which is known how it's manufactured, we have to manufacture it ourselves because we don't have a stability. So what we do is, it's just like a puzzle. What are the other TGF-beta signals? You have one, you have the Trehalose, which is there. So you can always combine this with lifitegrast or a Trehalose because that's how they balance. So what we have done, which we have a patent for, is that we have combined the losartan with a certain combination of Trehalose in it. So because we use the high concentration of Trehalose so that both becomes a TGF-beta signaling. So you just have to kind of balance them off because we need additive effect of it because handling scar is very challenging, and we have found that when you balance them out, they work well. The second reason why we need lifitegrast with one of them, especially lifitegrast, is when you have a scar caused by when you have a scar which is caused by infection versus a scar caused by trauma, bar any other thing, no, I'll explain. So what happens is the scar by infection is by a bacteria virus. It has a lot of inflammation in it. We checked on the surface. I did present in Cairo about it.
Oops. Buddy, something happened.
So this, I can write here the scar
That looks
by
like a Thea logo.
the scar by infection and scar by this are different. So that means if I have a scar which is infectious driven, then you have to treat, if you're using losartan, you have to treat losartan with one of the immunomodulators, which could be a cyclosporin or lifitegrast. Now, if I make you start thinking, which is the one which has a more TGF beta activity in between the cyclosporin and TGF, is the lifitegrast. So this is how you start thinking about the process. So when you look at that paper, if you go back and start looking at it every day, so you can stick it in somewhere, your mind becomes extremely active. That's the reason it's very difficult to connect. It's not coming here. Barlila. So off mud on mud, yeah. Till they get ready, you can ask a question. So by the time he'll be ready
I'll add one comment, sir.
Yeah, please, Band.
So I realized we have not added azithromycin for MGD, which Dr. CM uses. So I think this...
And any kind of antibiotic with
antibiotics,
some anti-inflammatory action.
So
thank you for that. If you can add a line on behalf of the French team.
Of course.
And
we'll update it.
It's very interesting when Steve Flugfelder was working on cyclosporin. His first drug he was trying out was doxycycline. He made doxycycline and he wanted to bring doxycycline as a drug. Restasis came later because of some, I don't know what.
People are telling that doxycycline has an anti-fibrotic effect.
It's MMP9.
Well. Yes. Yeah. Then maybe we can...
You know, there's so many things in biology is very interesting. You know, one of the very good anti-fibrotic is beta blocker. You know, it beta block, but I don't know at what dose in the eye you can work. But if you beta blocker has something similar, maybe much less is of TGF signaling. It's just like losartan, because they're all like hypertensive families. Yes?
Anything that works on the lid margin telangiectasia, especially in cases like rosacea? Or do you have any studies, thoughts about how to treat it?
Clinically, azithromycin, tetracycline, so one of these, azithromycin.
It helps with the blood vessels, the telangiectasia at the eyelid?
Yes, because it has an anti-angiogenic effect as well. Maybe...
so we can add this here, azithromycin.
And actually the beauty is as soon as you get an improvement, it's only 1 cure per month. It's enough.
So omega-3 fatty acid, the source is very important. You know, the topical is what we got now. I think a lot of international companies also have a topical ones. But primary indications is MGD. It works very well in MGD, except excessive mebum. When you see a lot of mebum secretions, it works very when your cap, when you showed a nice thing about that expressor, when you are blocked, so omega-3 works well. But again, this is what it is, resolvents. Resolvents is whenever you, see for example, I use it a lot in, of course, apart from the dry eye where the mebum secretions are there. Okay, you can see this. You can explain.
So the multiple pathways by which omega fatty acids, why do we keep talking about it so often, is it will solve two major issues. One, it has a very good anti-fibrotic effect, inhibits fibrosis, as well as the immunomodulation. Two, the third one is it converts an inflammatory phenotype of our immune cells to a reparative type. That is why it is the resolvin or the resolution type of an agent. Anti-inflammatories just suppress and leaves. This one helps the good guys to come, stay there, and help the reparative process. So that's why omega fatty acids is important
This
in
is resolved,
sustenance.
yeah. And why, there are two important things here. If I start digging your brain here to start thinking, if you are to give, like I'll start with you, if you have to give it, talk like a biologist, not a clinician. If you have to give this omega-3 drops, you have an omega, where would you start? And where would you not start? Let's assume you have it, both of you.
It reduces, we said fibrosis, right? Then PRK is one.
Absolutely. PRK would be the way to go.
And no for cross-linking.
No cross-linking for the first 3 months,
Yeah,
because
for
that's
the
what
first.
you need. But one thing which we found little interesting here is, if you can, we'll digress into it, is for some reason, the omega-3 drops works differently in an epithelial cells and the lens epithelial cells. That's something which you need to keep in mind. That means, I don't know whether it stops the epithelial cells, corneal epithelial cells from coming close by.
So after healing, the PRK
Maybe,
started.
because but for a lens epithelial cells, it does the opposite. It blocks. So we were very keen that if it goes into the eye, for those patients who are having early PCO or anything, it would be phenomenally good. So it does go. It does go, but in that concentration, does it go? Yeah. I don't know whether we can, it's something very interesting how a lot of these drugs behave differently in different environments. And yes, you have anything to add?
No, I was listening and thinking, sorry.
So till he gets in, this is how it is. You know, it has an IgE, IgM also. It has its work, and it works on sending back all the inflammatory cell back to their home. It's like after the war is done, all the soldiers has to go back. That is resolving. If they stay back, they create problems. So this is very, very interesting, which we just, this is the idea I had that if this can reduce you can see that this reduces it has an,
EMT, and this is the...
No, first go back to the thing. Now you know exactly what you said, that it works on reducing your fibrosis, and all your fibrotic genes are reduced, and this is where it is. But if you look at what it does on lens epithelial cells, this is what is important. So it means that you're virtually the cell migration of your cells, which causes your posterior capsular opacification, it is doing. And we measured it on the lens epithelial cells taken during the cataract. That means this is a true form. Swami can explain this.
Yes, please.
Because this will be wonderful if it works real time.
So if you look
Especially
at it,
in children.
This is a wounding process, and how quickly this closes is what we are measuring. And you can see that this is the space if you don't add anything, but compared to this space, this is slightly extended. That means it is slowing down the fibrotic process. It's called a scratch wound assay, which we use in an in vitro setting as a surrogate to assess whether they are anti-fibrotic or not. If it closes, if you add TJ beta, you can see the space is so smaller compared to this. That means more fibrosis is happening. Your wound is healing at a faster rate. Here the wound healing rate is slightly minimized, and that's what you get to see. And then the next slide, we already saw that what we saw in the healing rate is not an artifact, but it is a fact, because you can see alpha SMA, fibronectin, and collagen expression being reduced. So in a post-capsular opacification, it can be beneficial.
And you have the data in the eyeball about it going inside. I'm not saying that you write it for post-capsular opacification, but I'm just giving you a thought that for you to think. All of you are smartest here. Matthew next year will come. He's the smartest cataract surgeon. I keep telling he'll do my cataract surgery. So I keep telling him that if you go tomorrow and start using it, and tomorrow you tell me then it means that it's working. Because I don't do cataract, so I don't see too many patients, but just try it. And I will give you proof. This whole idea is, people tell us that, so not what I say is published, but I don't have time to wait till it gets published. By that time, a lot of patients will be denied it. So this is nothing, omega-3 anyway will help you with your dryness. What more can it do if it's not doing for your thing? But just start trying and see. And this is what we did. All this work was Lubna.
And the team there, and Dr. Lubna.
Lubna has done phenomenal work on this, where each of these drops were used on those eyeballs. And thank Konya department for helping us with the eyeballs. And you can just run through this.
So this is called the biodiffusion lab, which was started by Dr. Shetty and in GrowLab. And this actually compares how much of your eye drop is reaching in which sections, sorry, sir.
Take off it.
Yeah. In which regions of the eye. So these were the ex vivo, that is the donor eye was used. And you could see that there is definitely penetration at as early as 3 hours. And of course, the level goes out. That is probably the bioavailability changing. And the next slide, what we can see is the comparison of the actual product. The linseed oil has gone inside, that is this, which is an indication that gets converted to EPA and DHA, and finally the resolvent. So all these things are actually present in the aqueous, the vitreous, and the lens. So there is room for it to have a therapeutic effect.
Something similar we tried when lifitegrast was introduced, because lifitegrast should have been the intravitreal drug, not the ocular. So we tried, but it doesn't go to vitreous at all.
I have 2 questions, please.
Yeah.
First, you tested this on eyeballs from donors.
Yes.
So the cells was not living anymore.
The cells were not living anymore.
And to the best of my knowledge, there is only one molecule that is able to enter the lens without ion channels, and this is glucose. All the others do penetrate into the lens cells thanks to ion channels, meaning that the need that the cell is surviving. So what is the relevance of post-mortem studies like this? And if you want to prevent PCO, the idea is that there is no more lens. There are few cells that are indeed within the aqueous humor, because the aqueous humor is also in the bag of the lens. Where is the lens, the IOL?
So the first question is, this was done only to see if it enters the aqueous. There was no lens there, and we didn't look at the lens that much. Our idea was, if you put the drops, will it enter? And we also studied during cataract surgeries. When you do the cataract surgery, we put the drops before, and then when you're doing a cataract, the aqueous, and just see how much of it has gone into the aqueous. That was the first part of it. So first is to prove that it enters, first of all. The second part is, if it enters there, does it have a role in something? Because the aqueous humor content differs from different people to people. For example, there are patients where when your fellows operate, there are a big chunk of, say, capsules or not being cleaned or washed, and then nothing happens. And sometimes when you wash a lot, still you get those cells migrating, because I feel that it's got a lot to do with the aqueous content of TGF and other growth factors which are there, which might be playing a role. This is what
I mean, the next step will be to move to the rabbit study?
Yes. Yeah. We should be. But I'm just saying that any one of you can take it forward if we are not in, but it does go in. And if for whatever reason, it's worth looking at this. And yeah, go back to the table again. So I'm just giving you a tertiary level of use of drops apart from the PRKs and other things. So it does have a role in cataract lubricants. So coming to curcumin, we had a lot of discussion of curcumin in the morning. So it is an ocular surface inflammation. But remember what we said, it is again working on the, if you can put that pathway of NF-kappa B again, because that's important where it works. And because it works on NF-kappa B, it also has an anti-fibrotic. So if you're giving anything to your patients in terms of inflammation and in healing, especially in any refractive surgery, that's why I use a lot of omega-3 in men, not just for the dry eye part. And because if you're using a drug from a financial point of view, if it does multiple things, I would give one drug which works better. So vitamin D, corticosteroids, and all that is the combination, but it has an antioxidant and anti-fibrotic effect, more anti-fibrotic effect compared to what the omega-3 is. You can play the slide. And we have discussed about the resveratrol now. This is NF-kappa B here. And you can see that the NF-kappa B is triggered by the TNF-alpha, which is one of the factors of inflammation and haze in all your refractive surgery. And this is one which changes your ECM. It is one which makes your collagen not to heal. So that is why, orally, like I said, I don't know what dose reaches the eye. It's very, very difficult to know. But as a rational, giving, or if somebody says that I'm going to give it to my dry eye patients is good. Somebody says I'm going to give it to somebody who can help to build my collagen. You need some rationale, and this is the rationale behind that. Next. Vitamin D, if you have slides of the D. We did discuss about the vitamin D, but vitamin D, if you have any slide to show how it builds the collagen, it will be interesting. So this NF-kappa B also, cyclosporin restasis also has a role. And, that is because a lot of drugs, that's why I said, many drugs like cyclosporin and all of them are like a gene therapy drugs. They enter the nucleus and block it off. And that's why it's very important to understand that drugs works differently in different people. Like I said yesterday, you need this one to hold it. When this gets degraded, what enters inside the nucleus, I forgot the name, it enters the nucleus and starts producing these inflammatory.
The P65 goes
yeah,
inside.
transcriptive. Yeah, he's written there, resveratrol and this both block that very well, and this is where it works. Let's go to the big screen now. The big screen, the summary slide. So, like I said, the vitamin D also, the vitamin D again, we've discussed about it, that it has dry eye again, but it also has a role in ectasia, fibrosis, and we did a study where we looked at most of the keratoconus patients are deficient, especially the eye rubbers. So that means finding out what is happening is very important. And when the vitamin D is low, your action of your other cyclosporin, levotigrase is not great. It's with the vice versa also. For example, if you're, like I told in the morning, if your vitamin D receptors are good, it kind of, this whole combination of a receptor with the vitamin D itself is a very good immunomodulator. But if you just have a vitamin D, it doesn't work, or if you just have a receptor, it doesn't work. So you need the combination of this. And what improves the combination of vitamin D receptors in the eye is a lot of them, cyclosporin, levotigrase, trehalose, I don't know about insulin, but resveratrol, all of them have tremendous role on improving the vitamin D receptors. That's why if you're giving a vitamin D injection or oral treatment, it is important to match it with improving those factors. So Kaushik, you're ready with those things? Kaushik is the head of, he works on iPSC cell lines. He's head of our regenerative medicine. And his area of work is, he's been able to very successfully grow beautiful endothelial cells from your blood somatic cells. His work is, so a concept here is, because of him, we build this concept where we want to move out of, you have those videos of yeah. So what a concept is, we call it the eye twin model. That means you can create any type of cells from the blood or skin tissues. See, earlier, to study anything, you had to either go to do an animal studies, which is becoming very, very barbaric or very costly. So how do we actually do it? And like Mark said, cadaveric models are very complicated. First of all, you don't get it. So what we do is, I ask him to create models. For example, I ask him, I want a model of macular dystrophy. For that, he will ask one of us to give cells from a macular dystrophy, and he will create the lines, or
exactly. So it's the process is very straightforward as the sound of it. So from blood or any somatic cell, we have the ability to reprogram them and make them into induced pluripotent stem cells, because we are inducing the pluripotency in them. That's how it goes, the name. So once we have those induced pluripotent stem cells that we have generated a couple of lines in our lab now, which have from macular corneal dystrophy, retinal dystrophies, and so on. So these are patient-derived cell lines, right? These are pluripotent lines from the patient. From them, we make different types of the eye cells. For example, corneal epithelial cells we have made the stromal cells, endothelial cells we are taking to the preclinic right now, and then the RPE cells for the retina and ganglionic cells as well. For example, the endothelial cells that we have made from the iPSCs, we want to take it to the clinic for regenerative medicine. And for the other kind of retinal cells, we use them to model basically a disease in a dish. So what that allows us is a very human-specific. So what you're seeing...
Go back. These are the endothelial cells.
Yeah, so those are, what you're seeing is a video of those corneal endothelial cells that are derived from these pluripotent stem cells.
It's blood.
Okay, which were made from blood. And these endothelial cells, as you see, that they have all the specific markers that one should get to see in a typical endothelial cell. That is your Z01, sodium ATPase, and also the SLC4, A11, which tells you that these are functional and they have the punk-forming function. Next slide, please. And down below is what we have made.
It'll bury both.
Okay, so here are basically your RPE cells. These are retinal pigmental epithelial cells, which are generated from the iPSCs. And further on, we have made these retinal organoids. Now, as the organoids are, they are 3D version of your retina. So it recapitulates all the type of cells that you have in the retina. And they are wonderful to try out any of your molecules, your small molecules, which basically, when you try them in your animal, they fail. So these are human cells which you can try to use them. These are corneal organoids. And onto your left here, what you can see, for example, the markers for typical keratocytes, which is ALDH and collagen, lumican, vimentin, keratocan.
And those are collagen, those are keratocytes there?
Yeah, these are keratocytes. What you're seeing, this is a live video imaging of that. Can you please play the video shortly? So in green, you see the mitochondria there. So you can basically go to the organelle level inside the cell. So this is really going into very fine resolution there.
So when we talk about how do you measure the keratocytes, myofibroblast or TNF or drug, why does lifitegrast block? This is how we do, because this is exactly create the cells first. That takes at least sometimes few months to few weeks. And then after you develop the cell, how do you know this is actually a keratocyte cell, not a liver cell? Because you are taking it from the blood and passaging it to a stage where, so for that, you need to do multiple staining like what is put here, vimectin, lumigan, and all that. If those stain comes positive, like Henry was saying that, the bottles go to multiple level of checks through mass spectrometer and other things, only then you know that it is. So once you know this is your keratocyte cells, then you know that you're going for it. That's how experiments are done. This is what we call a twin, because it's a twin because this could be from your own blood. You can take your blood and create it, and your own blood becomes your endothelial cells.
So I'll add some more. Kaushik and Dr. Shetty they work beyond the eye. I'll show you something which fascinates us. Can you play the video? Yes, please.
The goal of having such twins is, first of all, to conduct your research and to follow potentially the behavior of the cells reacting to different whatever, medications and so forth, or wound healing. I mean, do you have in mind one day to use them, to transfer them, because I mean, of course, I'm jumping on the key issue behind that, which is the bioethical consideration, especially in our continent. Europe is crazy. And so I wanted to know what is your final goal in getting to that level?
We started with rabbits now for the endothelial cells. First few failed, then the second failed because they were not adhesing. We need a better medium it going in. Now the third one is holding on. So
So there have been some trials going on. So looking into the ethical point of view, you're quite safe when you're getting them from the induced pluripotent stem cells. If you're trying to get them from human embryonic stem cells, that's where the problem is, right? So we have in our country a very robust ethical body which looks into it, which is from and they take into all, and so whenever we are working with these kind of system, we need to get prior authority, licensing and all those things, and those things are all there. And I'm sure that we are trying to get something which will actually go into the clinic. The corneal endothelial cells is what we foresee that will definitely go into the clinic, and also the RP type of cells.
This particular cardiomyocytes is important because the cardiomyocytes was derived from the scleral rim.
Exactly.
And the person is a donor. He's passed away. So that means, imagine, it's the cardiomyocytes pumping heart of a person who died of a cardiac arrest. And we took the...
So I'll just say here, it was very interesting because we got a donor corneal rim from which we obtained the fibroblast. The fibroblast of cornea was reprogrammed to an induced pluripotent stem cell. And from that stem cell is what we got the cardiomyocyte. So, right? So it's
not that we're going to, it's not what we're going to inject it into anybody, but it just, why I showed you is to open your mind about the potential of a regenerative medicine. And this person does not even exist in this world today.
Can I ask a question?
Sure.
Yeah, so this is absolutely amazing. My question is like what we have read about the heart, we have the the electrical impulses which leads to the contraction and so because this thing is contracting and relaxing, so where is the electrical impulse coming from? I mean,
so
it's amazing.
So basically what these have the same ER, electric potentials, and the sodium potassium pumps, and the calcium signaling is very, very similar to you get to see in a cardiac, ex vivo, if you take it from the rat or something like that. So where is it coming from? That's very interesting because they have to have a very good question because it's a lot to do with mechanotransduction here. So you need to have cells all there to have a certain kind of connection with their whole neighborhood. So until and unless that is there, you're not going to see
Go to the B part.
So when they come all together I think that's how the beauty of nature is. When it all comes together is when you actually, it takes quite a lot of time. It takes about 60 days for us to get here.
Wow.
Okay.
Excellent.
And to the right, what you get to see in multinucleated form is a skeletal muscle, again, which is a type of muscle cells, right? And this is for something we are not, because as Dr. Shetty said, that we're looking beyond not only to the ocular, but also the realm of muscle dystrophies and so on. So that was something what we developed in the lab to study how muscle degeneration happens, and if we can identify molecules, okay, which can arrest such degeneration. So this goes beyond muscles, the brain cells, and so on.
Mark, you had it.
I mean, beside the transformation of one cell that you can differentiate, as you mentioned, are you able to get to the level of expansion? I mean, you can get even, potentially from one cell, many others. Again, in the spirit of maybe one day to provide a culture for endothelial cells and replacement of DMEC.
Absolutely. So that's the strength of the technology. It provides you cell as much as you want. So because these pluripotent stem cells, they're not so restricted, so you can grow them as much as you want. The only thing is that you have to take care of them, that they do not take up any kind of mutations as you culture them for a long time. So you have to have your quality checks very stringent. And if you're taking them to the clinic, your levels of stringency goes multifold. So but definitely, yes, that's the thing.
I have a question. Now, we know in nature, as we are created embryologically, we start with an impulse, but then there is a secondary impulse that stops this progression. Like you create a canal and then this canal is closed and there is back and forth. So there is an agonist and antagonist. If you have a sheet of cells that you are creating, how can you stop it at the limit that you want?
So what happens is that your cells, when you differentiate them after some point of time, they become a mature cell, okay? Now, because these are primary, so once they become mature, they will automatically have the same limitations that any cell has, that is cell senescence, aging. So that will definitely happen to these cells, and they will get older and they will die.
They can regenerate later on?
They won't be able to regenerate because once they are matured, then they are just mature, and just like any mature cells, they would behave that way.
So can you also provide like T cells, B cells?
Yes,
lymphocytes?
So they, in principle, there are a couple of, there's already preclinical development going on where they're making NK cells. They are called off-the-shelf.
What she's saying is, does the cell produce T cells, B cells? Because this is because the same cell as your cell.
They do.
It's not an artificial cell because this is modeled in such a way that it becomes like an epithelial cells of a normal person.
Can we order the one we want?
How much time it will take to create a twin? How much time it will take? Because, for example, that would help to personalize medicine as well.
So, yeah, so that depends again. So, for example, the retinal pigmental epithelial cell that you saw, that takes the longest. It takes about 140 days to get a mature cell, okay? That's a big challenge. The corneal endothelial cells takes about 30 days of differentiation. So what's very interesting is each type of cell have different maturation rates, okay, till they retain or get that type. So for example, the neuronal cells, some while the cardiomyocyte 60 and so on. So it depends on what exactly you want in the menu, you know?
Yeah, I am very impressed with what you are showing. This makes me thinking about paper from Jose Alio. Some years ago, he described a technology that he wanted to develop, taking the cornea from a donor, taking out the cells from the donor with DMSO, so keeping the scaffold of the collagen, and then he wanted to take the fat cells of the patient reconstruct all the three layers thanks to a passage to back passage to iPSC, and then to redifferentiated cells with the three layers of the cornea. So at that time, I was very impressed by the paper, but unfortunately, I didn't see the results of these studies in the years after. Do you think you could make that? Because it is like a dream indeed.
Absolutely. So the whole concept, what you said, where you take a cornea, you decellularize it, that's an approach that we are taking as well, because that works as a fantastic bioscaffold for you. Because when you want to put your cells inside for transplantation, you need something for the cells to go in with, right? So bioscaffolds or 3D printing, as you probably would have heard, is also another direction there. So 3D printing is where there is more of a, it's more of a thing where it's a man-made thing where we identify some molecules which we make the 3D scaffold. But the bioscaffold, the decellularized cornea, works wonderfully. You need to take your cells out by using dextran or something, a nice method, because we don't want to distort the collagen and so on. But that's an approach that we are taking as well, because that's how...
As you mentioned, the 3D printing is a new area, and I guess I saw that you're working very hard with Zeiss, and Zeiss is working in this area. I don't know if you are involved with them in that direction?
We have, but we tried, but I don't think that was giving us what we wanted.
Yeah.
Because you can print the cells, but how you integrate was always a challenge.
I mean, that's an altogether different ball game there.
Yeah, yeah,
so,
and that doesn't go at that level.
So in the next 6, 7, 8 minutes we have, I will just re-summarize what we said. So this is what I put it in the group. I call this as a BPATH, the biology-driven post-operative therapeutic and healing, and each one of you in your own clinical setting can see how it works in your own setting. And if it works well, please publish it. Like Mark keeps telling that we need more data of it. Biologists can only come to a certain level, and after that it's the data, otherwise the world will just say it's just hogwash. So if you move to the next one, this is exactly what we said. My choice of lubricant is anything which is, because like I said, I'm I'm more a biologist than a clinician. I use my biology because I know where it works, and that's one of the reasons. I'm not talking about the dry eye here, I'm talking about the refractive surgery here. And you can see that cyclosporin, we also add both 0.09% and 0.05%. Both I use Restasis, Sequa, both. Both are equally good. When I want very fast, maybe in a small way, cyclosporin, otherwise 0.59%. Anti-inflammatory support, curcumin, omega, around 3 to 4 months. And especially when you see a lot of gland dropouts, I add an omega-3 drops. Now, most of drops here comes with Trehalose. Like I said in the second slide, and this is for the post-PRK, I look at the T-cell mediated because that's where the inflammation is. And you can see that most of them are driven by TNF-alphas out here. So that's why you need lifitegrast, you need this, you need all the anti-inflammatory work. And in places like, I'm speaking from Bangalore, with people working 10, 12 hours a day, everybody has a T cell which is very high, and the T cell responses are always exaggerated. Alternative lubricants, we can see all this, what have I written. Post-cross-linking for me is very important because most of my process is driven by laser. Last 10 years, we compiled, and Abhijit is writing the paper. My stability of post-cross-linking laser is much, much stronger than my first 10 years when we were doing just a cross-linking. And Amita and me published the first work in AGO about what different dose sizing. You remember that paper, one of the big papers in AGO. And cross-linking, I'm very careful because I don't want to get any haze because that will offset everything off. So for me, Trehalose with the sodium hyaluronate, that is, cyclosporin is what I use. And first 3 months then, because I don't use lifitegrast here because it be very more stronger TGF mediated response in the first 3 months, and after 3 months I use omega-3 because it helps in resolving the scar. I don't want to go very aggressive on a TGF beta on a post-cross-linking because we need that response, otherwise we don't get cross-linking. And we don't need the TGF and TNF in PRK. That's why you see this is how you start looking at it. So you don't need it here, you need it here. You know, we did some work in the lab. If you use aggressive of this, you suddenly that cross-linking effect is gone. We need lysyl oxidase, we need those bonding. So, and if you go back now to that big chart what Swami had done, you will understand that this is where it is. One area of work, one area we have to really look at is neuropathic pain, which Mark spoke about. I think I've heard this 3 or 4 times, and every time you feel like such a big world out there, which he spoke, because one of my favorite cell-driven pathway is the ion channels, and he's the one who speaks so beautifully, eloquently on this. So if you look at this whole chart, now you start thinking, where does this neuropathic pain come into picture? And of course, there is, this is your, till the Alcon comes, you see it's on the trip channel out here. This is what it's talking about. But look at this. Alcon says that it works on aqueous deficient and pain, but it also has work on sensory. So now you put your biologist angle there. If I had to write this product for dry eye, I would also use it for places where my corneal nerve sensations have decreased, maybe for LASIK or anything which will improve the nerves. So now in this whole pathway, let's look at what Mark's thing is, which are the ones which improves the ion channels. Omega-3 fatty acid does, lifitegrast to some extent does, cyclosporin also does. Trehalose with any form of this works very well because that works. And vitamin D is again a phenomenally good, it improves. If you increase the vitamin D receptor, it changes your trip channels, TPRV1 or improves, pardon?
V1 and A1.
V1. So that means that now you know if you have a neuropathic pain, what would change, and including insulin also has its role in ocular pain. And 2 of my colleagues who use this quite frequently for neuropathic pain in a government setup feel that it's phenomenally good. So this is the summary of what we have discussed over the last few days. I think when you go back and read this again and again, it took a long time. It's not from any textbook. It's not from, it is what we have worked. And so if somebody asks you, is it published? Most of it may be published, not published, but it's from different literatures. But it's okay. Is there anything else? From anybody, from anything else which needs to be, yes.
So one thing I wanted to talk about, we hardly encounter any case of CTK in our practice. But if we do so, we know that losartan acts in a particular pathway of TGF-beta. So can we combine losartan with lifitegrast and try?
CTK is a very different kind of, CTK is not inflammatory.
It's not inflammatory.
It's more of a programmed kind of a cell death. So the best thing to do CTK, according to me, is to have a lot of patience. By 3 months, it will heal itself. 3 to 4 months, it will heal itself. Losartan, if you do, it will be much more challenging because it will block pathways of healing also. For CTK, you just have to allow them to heal. You don't need steroids, you don't need anything. Best thing to do it is improve your vitamin D. All my CTK patients have vitamin D deficiency. That means there is something else which has happened. Improve the vitamin D, add some trehalose or one of these. Omega-3 would be better because if you get a CTK, omega-3 helps because it helps to resolve it. But otherwise, just keeping quiet would be a best one. So before we move to the next one small segment, anything else?
Yeah, I would like to ask you a question. I always wondered about the exact mechanisms of cyclosporine according to the disease. According to the disease. For example, in dry eye disease, we know that we need some months to see the clinical beneficial effect of cyclosporine. But if we shift to an allergic patient, it may take only some days. And if we shift to afflicted conjunctivitis in the case of a pediatric rosacea, it takes only 1 or 2 days to improve after the introduction of the cyclosporine. So the same molecule, according to the disease, has a completely different way of action and most of all dynamics of action. What do you think about it, and how can we go further in that in the use of the molecules thanks to these observations?
Right. So the three conditions you said, the first one is very chronic inflammation. So there is a continuous stimuli. The other two cases, other two conditions you said about conjunctivitis, both are acute. So therefore, the effect is instantaneous, but all the three will be via immunomodulation.
I mean, that brings us back to what we discussed yesterday. Do you think that one day we will have different concentration with specific indication? That would be ideal for us, for cyclosporine as for insulin, as we mentioned yesterday.
Yeah. See, for example, to mark for a little more deeper, if you look at dry eye, there's a heavy driven by MMPs and many other factors. For you look at the markers for an allergy, they're like IL-17 and IL-1 beta. And
VKC is different.
And VKC, all markers are different. So when you have less of these and more of those, and cyclosporine also increases the IL-10. That is a very, very good thing about cyclosporine other than I don't know, I have not seen it with lifitegrast, but it improves, it not only reduces the anti-inflammatory part of it, it improves the it reduces the pro-inflammatory, but increases the anti-inflammatory. That is where cyclosporine completely differs from steroids. For steroid doesn't care about IL-10 and it just
suppresses everything.
Suppress everything.
Can I have a last comment, just?
Yes, please.
Yeah. Just to go back to your what you were saying about corneal dystrophies, and I support your view. We used to do in macular corneal dystrophies lasers, and I have seen some patients that 2 years later on said that finally they had more crisis than before they had no laser. And finally, with time, I understood that the most important thing is to decrease the inflammation, because if you have chronic inflammation, the abnormal gene is turning more, and finally you have more abnormal proteins. So if you can calm the surface, as you were saying, it's really important, and you can see that patients have improved their quality of life. I don't know if you agree with this view.
Absolutely. That's what I always believe that, and this is what he said. You can see that your trehalose if you look at this is a model of TGF-beta dystrophy. That means this is a patient, this model is from a patient who had dystrophy. And you can quickly explain in the interest of time what you see.
So what you're seeing here is, as you said, so corneal dystrophies are basically, you will have protein aggregations, right? So this is what we're getting to see here is a lot of protein aggregations that you have here, okay? This one on top, and
those orange, those pink ones.
Those pink ones on the top here, this one, okay? And followed by later, what happens is you also see a lot of cells that are undergoing cell death. That is what is showing by cleaved caspase 3, and this is also shown here by the pink down below here, okay?
So that's when you add trehalose, it reduces those pink things, which means that that is gone.
Okay, and for additional proof, what we also see is most of these TGF-beta corneal dystrophies are because if you have the aggregation of the TGF-beta induced protein, or BIG3, and that's the one here. Yeah, so basically what we are shown here is that trehalose induces autophagy in these model, and it basically helps us to clear the protein aggregates. So, I mean, we also have published showing that, you know, use of trehalose can actually clear the protein aggregation. It does so in MCD. We have seen that in our patient-derived MCD cells.
Thank you.
So there is proof both from the cell lines that it does work, and you know what you said is in the same line, and no harm in trying. You need to give them something. And what I was speaking once to somebody, and he says taurine also does the same thing. There are some pharmacological drops which has taurine. That is also an autophagy drug.
Right.
Mark?
Excuse me, sir.
Yes.
I have a question, sir. Like you said that the TRP channels, when they are activated, they decrease the pain. They help in the neuropathic pain. So, like in activating the cold channels, so does the cold compresses has any role in it? Because we give it for allergy, and what we are talking about
It does, but we need to have more sustain on the surface. And because by the time you put it on the lid, through the lid, it reduces the temperature. By the time it comes to that temperature is much, much reduced.
Okay,
so that's why these
the
drops.
lid, it is
Exactly.
not that.
Thank you. Yes, the last question. Yes.
So for this corneal dystrophy, we should have eye drop with trehalose
Or
since the
taurine.
first diagnostic clinical to avoid clinical evolution of phenotype.
Yes.
I think it should
so
work.
I will do it.
Yeah, please
Next
do.
week.
Because
and you prove on, do you have any result on clinical OCT evaluation?
Absolutely. Just that's why, you know, please try it, because this is, there's no harm in doing it. No ethical reasons why you should not be using it.
Absolutely. So I will. Very nice.
Thank you. I think we covered most of it. This is a summary of everything. So the last session will have Dr. Shiham is going to be here, Dr. Murad, Dr. Wasim, Dr. Yarha, Dr. Anand Bandari, you need to stay there. Dr. Rashid can take up, they won't have one person here. Murad is not there, you can be here.
Dr. Anand Bandari has become the guy who is guiding the penguin.
Dr. Anand, you have to be there. Yeah, I only made it. So we go to the last session of this Deoss. Dr. Frederick is going to speak about Tyson keratitis. Somewhere.
So thank you again for the kind invitation, and we'll be also, I will insist on inspiration in this case. We will discuss of this case. So I would like to present Tyson superficial punctual keratitis and ask you and discuss with you or recognizing perhaps a new actor in inflammation in this disease. So Tyson is a bilateral recurrent corneal epithelial keratopathy that affects the central of corneal opacity. You all know this clinical aspect. Cell present bilaterally as numerous strictly epithelial oval shape, small, white and gray. All, as you can see on this slide. Clinically, it can be really source of bad quality of life with recurrent attacks, eye irritation, foreign body sensation, mild pain, photophobia, tearing. You well know, I hope, the ocular discomfort that they have. The clinical course may last with children 2 months, as 41 years, so it could be quickly or really long in the life with patient. And this entity has been described in childhood, or classically more later. The average is 29 years. And classically, I'm sorry, it's predictably a female gender. So, what's the physiopathology? Quickly, etiology, we don't know. Etiopathogenes remain unclear. Both viral and immunological mechanisms have been implicated as potential trigger. Some have described a significant association with HLA-DR3 and HLA-W3. But like we saw, there is an interesting element in this paper showing confocal aspect in tiger zone. What's really interests me, the highly refractive dots and aggregation of dendritic cells, so macrophage, in the layer of in the basal cell layer of corneal epithelium. There are also aggregation in dendritic cells, as you can see, in the subepithelial nerve plexus of the cornea. So, this clinical aspect suggests this accumulation, aggregation of longer-run cells, suggests an immune response to an unknown incitating agents. So, based on this classical, the heritage of the treatment of tiger zone, I hope that we do all the same, could be first artificial tears. Patients with mild symptoms are really quick and nicely managed with artificial tears. Corticosteroid, the use of steroids is classical and are significantly disabled by pain, photophobia, and reduced vision. So, classical treatment of this superficial keratitis of tiger zone. Sometimes we could have corticodependency or resistance. So cyclosporine can be used as alternative. Different concentration of efficacy have already been published. And sometimes tacrolimus, if you have cyclosporine resistance, will also be used in this pathology. And classically, as you can see, you treat the patient, all is better, and you hope you will not have some recurrence in the year or the weeks later. But sometimes it's more difficult. I will report 2 cases, a young woman of 45 years, 1 year of history of recurrent bilateral episode, described as burning sensation, decreased visual acuity with corticodependency. I was very proud of my formulation of topical cyclosporine 0.%. I tried. She didn't support it. Some week later, I tried my formulation of tacrolimus 0.02%. She didn't support during 3 weeks, so I was with no solution for the moment. As you can see, we have a classical aspect of the clinical epithelial grace dot. OCT confirmed the superficial aspect and condensation of cells and epithelial level. The second patient was 3 or 4 years history of recurrent bilateral episode with ocular irritation, photophobia, decreased visual acuity. She was working, she was really complicated for working in a bakery. She was corticodependent and the same. She didn't tolerate my topical cyclosporine for 3 weeks. I tried the same, tacrolimus. The first week it was better, and 1 month later, no more amelioration. So as the same, clinical aspect, clinical velocity. So, what can we propose? And this is aspiration. I ask you, what can you do in this case? I hope you can help me. Nobody. You don't want to help me. What? Oui, Marc. I didn't understand.
Did you try hydrocortisone short term?
Yes.
It worked?
No. It means slowly amelioration after you. Normally you try to avoid some complications, so you stop, and you have a recurrency every time. So in the second case, I told for you it was 5 years of recurrency with different ophthalmologists.
In some mild case, you can use azithromycin, which has an anti-inflammatory effect. So this in some cases, and in some very refractory cases, I use contact lenses, soft contact lenses. So they are not symptomatic, but they have still the infiltrates.
So I won't say really high level. There is a problem in this little inflammation, ocular surface of tolerance, or some azithromycin drops. So they didn't support it. In one case, I tested. I didn't. I changed my strategy in the other. And contact lens, both was unable. I tried because it's a classical. The next level should be PTK, though, but they didn't want to with contact lens. Even the second was worse. I tried because it should be a nice improvement in the clinical aspect and the quality of life, but she didn't want this solution. So another idea.
Since you showed some infiltration of intraepithelial lymphocytes, liftigras might help because it prevents.
Yes, but in France, we don't have the lucky. It's not this problem. So, yes, a last suggestion. I will explain what I decide to do. The problem is that it could be recurrency because the physiopathology is an inflammatory. So, as you see, the recurrency are not always in the same place. So I didn't try this. So what I tried to, for this patient, because I was really, first was a really bad quality of life. Yes, I did it. I tested the three levels. So, yes, I remember the implication in the confocal aspect of activation of macrophage. So I was thinking about what is pro-inflammatory in ocular surface, and we all know and we all forget, I think, the complement on ocular surface. So I realized that C3A and C5A, who are pro-inflammatory, they was matching the mechanism. The first thing we know about the physiopathology, but activating of macrophage was matching with the activity of C3A and C5A. So I was proposed to the girl to try off-label treatment with a drug that is 30 years on the market with no side effect. I tried to block the activation of complement with a blocker of C3 convertase. It's called NAGA. As you can see in this paper, NAGA is also powerful in high inflammatory of VKC and AKC. So from it was physiopathology. Why not a drug to try with this patient? And I tried in both patients with anacetyl, NAGA, and thialose. They always already, before I start NAGA, on thialose. So we saw slowly, baseline, 3 months, 6 months, lower clinical aspect with low functional plaint. Good, best quality of life. Both told me you saw my life because really they were really a good bad impact on quality of life. So in the two patients, all was clearly in clinical. The second one, it was really young. She was able to work again. So in conclusion, complement seemed to be activated in this physiopathology of this in these two cases. They suggest that NAGA could be useful in TSPK treatment, and I think clinically study will be useful. And exploring C3A, C5A in tears of this patient. So I was really thinking about the whole Bangalore team because you have a huge series of patients, and we can make a clinical study to evaluate after corticoid or not if it can really in 3 months. In 1 month, you are really better. In 6 months, and of course, during these 6 months, no one recurrency. So, a new actor perhaps and a new treatment if you are in impasse of therapeutic. Voilà. Thank you.
Thank you.
Do you have questions? No question.
Any questions for Dr. Friedrich? All right.
Mark.
We can go to the next speaker.
The last one.
Oh, sorry.
This is always the same question about the pathogenesis. You say that this is either inflammatory disease or viral disease. Immune disease. We don't know what exactly. I personally tried NGS sequencing, trying to find viruses. Didn't succeed in it.
Yes.
So did you, in Bangalore, if you have a lot of patients with Tygason, did you try to find viruses? Yeah.
I wasn't paying attention. I was just
With your series of patients with Tygason, did you try to find viruses into the tears using NGS sequencing or something like that?
Not that I remember. I should ask Dr. Shetty about it.
Okay.
So all publications that try like you to find virus fail in sequencing. So we should try all together.
Yeah.
Yeah, I think so. Yeah.
Thanks.
Good. Thanks for the session.
And now Professor Beatrice Kochner will talk about Demodex.
Complemented this.
In practice. And this is a very interesting session, by the way, because we are having the real life in ocular surface. Tygason, Demodex, and filamentary keratitis, all what we are seeing in our daily practice.
Bon appétit, I would say, because Demodex is a good moment of the day to think about these crazy animals. So I get that Demodex, you all know, this funny residence that is certainly in some part of your body, which is quite disgusting to imagine, I must say. And so it's known since many, many years, except that so far we didn't get this targeted treatment that makes that you were maybe not interested in trying to find out if he was there or not. We are talking about actually 100 species of mites, and with 2 key of them, which are located in the eye. And as you see here, beyond 60 years old, 80% of our body got this kind of residence on the body, which is, again, something that it's quite scaring, I think. So the Demodex folliculorum is located in your ciliary follicles, and the Demodex brevis goes deeper inside of the sebaceous and the meibomian glands. What is important to consider actually maybe the link between the rosacea and these blepharitis that may be induced by this agent, even if it's still under controversies. So what is truly well identified, it's what can induce this agent, which is called the Demodex blepharitis. It's really characterized by the current that can be considered to be a pathognomonic sign, but it's not only that. It can be only eyelid redness, inflammation, and ocular irritation. We can estimate that the number of Demodex is 30 times higher when the sleeves are present. And on top of that, the dandruff carriers bacteria and mycotic agent that can be source of additional inflammation. So in saying that, there are so many studies, and I forget, I'm sorry, Frédéric, to mention the one that you conducted in France that has clearly identified the epidemiology and the prevalence of this infection. As you can see here in this American study, 50% of the population globally will present Demodex with cohorts that you can identify and associated in 60% of them with true blepharitis. That can be blepharitis, but it can be pterygium, it can be ocular surface disease in global consideration, and again, potentially rosacea. The different figures that you can observe can be summed up on this slide, and as I already mentioned, dandruff, misaligned lashes, meibomian gland dysfunction, inflammation of the eyelid margin, inflammation of the bulbar conjunctiva, corneal infiltration, so many other signals that can be an alert, not only the corrects. So we conducted with the ESCRS this survey, asking how frequently does Demodex blepharitis negatively impact the patient's daily activities. And as you can see here, their life is impaired. In 93% of them, we are talking about, of course, the elderly population. And when you look at the symptoms, many of them can put together all the different symptoms that can go from dry eye to, of course, itching, or even up to this very significant and severe signal of inflammation. As you can see here, The key signs and symptoms that are reported, that came from an article in 2022, goes not only from itching up to blurred vision, but also impact significantly the night driving. So all these different impacts on vision, that means that it can be a specific approach of one category of severe inflammation among the global MGD. So that's why it's important to consider symptoms. And again, coming back to this survey conducted by the ESRS in 2024, we're asking for those patients with ocular surface disease complaints, how often are you considering and looking for Demodex? At that time, it was only 20%. As the same, when we were looking for that in Demodex blepharitis, when we were looking for corax, only 30% of the medical community were looking for corax. You know how we can categorize this patient. Actually, there is an official grading for the corax, as you can see here. The more you can have, and of course, you can go up to these grades 3 and 4. You can imagine that in these cases, the patients are really embarrassed. We also all know the way of removing the lashes and putting them under the microscope that nobody of us is certainly doing. The confocal microscopy is also a funny approach, and I will never forget, Serge, the funny presentation that made you so popular in France when you were talking about the family of Demodex that puts together in the glands actually the children, the parents, and of course the tomb, because I mean, after this very short life of 10 days, all the particles are still remaining there, are certainly keeping the inflammation. Looking at the current management that are available today in your hands, we know some topical or oral antibiotics, ivermectin or metronidazole. Just thinking about the toxicity of this agent, it's quite uncommon to manipulate them in many of these blepharitis. The added value that makes me coming on this stage today is because we have two new treatments, actually one which is not true new at all, but that came up in France thanks to Thea again, which is a tea tree, and the tyrpanum for oil that goes with it, as you will see later on. You can, of course, add to that, and I think that it's still interesting to combine the treatment, whatever the severity of the blepharitis, with the non-specific MGD management, you wet, you warm, and you express. And of course, there are some ointment, but all of them have a very poor reputation because of the poor tolerance and the toxicity. So we can mention first the virtue of the tea tree that act as an antimicrobial, anti-inflammatory, antifungal, antiviral property, good for everything. It can be, of course, it could kill, for instance, the Demodex. It's a natural essential oil. And for us, we were lucky to have Thea putting together this one with some sodium hyaluronate that makes the terpinane coming from this oil combined to it, and that ends up with a product very well tolerated. The beauty of it, as you can see here, it's to definitely improve the comfort of the patient and to improve with all the dosage level, the symptomatology and the severity of the inflammation. It's only 1 month of treatment, 1 wipe per day in the evening, 2 wipes per day, morning and evening, because it comes with 2 dosage, but it works well. And of course, there is this new promising topical treatment coming from the US with the FDA approval, very expensive by definition, that can be quite interesting because it should paralyze and eradicate the Demodex mites by selectively inhibiting the parasite, specifically GABA channels. That means that it kills specifically these mites. So there are 2 great studies coming from that, which are 2 randomized, multi-center studies that have demonstrated after 1 month of treatment the significant decrease in terms of corax, whatever the grade, the mice eradication, the erythema cure, with no bad signal in terms of tolerance, no significant adverse event. And so in clinical practice, they are able nowadays to tell you that the treatment should durate 1 month. You can follow up 2 and 3 weeks and even conduct a second cure. It's a second-line treatment that's important to consider. That means that you start first in trying to control the MGD. And based on the second study, the reduction of the corax, the reduction of dry eye symptoms are definitely significantly improved. So I would say that the Demodex today you can definitely think about it. As soon as you have variety that can resist to the treatment, you need to look for corrects, which is pathognomonic, and we do have now a targeted treatment, the Lotiliner and the T3. So I think that it's the end of the happy time for the Demodex, at least on our leads. But to me, there are still remaining questions that I would like to bring to your attention. We were underestimating before because we were not having any targeted treatment. But maybe tomorrow, especially under the American pressure that helps you, of course, to the distribution of new treatment, we may overestimate if we have one easy treatment to help to manage. So I think that we need to define the barrier. When should we kill this I would say, resident on our body, when actually we can live with them on a very easy way normally. Thank you very much for your attention.
Thank you.
And of course, if I allow me to say a few words, if you want to explore Europe, we do have this European Society, Eucornia, and you are more than welcome in Porto, end of May, to explore Portugal, which is a very, very, very nice and sunny country. Thank you in advance, and you're welcome there.
Thank you, Beatrice. And really, Demodex is a real issue because it was very underestimated and underestimated, and now it's overestimated, I think. Even in Europe and in our countries, because also all the machines that they are selling, there is a software for Demodex testing, which is I never see that, but maybe it's pushing by the companies.
Yeah, but I think that it's like MGD, you know. I mean, we already mentioned that yesterday. So I think that Demodex, when you have this kind of resistant varieties, makes sense to, of course, whatever the T3 or whatever this new product, if it might be available sooner in your country, then we may have it.
I have a question.
Yeah.
What's your threshold for the treatment? When you see any choleritis, you treat. You treat when there is symptom, or what's the criteria? Because I do have some experience how to treat it, and even I tried the Lotiliner. Apart from it's expensive, it's doing very well. So what's the criteria? How do you approach it?
I think that the consideration is in two, I would say, two scenarios. The first one is if you want to go to a cataract surgery, for instance, or if the patient spontaneously complains about this inflammation. In that case, I would start to treat a regular NGD. If it still resists, I would use, especially in France, the T3, because I think that it's definitely part of the inflammation. So it's all about the way you want to make the cataract surgery first successful and the comfort of the patient. And again, it's 50% they do have cataracts, but I would say that at least 20% of them, they do complain about that.
I may add, apart from the complaint, not any Demodex to be treated, but if I find at the lid margin telangiectasia, those blood vessels, so I know that there is an inflammatory process as well behind it, so maybe that triggers me to treat it earlier than
yeah, but I think that it makes sense.
I have only, like 15 years ago, I was in Germany, I did my fellowship, and they discussed this, they said should not be available very rare in Europe, and more related to the hygiene. From your experience in clinical practice, did you find it related to hygiene of the body, or this comes to anybody could come?
You know, I have terrible echo. I'm not sure that.
No, you can expect which patient have Demodex infection from the hygiene or from which country is coming.
Yeah, I mean, it goes with the age anyway, and we got that on all our body. But I think that, again, you start to treat because you want to make your patient happy. So I think that the proper time, it's when you feel any discomfort. So I get that. I don't know if I pick up your question.
No, still my question, what people saying, is it related to the hygiene of the body or
hygiene.
no?
Yeah, but hygiene is not good enough. I mean, I think that it's not enough because, I mean, it does resist to the regular cleaning.
No, but from your clinical experience in your clinic, did you see it more in less hygiene people or in diabetic patients more related to the immune system or to the hygiene, or could come to anybody?
Yeah, you know, I think that we don't have the answer so far because that's really we were not considering this kind of assessment before. So I don't. I mean, you mean if I'm not? I don't want to spend hours on that question.
So can we discuss that later so that we move on to the, because
Yes.
we're
We
in
need
the
to
interest
move
of
to
a lot of
that,
people have flights to catch. So I would
Yeah.
call,
Yeah.
we can discuss once the session is over.
Yeah.
So we have,
We will discuss that tonight.
so we have Dr. Sushmita Shah, senior consultant. Now she's started her own lab in Mumbai, one of the few who decided to go the research route, and she's going to speak about a case, conjunctival inflammation, and also a small case which she has handled. Thank you.
Thank you, Dr. Rohit, for that kind introduction, and thank you for the invite as well. And let me also take this opportunity to thank the entire organizing team for all the hard work that they have put in to make this amazing event. Thank you very much. So let me introduce you all to the Demodex, which is found in India, or rather I should say the Indian Demodex. So this was a 45-year-old male who presented to us, again, history as a businessman, and a history of recurrent chalazion from many years have had undergone excision, curettage in the past, and he had a swelling in the left upper lid, and which had actually caused a mechanical ptosis, and he was very embarrassed about it. So when he inverted the lid, we found this lesion, a 5.5 by 3.8 millimeter lesion, as you can see, and there is intense papillary congestion involving the upper tarsal conjunctiva. We started him on the normal treatment of oral azithromycin, warm compressed lid massage, and also oral azithromycin. He refused, but then after a week, we did not find any clinical response. So, and the patient refused any kind of surgical intervention. So going back to his history of recurrent chalazion, we decided we wanted to rule out Demodex. So we did the eyelash microscopy. This is something very simple and anybody can do it. We just need to epilate 2 lashes per eyelid and then put it on a glass slide and cover it with a cover slip and just add about 20 microliters of normal saline. And you can very easily see it in a very ordinary routine binocular microscope. Just see it as a 10x and then in the 40x magnification. And so this is what we found, the Demodex. This image is not from this patient, but from another patient. And we started him on, because since he refused surgery, we had to do something conservative. We started lid scrubs with 50% tea tree oil. This was a technique described by Gao et al., a very brilliant and lucid paper published in the British Journal of Ophthalmology in 2006. And we also advised him to do daily lid scrubs with 15% tea tree oil at home, along with the tea tree oil face wash and shampoo. Now to just quickly describe how the clinic, how we do the scrubs, we just dip a cotton tip applicator in 50% tea tree oil. We usually mix it with an almond oil. And we have to make 6 strokes from one end of the eyelid to the other, as you can see in the photograph. And at the end of 6 strokes, we wipe it off with the dry cotton tip applicator. Now the reason behind this is, as we know, the tea tree oil kind of paralyzes the mite, and it kind of forces it to come out of the meibomian glands onto the surface. And after this, we wait for 5 minutes and again run a dry cotton tip applicator to clean up the eyelid margin. Now this sequence is repeated 3 times over a period of 30 minutes, and we do it on a weekly basis along with lid scrubs with 15% tea tree oil daily, which we used to give it off to the patient. And this is the paper. If anybody is interested, can go through it. Absolutely brilliant paper. So this is how the lesion resolved. As you can see, the first photograph, day 0, and then gradually we did not touch the lesion at all. We just did the tea tree oil treatment, and you can see beautiful resolution of the nodule, how it shrinked into a very small lesion. And there was we continued the lid scrubs for almost 3 months and continued the lid thing also longer. And there was no recurrence at the end of 2 years, and eventually we could successfully do a femtoLASIK for this patient. Now this is my second case, again a male, 26-year-old younger male. And he also had history of recurrent chalazion and also a history of chalazion, surgical intervention. 6 and 6 vision with glasses, but see this lesion, see the mass. The mass was extending from the palpebral conjunctiva even up to the bulbar conjunctiva, and it caused tremendous amount of trouble for the patient because it used to pop out whenever he tried to go to the gym and things like that. So he was very, very troubled. And again, because he had undergone a surgery, he and his family refused us any kind of surgical intervention. So this is you can see that. This is the routine epilation and the microscopy. You can see how the Demodex is nodding its head. So because the patient refused the surgical modality, so we did the same treatment as we had done for the previous patient. And see at the end of 4 months, that is 16 weeks, significant reduction in the lesion size, but somehow the lesion did not respond completely. So at this point, I think we were both patient and me, we were tired, and then we thought of adding oral ivermectin to his treatment, but that kind of actually became detrimental. The lesion suddenly increased in size. This possibly is because of increased inflammation induced by the ivermectin. So at this point, then we did not have any choice but to do an excision biopsy. As and post-op, see the photograph on top, very clear. The lesion was not there, and very interesting the histopathology of the lesion that we got. So though it was concluded as a pyogenic granuloma, but they also noted multinucleated giant cells, which my pathologist said that this is something which we usually don't get in a pyogenic granuloma, but somehow they could not find any Demodex within the lesion. That possibly also because we had treated the lesion for a very long time. My third case is quick. Again, a 30-year-old male. So discharged, and he even complained that he had some blood streaking in the morning on that day. Again, once we inverted the lid, we found the lesion, and you can see some engorged blood vessels also. The lesion size was huge, by about 5 by 4.6 millimeter. And here again, eyelash microscopy, and you see multiple of those Demodex. These are the follicular, which are nodding their head and very happy. So we did the lid scraps, first seating, and also gave him tea tree oil to use at home. I also gave him oral ivermectin, which in hindsight was possibly a mistake. Patient was a little irregular with follow-up, but then the lesion did not showed a very atypical kind of resolution. It kind of became papillomatous and things like that. And after this, we kind of lost follow-up with the patient. And after multiple phone calls, we somehow managed to get in touch with him, and he said he had got the lesion excised somewhere else. So this is fine, but the risk of recurrence still remains. So we looked at the literature, and we could just find one case report, which was from South Korea, which was published in the Indian Journal of Ophthalmology. This again was in male who had these nodular lesions in the lower lid palpebral conjunctiva, and since they did not know what this was, they subjected the patient to excision biopsy, and even they got these multinucleated giant cells, and they even found the Demodex within it. Their line of treatment was same as what we did, 50% tea tree oil lid scrubs in the clinic weekly, and 10% tea tree oil shampoo scrubs at home, and had good results. So to conclude, Demodex may have varied presentation. All important to note that in all our patients had history of recurrent chalazion, and none of these patients had cylindrical dandruff, and diagnosis was pretty easy with direct microscopy, and tea tree oil was quite effective, though ivermectin, I possibly feel that it increases the inflammation, so may not be a great idea in this situation. And just to add to what our panelist was asking regarding hygiene of the patient, well, these were all from pretty affording families, so I don't think hygiene is an issue in this case. Thank you so much.
Thank you so much. Very interesting, really very interesting case.
Thank you.
And yes.
The question from without sending to the labs, this dandruff always available, this cylindrical dandruff in the eyelids?
I'm extremely sorry, I really can't understand.
No,
I can't hear it.
From the clinic on the slit lamp, you can make diagnosis for as Demodex infection. From dandruff, cylindrical dandruff?
Without sending it to the lab.
Yes, yes. No, so exactly, so exactly. So what Professor Kochner has also mentioned, those collarettes and demodex, we have those set of patients are different. They have dry eyes, they have all the things. Those are very typical presentations. So whenever we see those, we just epilate the lash and we do the macroscopy and do the treatment. But these cases, here the pathognomonic feature was the lesion on the conjunctiva, the conjunctival nodules which were there, and there were no collarettes, no cylindrical dandruff. But again, the history of recurrent chalazion, which was the most consistent, and that was kind of the clue which made me think that this is possibly demodex.
Can I answer on the question that I was not able to understand from the podium? So is it depending on the hygiene of the skin? The answer is no. It has been demonstrated that it's more depending on the quality of the skin, like the oily skin, for instance. That's why certainly might be related more in rosacea and this kind of skin. And actually, when you clean your skin, you may increase actually the inflammation. So, and it's a global process. That's why with the desquamation that occur with the aging process, you see them loving the skin of the old people compared to the young one. But it's not depending on the hygiene.
Okay.
That was the question, I think.
Thank you.
I'll present the next case.
Let her finish.
Okay.
At the end, you can sit there only, so you can then, so that those who are going in the evening can finish them off, who are taking a flight. So she's going to speak on Amrita. Amrita is going to speak on filamentary keratitis.
At the outside, I'd like to thank Dr. Rohit Shetty and Deoss for this opportunity. A very good afternoon to everyone. Before I dive into the management, I would just like to explain the etiopathogenesis in short. A filament formation in filamentary keratitis consists of a vicious cycle. And why is this important from the point of view of management is that every point in the cycle needs to be broken for ultimate resolution, and this is true for most of the recalcitrant patients. So there is some kind of an ocular insult which causes damage to the epithelium and the basement membrane. That is a weak spot where the filament starts forming. Now this filament consists of these desquamated epithelial cells and mucin, and this is due to the abnormal mucus to aqueous ratio. Added upon this is the lid dynamics. That is, with every blink, there is shearing forces on these early filaments, leading to elongation of this filament, which in turn causes inflammation, and that's how the cycle is completed. So this cycle has to be broken at every point to prevent recurrence. So this is how the filament looks, and classically one end moves and one end is attached to where there is the damaged epithelium and basement membrane. So the management consists of two main things. One is the filament per se, and the second is the underlying risk factor. So it could be very short filaments, very few filaments, or too many also. So firstly, you need to identify what is the risk factor. Literature has shown that aqueous deficiency dry eye is the most common, but is closely followed by autoimmune disorders, allergic eye disease, viral keratitis, and many ocular surgeries including penetrating keratoplasty. So as such, per se, for the filaments, you need not investigate, but if you're trying to find out the underlying cause, a workup, a new autoimmune workup is a must to know in these recurrent cases. And also a thyroid function test would help you identify superficial limbic keratoconjunctivitis. The position of the filaments somewhat gives an idea of the underlying factor, which would be, in cases of dry eye, it could either be diffusely present over the cornea, or it may be on the exposed interpalpebral zone. In the viral keratitis cases, mainly they are around the limbus, and of course, in any surgery, they are usually around the suture. So this is from Deoss 3, where filamentary keratitis per se is not a standalone diagnostic threshold, but what it indicates and what we need to understand is there is a significant tear instability and epithelial damage. And this has to be borne in mind while deciding treatment for each and every patient, which can be different. So one important point that Deoss 3 has highlighted is again about the lids, which I would like to remind you is the reason for the perpetuation and elongation of the filament. So the most simple procedure, which is pointed out in theory, would be removal, mechanical removal using a tying forceps in the OPD. But here I'd like to point out the most important point in this simple procedure being when you remove it, it should not be just taken as a very simple procedure. When you remove it, you have to be very careful about not damaging any more epithelium or basement membrane around the filament as well. This is a very important point in this simple procedure. Remaining things would be N-acetyl cysteine solution. This is not commercially available in India, of course. It has to be compounded by us using the respiratory solution and topical hypertonic saline, which also has an added advantage of increasing the hydration. A bandage contact lens, it would just form a mechanical shield to prevent the shearing effect of the lid again. But one point I'd like to highlight here, prolonged patching and prolonged contact lens use itself is a cause of filamentary keratitis. So you have to maintain a close follow-up when you put a BCL for these patients. Preservative-free, electrolyte-rich artificial tears, like we know, they will restore the epithelial barrier and also they will minimize the epithelial cells from exfoliating, which is the actual core of the filament. And if you use medium to higher viscosity, for example, hyaluronic acid, that sodium hyaluronate, it will also help you avoid the shearing effect of the lid also. One step above lubrication would be autologous serum, where the patient's own blood is used, and this works very well because it has the additional growth factors in them. Other techniques would be tear retention using punctal plugs, or yesterday, like we discussed, punctal cautery also works well, especially in the aqueous deficiency dry eye patients. For the lids, we have an added advantage of using botulinum toxin if it's not resolving with the earlier method suggested. Also, an amniotic membrane in the very severe cases will have a multifold effect in the sense it will help from the lids, it will help the surface improve, the epithelium can regenerate, and also it's anti-inflammatory in nature. Coming to the immunomodulatory drugs, which are quite a mainstay right now for these recurrent patients, of which we have discussed a lot in the previous table as shown by Sir, compiled very well, including all the primary and the secondary mechanisms. So the choice will depend on each patient, how good or how bad it is. And steroids may have a role in the acute phase, but you cannot depend too much on them in the long run. So basically, you need to classify it into inflammatory and non-inflammatory and then take it forward from there. Basically, it's usually mechanical removal followed by bandage contact lens with topical lubricants and a mucolytic agent. But if you feel this is not resolving or it's recurrent in any way, you can always add on the remaining therapies that have been discussed. Having said that, just showing a few patients. So this is a case, this was a very rare case actually of acrodermatitis enteropathia referred by the dermatology department. I work in a medical college, so I have a lot of multi-system references. And this is a rare disease where there's zinc deficiency. I could not even find this cause in the latest publications, but mere correction of the zinc deficiency along with the basic treatment actually helped the patient a lot. Allergic eye disease, these are usually younger patients and they have short filaments which resolve beautifully in a short time. However, the recurrence may be there, and that is why an immunomodulatory agent in the form of cyclosporine, tacrolimus, and very recently have started using lifitegrast also. In the case of viral keratoconjunctivitis, sometimes again there can be, in the healing phase, there could be filamentary keratitis, which can also be handled in the same way. This is a patient who was undergoing chemotherapy for metastasis to the brain. We had started the treatment, she was under control, but she had some persistent inflammation for which we did add some cyclosporine, the dosage of which is available in 0.5 or 0.05 or 0.09 is usually what we start with. And then if we feel, because the surface is already compromised, and like we discussed, increasing the cyclosporine dose may not increase its therapeutic effect, but may increase the side effects. And then finally, you have your autoimmune diseases, where it's a very recurrent and prolonged course. I'm just finishing. We have some raw data where it's usually more common in females, middle-aged female, and in our hospital also, we have an in-house rheumat department. So we may just be biased with a lot of aqueous deficiency cases presenting with filamentary keratitis. So what does the future hold for us? If you look up the textbooks, this is all the treatment that you will find. But like I discussed, every patient is very different, and a tailor-made approach is needed, for which we will need to know how much inflammation is there. So the inflammatory biomarkers, like we have a stall just outside, if they tell us how we can identify and rather quantify them, that will be very, very helpful to tailor-make up treatment for every patient that we are seeing. Other newer things which are under review, not extensively studied, are the Janus kinase inhibitors, which are used for refractory autoimmune conditions, Manuka honey, as it was discussed, resveratrol, and also platelet-rich plasma, which is something like autologous serum, but has a much more concentration because it's plasma and not serum, as compared to autologous serum. So when autologous serum also fails to work, this may be tried. So this is my last slide. This is what I gathered from the conference. And yesterday I thought these are the 4 things that will probably help us in filamentary keratitis. Any suggestions or discussions is welcome.
Maybe discussion at the end because of that
Yeah,
time.
discussion at the end. Thank you. So, thank you, Dr. Amrita. And since you mentioned about those tear fluid, there are some people who have tried out, and the reports are here. In case if you have not collected it, please feel free to collect the biomarker kit. We now invite Prof. Alagai, who's going to speak about recurrent corneal erosions.
Good afternoon, everybody. First, as a board member of the Deoss, I would like to thank Dr. Rochetti and all the team of Narayana Hospital for their hospitality and their hosting the 3rd edition of the Deoss meeting. I'll be today speaking about recurrent corneal erosions. First, a quick review. By definition, it is a relatively common disorder of defective adhesion between the corneal epithelium and the basement membrane. It is... No slides?
Slide, please.
Okay. Again, it's a quick review. It's by definition, it's a relatively common disorder of the defective adhesion between the corneal epithelium and the basement membrane. It is characterized by repeated episodes of spontaneous epithelial breakdown, which typically presents with sudden pain on awakening in the morning. The course is often chronic and relapsing. The importance of RCE is that its chronic and unpredictable nature, and this may lead the patient into depression and anxiety. Sometimes, since the erosions usually occurs during sleep or on awakening up in the morning, some patients come to fear falling asleep and experience varying degrees of insomnia. The etiology of RCE, the most common cause is previous corneal trauma, often from a fingernail or a T-branch or a paper cut. The second main cause is corneal dystrophies, mainly epithelial basement membrane dystrophy, Reese-Buckler dystrophy, lattice dystrophy, macular and granular dystrophy, and even Meesmann dystrophy. Other causes, less common causes, are diabetes mellitus, bullous keratopathy, and previous PRK or corneal cross-linking. On examination, you can find a variety of conditions. You may find a frank epithelial defect, or you can see loose redundant epithelium, or you can see negative staining or map-dot fingerprint changes in cases of epithelial basement membrane dystrophy. And in most of the cases, you will find the cornea is normal with no clinical signs in between attacks. Differential diagnosis includes recurrent herpetic epithelial keratitis, especially the geographical type, neurotrophic keratopathy, severe dry eye or exposure keratopathy, mechanical epithelial defects. Maybe the most important differential aspect or disease is recurrent herpetic ulcer, but the most important differentiating aspect is the pain. Pain is severe in recurrent corneal erosions, while it is minimal or present or absent, sorry, in recurrent herpetic ulcer. I posted this slide because I faced many patients who were misdiagnosed by other colleagues because of this only sign, the symptom of pain. The aims of management of RCE is to promote stable epithelial adhesion, prevent recurrent epithelial trauma, control pain and inflammation, and adopt a stepwise approach from conservative to invasive therapies. The stepwise therapeutic algorithm includes step 1, the acute episode management, step 2, long-term medical prophylaxis, and step 3, surgical intervention in refractory cases. The acute episode management includes lubricants and ointments, topical antibiotic prophylaxis until the epithelial defect heals, cycloplegic drops for pain control, which is rarely needed, and also oral analgesics, but beware of using topical anesthetics. Bandage contact lenses are important in the management of RCE. They are used in acute episodes or for short-term prophylaxis. They provide mechanical protection and pain relief, and also they promote epithelial healing. They requires antibiotic cover and close follow-up for fear of infection. The recommended lens, it should be a thick, high water content silicone contact lens to be worn on an extended wear basis from 3 to 6 months. The long-term medical prophylaxis includes frequent preservative-free artificial tears during the day, lubricating ointment at bedtime, hypertonic saline ointment at night, short course of topical steroids to control surface inflammation, oral doxycycline in patients with MGD. So when is surgical management considered? It is considered in persistent or frequent recurrences despite adequate lubrication and prophylaxis, when there is significant impact on patients' quality of life, and recurrent episodes over months despite compliance. The surgical intervention may be one of the following: anterior stromal puncture, epithelial debridement, diamond burr polishing, and/or phototherapeutic keratectomy. Anterior stromal puncture induces focal scarring to improve epithelial adhesion. They are best used for peripheral or off-axis lesions. It is a simple and quick office procedure, and here is the photo of the post-puncture state. Diamond burr polishing includes mechanical removal of the abnormal basement membrane. It smoothens the Bowman's layer and promotes better epithelial adhesion, and it is more effective, especially in epithelial basement membrane-related RCE. It is usually combined with bandage contact lenses post-operatively. Phototherapeutic keratectomy is used, we use excimer laser ablation of the superior cornea and Bowman's layer. It is highly effective for central or severe refractory cases. Ablation depth between 4 to 8 microns, and it allows precise and uniform treatment. But it is more expensive and less widely available. Choosing the right procedure depends on the location of the lesion, whether central or peripheral, underlying etiology, post-traumatic or epithelial basement membrane dystrophy, the severity and the frequency of recurrences, and the available equipment and the surgeon's experience. This is a case report where a 32-year-old male patient presented with repeated attacks of corneal erosions with family history of similar conditions. The mother, the sister, and the son, they suffered from the same condition. The corrected visual acuity in the right eye was 0.4 and the left eye was 0.05. Slit lamp examination of the cornea revealed scattered grayish-white, slightly elevated opacities bilaterally, and the diagnosis was Reese-Buckler dystrophy, as you can see in the photo. The management plan was to provide the patient with bandage contact lens to be used for 1 month with lubricants and antibiotic drops to alleviate symptoms, and a phototherapeutic keratectomy in the left eye, the amblyopic one, was performed aided by diamond burr polishing of the corneal surface. Here is the superficial keratectomy with diamond burr polishing. Can I advance the movie? I can do that. As you can see, after removing the epithelium, the basement membrane or the Bowman's layer is irregular because of the dystrophy. Sorry, I planned to fast forward it, but I can't do that from my side. And then the diamond burr, it's a 5mm rough head. Just 1 minute. And here is the diamond burr to be used. It is a very nice, simple instrument which has a great value actually in corneal surface abnormalities. Post-operatively, there was a smooth, clear corneal surface. The best corrected visual acuity improved to from 0.05 to 0.2 as the eye was amblyopic, and there no recurrences of erosions for 2 years. And of course, I did the right eye also. This is a picture showing the differences between pre-operative on the left and post-operative on the right. The take-home message is that RCE is a common, painful, and often chronic condition. History is crucial. Pain on awakening is a red flag. Start with lubrication and step-up therapy in a structured manner. Most patients can be controlled with conservative or minor procedures. Procedural and surgical options are highly effective in refractory cases. Thank you.
Thank you, Dr. Allah. We'll have the Q&A at the end, and we invite Dr. Joanna Sade for her talk on aggressive forms of dry eye.
Hello. First of all, I would like to thank Dr. Siham for this opportunity, and of course the whole Deoss team and Dr. Shetty for this wonderful, wonderful meeting. So I'm going to present 2 challenging cases that I encountered in clinic, and they are touching up on subjects we already discussed. So the first case is a 47-year-old man who presented with marked discomfort and progressive visual loss in both eyes, the left affected more than the right. His past ocular history was significant for chronic conjunctivitis since childhood. It was very severe with a lot of redness, tearing, and progressive scarring. He saw multiple doctors, including immunologists and rheumatologists, to rule out atopy as a cause or a rheumatologic disease. He underwent many treatments with only transient improvement. Now, on exam, his vision in the right was 2100 and in the left was 2400. This was his right eye. There was significant injection. There was scarring on the cornea. He also had meibomian gland dysfunction, lid thickening, telangiectasia, and a lot of staining all over. In the left eye, the picture was even worse. He had the descematocele. He also had a lot of scarring over the cornea and thinning. He had symblephara inferiorly only, sparing the superior part with a lot of injection. And this is another, basically, picture of the inferior conjunctiva in the left eye. So superiorly, there was only injection. This is the OCT MS39 of his left eye with the descematocele. When we stained with fluorescein, which was mentioned many times, there was 0 tear film. It was completely dry, no tears whatsoever. So this was a case of a long-standing chronic conjunctivitis with the left more affected than the right since childhood, multiple lid surgeries, and by the time he came to me, he was on systemic immunosuppression, methotrexate, he took prednisone, and then he was switched to biologic with a little bit of improvement. Of course, also before coming to me, he had a biopsy taken and it was negative for ocular cicatricial pemphigoid. His whole rheumatologic workup was also negative, and an MRI also showed nothing remarkable. So as a plan, we were treating him for immune cicatrizing disease, most likely OCP, could be a result of severe atopy in childhood. He is still on immunosuppression. Topically, he's on intensive lubrication, on cyclosporin, on PRP eye drops. I even did an injection in the lacrimal gland. And he also has CME for which he's treated with steroid and NSAID. He underwent, right before I came, lysis of his adhesion and buccal mucous membrane graft in the left eye. And now I'm planning to do an amniotic membrane graft with limbal stem cell transplantation and PKP. And any suggestion is welcome. So we looked at the literature for OCP. It affects 1 in 10,000 to 50,000 individuals, women more than men, 2 times more. 40% of patients will have a negative biopsy, and only 10% will not have any oral symptoms. He doesn't have any oral symptoms. About the PRP lacrimal gland injection, it was discussed, and actually I learned about it last year in the Deoss meeting, so I will let you know if he improves. And that's where we're at now with the first case. The second case is a 52-year-old man patient who presented to clinic with a corneal perforation in the right eye following a phacosurgery done outside 6 weeks prior to presentation. So he was sent to us. His medical history was positive for presumed cerebral palsy, and he was on a wheelchair, coming with family members. Upon arrival, we took cultures that were negative, and we started him on moxifloxacin eye drops, awaiting a tectonic PKP. He used them every 2 hours. On exam, in the right eye, he was counting finger at half meter. In the left, 2150. He had lid changes, typical of severe MGD with thickening and telangiectasia. In the right eye, he had 2 large inferior perforations, which were blocked by iris, and he had a contact lens in place. In the left, he had an inferior 1.5 millimeter scar, but that wasn't, there was no defect overlying it. The anterior chamber was flat in the right and deep and quiet in the left, and he had a PCIOL in the right and a little bit of cataract in the left. So this was his very complicated course. When he came, he had the perforation. We did the first tectonic PKP. Directly after, he had a very early graft decompensation with a superimposed infection, needing resuturing. He had a corneal melt and a second tectonic PKP with a recurrent melt as well, a lot of inflammation, a lot of secretions, and so I had to do a Gunderson flap. This is the images of this right eye. It was a very quickly progressing situation. In the meantime, his left eye started having ulcers, many sterile ulcers, and in many different central locations. And this is his left eye OCT. Now, this is what the patient looked like. We asked about a rheumatologic workup. They denied the family, but we still insisted on sending him to rheumatology, which was discussed earlier, how important is the communication between us. So he went there, he underwent tests, and because he had the recurrent sterile appearing melts, the severe dryness and multiple joint problems, his results came back positive, ANA positive, rheumatoid factor elevated, anti-CCP positive, ESR-CRP elevated, and anti-Rho, anti-La negative. So this, the diagnosis was advanced seropositive rheumatoid arthritis with secondary Sjogren, and he was started on methotrexate, then adalimumab. He had marked improvement, but it actually took a while for him to respond. In the meantime, we were giving him aggressive lubrication with PRP drops. He was also using lubrication, and on last visit, his right eye is still stable, and the left is it's doing very well. He's not staining even anymore, and we're awaiting to do a cataract surgery. So this is secondary Sjogren, and secondary Sjogren in rheumatoid arthritis occurs in about 8.7% of patients, and the positive anti-Rho, anti-La, the anti-Rho, anti-La are only positive in 26.5% of patients. In a study that looked at rheumatoid arthritis patients with secondary Sjogren, 25% had extraglandular ocular involvement, and 13% of patients had vision-threatening ocular complications. So the take-home message is that even if we have a negative biopsy, for example, we are still dealing with a cicatrizing disease that requires immunosuppression. Systemic control is very important in cases we have to look beyond the eye. We have to communicate very well with other physicians, and multidisciplinary care is very important in these patients to save their vision. Thank you.